Well, ladies and gentlemen, this is a joyous occasion, and I would like to, you'll hear I'm speaking slowly and I'm hopefully clearly. And it's because the VIPs in the room are in the booths at the back, our interpreters. So if I could ask if you ask questions or the speakers, just speak at a relatively slow rate and clearly. Then it's much easier for those following on headsets to follow you. My name is Delon Human. I am a specialist family physician. I'm a physician. And I have been involved in harm reduction for several years. Harm reduction in drugs, alcohol, food, COVID, and also tobacco. And the focus of today's summit will be very much specialized in tobacco harm reduction. And that's part of our Pan-American Harm Reduction Alliance, which is an alliance of networks from all over the world. And I'll introduce some of the leaders from other parts of the world to you today. My co-moderator is Jessica Perkins.
Good morning, everybody. It's such a pleasure to welcome you all here today to this really fantastic event. We have world-class speakers, and I think you'll find the day really enjoyable and really interesting. So I have a background in science. I'm a scientist, and I worked in product innovation for 11 years in alternative products, in tobacco harm reduction, and now I work with Delon and the team in developing global platforms such as PARA. We have an Africa Harm Reduction Alliance as well, and we like to advocate for tobacco harm reduction and harm reduction science and the evidence base to promote the good science and the good quality work that's really being done in this space. So it's a pleasure to be with you all here today.
Thank you, Jessica. So we are the Beauty and Beast combination, and I apologize in advance. We'll be linking the various speeches and question sessions with each other. Let me just give you a quick overview of the day. We will have the agenda has been put on the PARA website, and you'll have it on your phones as well. But I just want to quickly run through some of the speakers. We'll soon be listening to Derek, and I'll give him a more formal introduction. Derek Yach, who used to be a cabinet minister in the World Health Organization. We have Anders Milton from Sweden, a specialist nephrologist and a health expert. We have Konstantinos Farsalinos, who is probably the best-known scientist in the tobacco harm reduction science space. We have Mihaela Răescu, who is a professor of dentistry in Romania. We have Clive Bates, who is very well known in tobacco harm reduction, runs the counterfactual website and is an absolute Trojan and advocate in this field. Heine Sturve, a professor in social sciences from Frankfurt University of Applied Sciences. We're very pleased to have you, Heino. We have Kgosi Letlape, who is the president of the Africa Harm Reduction Alliance. Professor Mariva Glover, who flew all the way from New Zealand. She'll be speaking later. Then we have Patricia Kovacevic from Romania and the United States, an expert in FDA and regulatory science. Christopher Russel, a Scot, who's also a PhD in social sciences, and he'll talk to us about the consumer perception studies in various countries. Cynthia Netzi Rodrigues from Brazil. We're very pleased to have her here, along with Francisco Ordonez from Colombia, Diego Verrastro, a general surgeon from Argentina, Professor Adriana Gioda, very pleased from Brazil to welcome her. Federico Fernandez will join us online with some very exciting new results of a consumer study that was done. Juan Facundo Temi from Argentina is a consumer vapor advocate. Very pleased Juan is here, as well as Eileen van Isseldijk. And with that lineup of speakers and the various panel sessions, we intend to have a day where we can have a conversation about what is happening in Brazil. So just to set the scene, Brazil is one of the largest countries in the world, the 5th largest country in the world, 217 million people, and has a relatively high smoking prevalence of adult smokers in this country. At this stage, combustibles are still freely allowed, but the smoke-free nicotine alternatives is being considered to be placed in a regulated space, but not at the moment. So it's a timely summit to look at what has happened in other countries in the world and what the scientific principles are of harm reduction in tobacco. We always think of tobacco, and especially smoked combustible cigarettes, as a fire. And if people want to go to a fire escape and have a smoke-free nicotine alternative that they can switch to, if they cannot or will not quit, that's really the science behind tobacco harm reduction. Harm reduction is an old public health principle. If you have a diet beverage, you're also practicing harm reduction. If you wear a helmet on your head when you ride a motorcycle, you are practicing harm reduction. Condoms to prevent HIV/AIDS is harm reduction. So that's really what this day is about, is to explain harm reduction in general, but then to specifically look at some of the aspects of tobacco harm reduction. So I would like to introduce our first speaker, the keynote speaker, Derek Yach. Derek is an epidemiologist and physician, and who's had a stellar career. He was a cabinet minister in the World Health Organization, and this photograph was taken when the Framework Convention on Tobacco Control was negotiated. And especially that person in the middle, I'd like Derek to ask him to explain to you who that is, because Brazil played a very important role in the Framework Convention's negotiation. So the objective of the Framework Convention was to protect present and future generations from tobacco consumption and to make sure that it is either reduced or eliminated. Derek in his remarks will address that. And there is one article in the introduction of the framework which I would like you to remember, and that is that tobacco control means a range of supply, demand, and harm reduction strategies that aim to improve the health of a population by eliminating or reducing their consumption of tobacco. We all know that in most countries, these harm reduction strategies are not well established, and that's why we have conferences like today. So without any further ado, Derek is online, and if I may just say, Derek, for all of his life, he has been fighting on behalf of others to help prevent disease and premature death, especially for the chronic diseases. He is fighting one of those diseases himself. So we are deeply honored that Derek, in his status now as a patient, is willing to join us online. He would have been here, but we'll listen to his remarks first, and then I'll get him online and we can ask him some questions. The video, please.
So currently, the tobacco harm reduction debate in South America is overshadowed by ideological pressures rather than sound science-based policy development. There is a conflation of reduced risk products with FMC and an overemphasis of the dangers of youth initiation and use, rather than a pragmatic policy approach aimed at preventing the maximum level of tobacco-related diseases and premature death. Derek, I'd like to ask you a question. So what was the role of Brazil in the Framework Convention?
I think many people already know that the first ambassador to chair the development of the Framework Convention, the working groups, was the ambassador Celso Amorim from Brazil. But it's useful to think, how did we actually get there? Because these things just don't materialize out of thin air. When the decision was made to have the Framework Convention move ahead, Dr. Brundtland challenged a few of us to engage with the diplomatic community in Geneva, the leading ambassadors, to find out who they regarded among their peers as the best negotiator, the best person who could actually steer a convention process, which was going to be unwieldy, involve 180 member states. It was going to take several years. So it took somebody with very special skills. And pretty soon, it got narrowed down to Ambassador Celso Amorim, who'd been the Brazilian Minister of Foreign Affairs. He played a central role for many years. And in fact, today, he's back as the special advisor to the president of Brazil. So once we narrowed that down, the next thing was to go and persuade him that this was something he'd want to add to his huge tasks. And I always recall the dinner when I was privileged to be there with Dr. Brundtland. He and his wife were there. And I was asked to explain the rationale for the treaty. Brazil, at the time, had a modest tobacco control program. It had a very strong cancer program. Vera Costa Silva was an epidemiologist sitting there at the time and doing good work. There was an awareness that the country was ready to actually move and that they were being hampered by some cross-border issues, particularly illicit trade coming out of Paraguay, a big threat to their progress, and some of the more technical aspects. The industry was putting a lot of pressure on them. So that was the context. And after I raised the importance of the convention, which he got very quickly, Brundtland immediately jumped in and said, and we believe you would make the best chair for this, provided the member states agree, because we had no power as WHO to appoint him, and we weren't doing that, but we needed to know if he was interested. And the first response he had was, love to do it, it's an intellectual challenge, he's always there for that, but he's a smoker. And his wife looked at him and said, and that is the reason why you're going to quit, which he did. And he went on to be the negotiator, the lead. And I can remember all of those early discussions. And remember the first discussions we had were around the question of definition. What does tobacco control encompass? And remember that Brazil had a history of doing good HIV/AIDS work, good harm reduction in HIV/AIDS. It had a history of doing good work in drug control, drug policy, harm reduction in drug policy. So it was kind of natural that they'd add in harm reduction must be part of the definition. There wasn't even much of a debate around it. It was obvious. The fact that we didn't have too many examples at the time wasn't the issue, because a treaty is for the future and science would evolve. But even at that early point, we were aware that there were two types of harm reduction that did exist. The most basic one was the message, smoke less. If you're smoking a pack and a half a day and your doctor is able to persuade you to go down to 5 a day, you're cutting your risk of lung cancer by multiples. If you go on to NRTs, which is the first purest forms of harm reduction, you continue to use nicotine without the bad stuff. So two forms were out there, so it was natural it should be there. Unfortunately, he then got called to other higher office, as these ambassadors are prone to be, and he handed over to the second ambassador, Seychelles Korea, who actually ended the process. Another brilliant negotiator who was very involved in the WTO negotiations at the time. And his maiden message was, nothing is agreed until everything is agreed, and held the process together, knowing that we could easily be going in different directions. We could have a more rigorous, higher, a treaty with more bite that may have included trade-related issues. It may have even included requirements on all countries committing to banning advertising. But if the language had been too severe, we wouldn't have had the large number of countries on we did in the end. And I think it was his judgment and his extraordinary personality to weigh people that meant in the end we had the Japanese and the Chinese and most other major countries in the world on the board, with a few exceptions. Indonesia, Russia, US in the end took a long time. Again, an example of bringing the force of character. Throughout this period, it's important to remember that for much of the period from 1998 to about 2002, this was also being watched carefully by the person who was the Minister of Health of Brazil at the time, José Serra. And José Serra was a very powerful politician. He'd been governor of the state of Sao Paulo, mayor of Sao Paulo, later ran for the presidency, deeply committed to health. And I think it was his constant support that helped Brazil have a strong delegation there and committed to actually make sure that the language they would support would always be on a higher level rather than the sort of middle of the road or the lower level that so many member states prone to industry pressure came out. And remember that during his tenure as the minister, Brazil also emerged to be pretty critical in the nutrition debates, the food debates, the non-communicable disease debates. So it wasn't just tobacco that he was supporting. He was supportive across the spectrum of chronic diseases. I mention all this because it's often the personalities that matter. And the force of those early personalities shaped a treaty which has harm reduction in the definition for reasons because it seemed so natural and obvious to them at the time. It was only years later where the potential to use the definition came into question, as we've seen in the last few years. But it remains there, so you don't need a constitutional change to actually endorse and support what the UK government, the New Zealand government, the US government is doing. It simply needs an unblocking of the political roadblocks.
So, Derek, you mentioned that the Brazilians have been very effective at implementing other harm reduction measures in other areas of diseases. But for Brazil and the wider South America region, which are the particular and unique challenges to this region in implementing the FCTC and in tobacco harm reduction in particular?
I think for the FCT in general, I actually think that illicit trade is a massive issue, given the complexity of the borders and the geographic reality of the countries, which always means that the most powerful intervention which we'd want to use, taxes, is always going to be limited, as opposed to across European borders where you're going to have stronger abilities, or the US. And we often forget that what gets decided in Geneva is not often easily implementable on the ground in all countries, because of the local circumstances and the realities. I think many of the others add bans and so on, all that's implemented, but it's not anywhere near as effective as the tax issues. On harm reduction, I think the biggest impediment is the enormous galvanized support that we've seen through the Bloomberg network and the Campaign for Tobacco-Free Kids. Many of them in America have naturally made countries in South America agree and support their philosophy. And it's been greased by large amounts of money, large amount of grants. When I look back, at the time, there were a lot more independent tobacco control researchers in Brazil who would have independent views. Today, there aren't that many. And in fact, tobacco control research has kind of gone out of favor as a cutting edge need in research. We don't have many clinicians involved in the issues around they also have a big tuberculosis problem. They have mental health issues. Why are we not dealing with their smoking problems? That just doesn't seem to be on the agenda. I suspect, again, that until we get a change in WHO's voice, and that requires a change also in Bloomberg's voice, it'll be very difficult to make the progress that we need. But in the meantime, many of these products have made their way to the market. Illicit trade can sometimes work in ways that benefit public health. Sneaking e-cigarettes onto the market, getting illicit nicotine pouches certainly is not desirable, but it's happening because consumers are demanding it, and it's happening in countries where they're officially banned. Most people know you'd be able to get e-cigarettes in parts of India fairly easily. Officially, they're banned by government. But you don't want to go that route, and you shouldn't want to go that route. You should want government to align policies what's best for public health.
Derek, you're aware that Anvisa, the FDA of Brazil, is currently considering the regulation of electronic nicotine delivery systems, or e-cigarettes, amongst other potential smoke-free products. What role could the process employed by the US FDA play in making this a meaningful process in Brazil?
Yeah, absolutely excellent question, Dylan. In areas like pharmaceuticals, or in vaccines, or medical devices, or even food safety, the usual process, and I served on the Global Advisory Committee on Food Safety to the FDA a couple of years ago. So I saw this right up front. The US FDA would have their considered opinion, they would take global views, and they would decide on X, Y, and Z, but they wouldn't usually end there. They would then alert the medical attaches and the medical officers in the embassies around the world as to why did the FDA make this decision, and encourage and support the embassy to reach out to the Ministry of Health to actually apply what the Brazilians have, what the FDA has, in their area if felt appropriate. Now, the same should happen here. The FDA has put many billions of dollars behind reviewing these very large authorization processes. One would hope that the FDA, either in the COP meeting or through their usual embassy outreach within Brasilia to the government, would run briefings for the Ministry of Health on the rationale, the logic, science underpinning the authorization of all of these products, to actually make it transparent. This is no longer a secret, and explain why it's of value. One reason why this is so important is because the more the FDA is able to get other countries on board, the lower the risk of illicit tobacco harm reduction products making their way into the US market actually happens. So I think it's for their own material interests as well as to help the Brazilians. And I'd add one last little technical issue. During the Framework Convention, there was also a discussion with the Congressional Appropriation Committee, and a small amendment by Lloyd Doggett of Texas was introduced that required embassies around the world to no longer support tobacco companies when they engaged with corporate companies around the world. Usually an American embassy is the home and support for American business. That's expected. That's the case with all governments. So this amendment banned that. Well, that was an era when the FDA hadn't said these things are appropriate for the protection of public health. And I think we need to have the amendment changed to permit embassies, and in fact encourage them to engage with the governments of countries around the issue of why is something appropriate for the protection of public health? What would be the value of doing what we are doing and putting vapes onto the market, heat-not-burn products on the market, snus and nicotine pouches? The last point I'd say is that, when you've got a thorny issue, which you try and get off the table in other areas, usually governments who are leading the fore host other governments to come to their closed meetings initially. I think back to some of the vaccine work that the Canadian government held initially behind closed doors, eventually gave us Gavi, the Global Vaccine Initiative, or a lot in the undernutrition space, where the British government did a lot, or a lot which Norway did in meetings around HIV/AIDS and so on. Well, there are two governments who've got exemplary approaches and thoughts out there in the harm reduction space, the UK and the USA. I would hope that either or both of them would be hosting ministerial level or interministerial meetings between their governments and the governments of Brazil, other countries, to actually share what they're doing and see how they can make progress. That's the normal way we've seen it happen.
Thank you, Derek. Your view, please, on the role of health professionals in the acceleration of tobacco harm reduction. It seems that this is an inordinately important subgroup or stakeholder in the process. How can health professionals be encouraged to get involved in Brazil in the acceleration of harm reduction?
Well, I wish I could say that I have a deep enough insight into the structure of Brazilian Health Professionals Association, but I know that in general, the underlying argument you're making is that basically, unless the physicians, and I say physicians, not the nurses, not the other professionals, physicians, who tend, whether we like it or not, to be in the leadership position in major policy decisions, unless they are willing to accept that nicotine does not cause cancer, that harm reduction products will save the lives of their patients who they're seeing every day, those with chronic lung diseases, cardiovascular, early cancers, tuberculosis, many with mental health. Unless they see that, I fear that we'll continue to have the slow progress that we're making. During the era that we were at WHO, I think it was a almost rare and privileged time. We had you being the president of the World Medical Association, we had the head of the Dental Association, we had the head of the Nursing Association, all deeply engaged with WHO on issues that affected clinical decision-making. That was an era that seems to have gone, and it's been displaced in terms of, instead of focusing on the clinical interface with the people you're trying to deal with, then the vaguer issues of policy, regulations, where it's unclear who the real beneficiaries are. And often it may actually ignore the beneficiaries in terms of people who are suffering and clinically ill. That's why I remain convinced that we need to make greater efforts. And in Brazil, I'm sure it'll be a uniquely Brazilian way to reach out to doctors who are seeing patients dying of smoking-related conditions and get them on board earlier to realize that need not be the case if you're actually going to be providing harm reduction products.
Derek, you've had a varied career and you've worked both in the public and private sector. You've worked for WHO, you've worked for the Rockefeller Foundation, Yale University, the Medical Research Council in South Africa, but you've also had periods where you worked in the food and beverage industry for a company like PepsiCo. And at the time, you realized the importance of responsible marketing to children. Now, that's obviously a flashpoint within tobacco control as well. So how can the lessons that you learned and employed in the food and beverage industry be applied to
PepsiCo? Probably 3 or 4 months when the CEO, Indra Nooyi, called me in and said, Derek, I think it's time that we're going to actually start doing something differently about marketing to kids. And I know that you want to see how we can change the age criteria and raise it to, I think it was going to be 16 at that time. And could you go and speak to our head of international marketing and get his support to do that? And naively, I went off to him. I won't give his name. And I explained what the opportunity and the challenge was. And his answer was, you're asking us to commit suicide in the market. You're a traitor to the organization. There is no ways I'm going to do that. You know what will happen if we do that? Coke will take our market share. And that was the clue to what we needed to do. There are some things that companies cannot do alone and have to do as a consortium. Marketing to kids is a great example. Lowering sodium is a great example. So what did we do? We went out and worked and created, as you know, the International Food and Beverage Alliance, 10, 12 leading multinationals, to get them to agree as a unity that we will all have the same norms and standards with regard to marketing and use that in our discussions with WHO. That would mean you couldn't have some competitive abuse happening out in the market, and you'd be forcing the smaller companies to come along with what the bigger coalitions were willing to do. The same applies here in this area of tobacco control. And I know that the Master Settlement Agreement imposed some restrictions on how companies can and can't interact. And I don't think we've reviewed those closely enough at the global level to use it as an excuse for the larger, smaller, and medium companies who are willing to actually make these kind of pledges about ending marketing to kids and ending access to kids in ways in which they drive the process initially. Of course, government must regulate and provide the regulations. But if the companies are looking at each other and knowing that if one cheats, they're going to be knocked out of the park, they won't cheat. I think what we're seeing in the UK with the UK Vaping Association starting to do exactly this, bringing together the vaping organizations, getting on the streets with government, pulling stuff off the shelves that shouldn't be on the shelves, alerting the public directly to the dangers and the needs to address marketing to kids. Otherwise, they lose the entire vaping market. That is the way to go. And there are many examples of how a combination of industry-led self-regulations complemented and cemented by government regulations can actually work. And I think in our field, we've just seen far too little of this.
Derek? We'd like to welcome you to Sao Paulo, and especially from all of our guests and participants here, wish you only the very best in your treatment and convalescence. Thank you so much for joining us. Can you hear me?
Yes, I can, and great to join you, and hopefully it won't be too long while now. Return to Ilhabela, one of the great swimming spots I've been privileged to experience.
You might not know, but Derek is a wild swimmer, so he's swum in most oceans of the world. That's why he looks the way he does. But Derek, if I may, we have on the screen a very important question, and that is the central dictum of public health is to prevent and control tobacco-related disease and premature death. If we can just show the graph again, you wrote an article to basically state how many deaths could be avoided. Could you give us more background on your methodology and what you calculated, please?
Thanks, Dylan. So I was very impressed by the power of graphics to inspire people to take action, particularly looking far out, and for people to understand that actions taken today magnify over time and lead to big outcomes. That's what we did early in the HIV/AIDS epidemic to justify the use of antiretrovirals. That's what we saw almost every night on television with different interventions around COVID. So the same principle applies, where the two questions are, what is the trend in mortality over the next many decades if we follow the status quo that WHO believes is likely? That doesn't mean nothing. It means continuing to apply increased taxes, bans and advertising and so on, but more of the same group of activities. And then we say, well, what happens if we add in tobacco harm reduction, as well as better cessation, and a few other things? I won't go into details. And remember, we're talking about several decades. Several decades behind us was when we saw the innovations leading to the current harm reduction products. It's also when we saw dramatic changes in improvements in pharmaceutical treatment of many of the diseases that tobacco causes. So it's very likely that that cycle of innovation is going to accelerate over the next few decades, and we should build into the model what is likely to happen, let's say at a modest level. And so those are the factors I took into account. I basically made a bunch of assumptions about what percentage of current users of combustibles and smokeless product users are likely to switch to the currently available products, and what would be the long-term benefit in terms of mortality using very, very modest conservative assumptions about benefit. And I won't go into them. And the figures I came up with based on a very simple model already show you that at the end of the period, by the 2060, you have 3 million deaths a year less. Now, that's a big number, but multiply it over the course of the difference between the blue and green curve, and you're talking about hundreds of millions of lives being saved over the course of those decades. I feel that we should be refining these, adapting them in a number of countries, so the policymakers themselves can ask the question, what's the consequence of us not acting? What is the benefit if we do act? So that was the rationale.
Thank you, Derek. And then I want to show the two brilliant Brazilian ambassadors. If we could just show the picture of Celso Amorim and Luis Felipe de Seixas Correa. And perhaps just another word on their intervention at a crucial time of the Framework Convention.
Yeah, thanks, Dylan. And as I said, I think first it was a very deep privilege to work with two people who anybody in Brazil knows are giants in their field, not just in negotiation, but Ambassador Celso Amorim being both foreign minister, defense minister, and now support to the presidency. The intellectual strength of Brazilian negotiations was really regarded as the best in class in the world. And remember, that was why they were seen as playing such a big role at WTO. What was driving some of it in health was the HIV/AIDS epidemic. And it was their leadership that got us to the WTO and got us to some of the things we'll mention later. But the key point to think about is that when you have ambassadors at this level leading a negotiation, they will tell you all the time, text matters. Every word matters. We learned that every comma matters in a text. So when the definition under Article 1D of tobacco control itself explicitly includes harm reduction, It means they meant it to be like that and meant in time for it to be acted upon. And the tragedy is that we haven't picked up the mantle to actually do that. I think it'd be testimony to their great vision if Brazil were to actually now act upon the harm reduction language that they played such a strong role in getting into the definition.
Then a trick question. What has TRIPS and the 2001 Doha Declaration got to do with tobacco harm reduction?
Yeah, I'd love people in the audience to answer, but I don't have an ability to check with them. But I think the key thing to remember is that the 2001 Doha Declaration really transformed the way we deal with drug policy. And for the first time, it allowed generic exports to low middle income countries where affordability was an issue. Basically making the point that patents, intellectual property were the hot topics of the same period that the Framework Convention was being negotiated. So the question is, why do those words not appear in the Framework Convention? How is it that in one realm, Ambassador Seychelles Correa, the permanent representative to the WTO on the one hand, and the chair of the Framework Convention and his staff never asked the question, why are we not applying what we're learning about the power of patents and intellectual property to share innovation for all in the Framework Convention? And there really are probably two answers. First, none of the delegates, including the Secretariat, had the imagination to believe that we would see such a spur of innovation that would actually require thinking about patents and intellectual property. Most thought this is an old legacy product. There isn't any science behind it. It's not going to get better. We've just got to make the industry go away. And it was that failure of imagination and a failure of understanding what was already happening inside some of those companies that led us to exclude it. The second was a slightly more mundane but political issue. There's always the fear that the moment you put intellectual property and patents into a treaty, the complexity of negotiation goes up dramatically, as we've seen in other treaties. And so let's just keep it out. And that was a decision that was made.
Thank you, Derek. And then just the one last question, please, and that's your reference to the brilliant Brazilian foreign minister at the time. But at the time, they were working on a specific article in the Framework Convention called Article 5.3. And you were very much part of the WHO Secretariat at the time. What was their thinking as they developed Article 5.3, and have there been any unintended consequences?
Yeah, that's a really fundamental question, Delon. Let's first remember what 5.3 says, because there's a lot of mystique around it. So it says, in setting and implementing the public health policies for tobacco control, parties shall act to protect policies from commercial and other vested interests in accordance with national law. Full stop. Nothing else. No other words follow. So what does that mean? It basically means make sure you deal with conflicts of interest, which we agree. Be transparent in any engagement with industry. What does it not say? It doesn't say ban, prohibit, don't talk to industry. It doesn't say demonize. It doesn't say denormalize. Those words came in guidelines that the Secretariat developed. So the question is, people who framed the Framework Convention were thinking very deeply about making sure that the UN inquiry into the tobacco industry, which did show substantial tobacco industry interference, was thought about and taken into serious account when you're engaging with the tobacco companies. It was a recognition that in all discussions about policy, all stakeholders with a material interest, whether you like them or don't like them, need to be consulted if you're going to have effective policy. That includes talking to tobacco companies when you're going to raise taxes or you're going to change types of advertising and so on. There was no intent to ban, exclude, prohibit them. And there was certainly no intention to ban, prohibit, and exclude anybody with any potential link, even going back 3 or 4 generations, from participating in WHO discussions. The unintended consequence, well, was that for whatever reason, the Secretariat was allowed to go ahead and issue guidelines when it's very clear that the ability to issue guidelines for the convention is carried in Article 7. And anybody reading Article 7 will see that it applies only to Articles 8 to 13. I'm being very technical, but 8 to 13 are the ones dealing with things like advertising, cessation, and so on. They do not refer to 5.3. And that was a deliberate decision, as every decision in the text of a treaty is. It's not just by chance that it's excluded or a mistake. It was explicitly excluded because there was a sense that there was no point in going on to guidelines in the way there would be in other areas. So the guidelines that have been issued, which do include words like limit interaction, denormalize, and start pushing us towards the prohibitionist policies, were certainly not intended and are certainly probably under checks of international law against the spirit of the convention, if not the text itself, something that deserves to be checked. There was another consequence of it, and that was that it became mythology that the text of 5.3, first of all, said don't talk, don't interact with industry. And that applies to industry itself, which it cannot, because industry is not a party to the treaty. That it applied to academic groups, or, for example, the foundation that I started couldn't because they're not parties to the treaty, or to a number of non-profits, academics, and many academics around the world have suffered abuse and harassment under the guise of people saying, well, they're violating 5.3, when they can't be violating something that they're not a party to. So I think that all of this, still to this day, all these years later, needs to be looked at in the light of the text. And no better place and no better country to take a careful look at this than Brazil, who understand and were grounded in the development of the very text that gave us 5.3, which I feel is a very well worded voice of text. The last point I'd say is that the very ambassadors who were involved went on to many other multilateral negotiations. And over the course of the last 20 years, we have seen the notion of international governance dramatically move towards openness, stakeholder engagement across the board. Look at what we had with COP26, look what we're going to get with COP27 and COP28. Engagement by the oil and gas, the transport, the energy sector in many of the discussions and deliberations that are going to happen over the next few years to try and save the climate. Without that, you won't have an access to their innovation, their research, to find the solutions from many of the problems that they may have caused, and they probably did in some cases, but the solutions we now need to have at our use. The same applies in the area of tobacco control.
Derek, hearty welcome and thank you from all of us here in Sao Paulo. We enjoyed your remarks, and specifically to provide the Brazilian context of the Framework Convention. I don't think we could have ended your remarks on a better note than your call for engagement. Engagement between all stakeholders. Engagement does not mean agreement. And I think you've made a powerful call to all of us, and in Brazil, where they are busy negotiating and debating this issue, that tobacco harm reduction can be part of the public health solution. Thank you very much for joining us, even in your condition as a current patient, a future healthy wild swimmer again. Thank you for joining us. We now have the pleasure to welcome Clive Bates to address us. Now, Clive is a very well-known tobacco harm reduction advocate, but he's led a varied life and a stellar career as well, both in the public and the private sector. He's most well known in tobacco control as a former Director of Action on Smoking and Health in the UK, and it is our pleasure to welcome Clive. I just want to make sure that we see Clive. Fine. Clive, I just want to do a sound check first.
Hello, Delon.
Hello, Clive.
I'm very pleased to be here.
Thank you. Well, the floor is yours, Clive.
Okay. Well, look, everybody, thank you very much for hearing me out. I've been asked to give a short introduction to the concepts around tobacco harm reduction, which I believe is probably the most significant public health strategy of the 21st century. So I'm just going to share my screen, hopefully. Just bear with me a minute. Go on, hang on. I beg your pardon, excuse me. Here we go. There we are. Right. Good, thanks. As I was saying, I'm just going to give an introduction to some of the more basic, not the basic, but the key insights into tobacco harm reduction. I'll try and go reasonably slowly and clearly for the interpreters, for whom I would like to thank in advance. Okay, the first thing is, I think we have to discuss the actual problem here. And the actual problem, you'll all be aware, is the enormous burden of disease caused by smoking. Kills around 8 million people annually, more than obesity, accidents, road accidents, drug use, misuse, and HIV combined. And the death toll is roughly similar to the death toll from COVID-19 in 2020 and 2021, but happening every year. And in much the same kind of demographic, the same sort of age group as well. So it's a huge public health problem, and it's going to go on for the rest of the century unless we do something about it. We have evolved a policy response to smoking, in which we warn people, we tax the cigarettes, we tackle it, and we basically try to deal with the harm associated with smoking. But there's been very interesting innovation here. And this is a famous quote from Professor Mike Russell, a British scientist who passed away in 2009. But he points out that people smoke for the nicotine but die from the tar. And in many ways, the whole premise of tobacco harm reduction is based on this idea. The idea that people use cigarettes for nicotine, but they die from the toxic cocktail of smoke particles and toxic gases that come from the burning tip of a cigarette, but not the nicotine. So the interesting question is, what happens when we have ways of taking nicotine that don't involve smoke, the smoke-free products, so-called? And there's roughly 4 categories of these: vaping products, heated tobacco products, oral nicotine products, and smokeless tobacco has been around for some time. All of these products can deliver a satisfactory dose of nicotine to the user, but without smoke, and therefore without most of the 7,000 chemicals and carcinogens that cause the damage associated with smoking. We know that because, not because we've been able to look out 50 years and see what happened. We don't have a time machine, so we don't know what the final results will be. But we don't know nothing either. And we have a great deal of information from so-called biomarker studies. And this is where you look at somebody who's a smoker or a vapor, and you look at the level of toxicants in their blood, their saliva, or their urine. And there's been quite a lot of studies of this nature, but they all have one thing in common. They show that the levels of toxicants in vapors are much lower than in smokers. And that gives us confidence that there's going to be a significant health benefit from switching from the high-risk smoking products to the low-risk vaping products. Just last week, a large review of biomarker studies came out and came up with some interesting findings. Toxicants measured in biological samples collected from ENDS users, that's vaping users, did not differ significantly from non-users for most of the metabolites, for most of the biomarkers. Okay, so we're not just talking about a bit lower than for smoking, we're talking almost the same as non-users. There's been a number of efforts to condense these findings into insights that can be used by health practitioners, regulators, and the public This is one of the earliest ones. This was the Royal College of Physicians of London. First published the major report on smoking and health in the 1961. And they estimated that the health risks associated with e-cigarettes are unlikely to exceed 5% of those associated with smoked tobacco products. More recently, a huge American study by the US National Academies of Science, Engineering and Medicine, it concluded that while e-cigarettes are not without health risks, they are likely to be far less harmful than combustible tobacco cigarettes. And then right up to the present day, 2022, a 1,400-page huge assessment by the Office of Health Inequalities and Health Information and Disparities found that vaping poses only a small fraction of the risks of smoking. Okay, now you don't have to believe that, but those are fairly authoritative assessments done by independent, credible scientists, no industry involvement, but people with a long history of research and analysis in this field. So that's the first major conclusion. Smoke-free nicotine products are much less harmful than cigarettes. That's the first thing we need to understand for the harm reduction equation to work. The second is that we need to be confident that these products will displace smoking, that they're not just additional or bringing new people in, but they're displacing smoking. In other words, when people are faced with a choice, they'll choose the low-risk product rather than the high-risk. And we've seen some assessments of this kind of thing, and the prestigious US Annual Review of Public Health. Alternative nicotine delivery systems have the potential to disrupt the 120-year dominance of the cigarette. We've seen high-quality evidence from randomized controlled trials summarized by the Cochrane Review. There is high certainty evidence that e-cigarettes with nicotine increase quit rates compared to nicotine replacement therapy. We've seen more in-depth evidence reviews that look at evidence from randomized controlled trials, evidence from observational studies, and evidence from population trends, and indeed evidence from economic data and user testimony, and they all converge on the idea that e-cigarettes and these smoke-free products are driving out smoking. It's a form of creative destruction. It's a diffusion of low-risk innovation at the expense of the high-risk incumbent products. It's exactly what we want to happen, and we're seeing it in the research and in the marketplace. This is an example here. This is an estimate of the effect of the rise of vaping at the end of the last decade on cigarette smoking in the United States. And you can see as vaping rises, there's been an anomalous decline, a more rapid decline in smoking than was expected over the period. The National Health Service in England, which is the main health provider in the United Kingdom, is very clear about this. It has a straightforward message. It's understood the evidence, and it says that vapes or e-cigarettes are far less harmful than cigarettes and can help you quit smoking for good. It's the kind of direct risk communication that the ordinary public or health practitioners or even regulators need in order to make the right decisions about these products. And that statement is absolutely true. They're not risk-free, but they're far less harmful than cigarettes. They're not a magic bullet, but they can help you quit smoking for good. Okay, so that's a second major conclusion. Vaping is displacing smoking, and the cigarette is facing creative destruction. In other words, destruction by innovation, by innovators that have produced products that people want to buy, and they're buying them instead of cigarettes, and that is basically driving down the cigarette trade. Next thing. One thing that people ask is, well, why don't we just get rid of nicotine altogether? Surely it's the best thing is that everyone should just stop smoking and stop using nicotine. Well, that would be all right, except there seems to be quite a strong demand for nicotine, and stronger than it is for smoking. And there's some of the reasons why here. Nicotine produces rewarding psychoactive effects. This is the views of Neil Benevitz, one of the world experts on nicotine. In humans, nicotine enhances stimulation and pleasure, reduces stress and anxiety, and is involved in mood control in daily life. Okay? Now, those are important benefits if you're a user and you're feeling stressed and anxious. Here's something on cognitive improvement. Nicotine improves performance on attentionally and cognitively demanding vigilance tasks. It helps improve attention and response mechanisms and enhance working memory. Okay, so these are functional and hedonistic benefits that people get from the drug, and that's the reason why they use them. It's not a mystery. People use these products because they like them, not simply because they're addicted or the tobacco industry markets them. And one way of thinking about this is just another class of recreational drug, like tea and coffee, like modest alcohol consumption, and increasingly like cannabinoids, which are becoming, there's more and more of a movement to legalize and regulate these products to make them available in a safe and acceptable form. And the reason for that is because there is a demand for them. Michael Russell, again, who's one of the great wise men of this field, said this: there is no compelling objection to the recreational and even addictive use of nicotine, provided it is not shown to be physically, psychologically, or socially harmful to the users or to others. And that's where we're getting to. We're getting to a situation where nicotine can be taken without the harms of smoking. And a whole lot of considerations change when we get to that point. So this is my next major conclusion. Nicotine is a recreational stimulant that is reasonably safe, not completely safe, in its smoke-free form. And we should think about it in the same way we think about caffeine, alcohol, and increasingly cannabinoids. How should we think about young people? Well, first of all, let's be honest. The idea that young people don't use substances, they don't drink alcohol, they don't take marijuana, they don't use caffeine or whatever, it's just ridiculous. Young people do what adults do, and there will always be a share of young people who take some sort of recreational drugs. So this is the United States, and it shows that past 30-day use of marijuana, used at least once in the past 30 days, has been around or just above 20% for the last 25 years. Okay, even though the product has been it's been illegal at federal level and mostly illegal at state level throughout all of that period. Daily use, the bottom line, is around 5%. So this has been going on. This is making things illegal or prohibiting them doesn't make them disappear. It just means they're supplied in a different way. Okay, and that's what's been happening with marijuana. And because the different way is essentially through criminal networks, people are now thinking it may be better to make these drugs available in a lawful way to cut the criminal networks out of the picture. But there was a very sharp rise in vaping in 2019 in the United States. Okay, but I want to unpack this because the United States has kind of caused a bit of a worldwide panic on this. Vaping shot up to 27.5% in the past 30 days. And that caused what I would call a moral panic in the United States. But the interesting thing is there was much lower levels of frequent vaping. So most of that orange bar there was people vaping once or twice a month, not really a concern for public health. And then it fell away again rapidly in 2020 and 21. Okay. So it was transient, it was temporary, and it was frivolous, and it wasn't particularly serious. The frequent vaping, however, is interesting. It's more committed, but it's among people who would otherwise have been smokers. Almost everyone who becomes a frequent vapor, we would have expected to become a smoker. So for them, it's beneficial. Although it's teenage vaping and everybody's worried about it, it's beneficial because it has displaced smoking among these younger groups. So youth vaping comes in two forms: frivolous and experimentation, and then as the displacement of smoking, which is beneficial. So the first of those is inconsequential, and the second is beneficial. Final phase here, or almost, a technology transition. This is how we should think about this. There is a demand for nicotine, and we are in the process of a transition of the technology for delivering it. A little bit like we're in the process of the transition for that's going on with automobiles and the move to electric vehicles, and the fossil fuel industry and the move to renewables. We are moving towards more benign ways of delivering the service that we want. In the UK, we have embraced that change, and the government, and this is Public Health England, runs campaigns to encourage people to stop smoking with an e-cigarette and switch away, stop smoking and switch to an e-cigarette. Okay, that's the right thing to do. They're doing that because they know there's going to be a big health benefit. Now, I'm going to leave that we reflect on why we're doing things differently in England and how to extract the benefit innovation. We can discuss the right way to regulate or the right way to control these products, but what we should be doing is thinking about the opportunity, which is enormous, and not getting completely overwhelmed by the risks, which are pretty small. Okay, and with that, I'll thank you.
Clive, just to explain, we can't film the audience, so we will relay the questions online to you. There's one online question, and that is the role of flavours in smoking cessation. What is your view on the role of flavours, and whether there are any unintended consequences of actually banning flavours?
Look, all vaping products and all smoke-free. Let's take a step back. Cigarettes are flavoured products. They're flavoured with all the burning chemicals in cigarette smoke. That's what gives them their sort of aromatic sense and so on. It's just that those flavors are incredibly bad for you. They're volatile organics. They're hydrocarbons. They're very, very toxic. But they are flavored with smoke. Almost every smoke-free product and all vaping products are flavored with something, whether it's tobacco flavor, menthol flavor, fruit flavor, alcohol flavor, whatever. And that's because an unflavored vape product is pretty awful. It's just not very nice. So the way vaping works to displace smoking, it's not like a nicotine replacement therapy, in which you're trying to deal with the withdrawal symptoms by giving somebody a low level of nicotine as they go to being from smoking to abstinence. The difference with vaping is that what you're trying to do is get people who want to smoke and get them to do something different. So the product has to appeal to them, or they won't use it. So it's a different consumer proposition. So vaping has to appeal to smokers, or people won't switch. That should be obvious. It has to be a consumer, it has to be done by consumer preferences. And if you think about how pizzas would work if they were all one flavor, if they were all margarita flavor, you wouldn't get pizza restaurants that were full. People would just have the occasional one now and then, but they wouldn't displace the other food choices they were making. So flavors, including the diversity of flavors, the ability to try one flavor this week, another flavor that week, one flavor in the morning, one flavor in the evening, to experiment with new flavors, is integral to the appeal. And if you take that away, then you've basically rendered these products useless. You're turning them into nicotine replacement therapy products that don't really work very well. And that would be a great shame, because in a sense, you would be using regulation to protect the cigarette trade from a competitive alternative. And in doing that, you're essentially bolstering the cigarette trade and so on. As I said earlier in the presentation, people want to use nicotine. So if you just take the flavors away, it doesn't mean they stop wanting to use nicotine. They'll use it in some other form. They'll either make their own flavors, they'll switch to smoking products, they'll buy on the black market or so on. Making something go away doesn't make it, banning something doesn't make it disappear. It just changes the way users of that product go about their business and what they do instead. And that's not always in a good way. You can't assume that when you ban flavors, people will say, that's it, I'm not vaping anymore, I'm going to do more choir practice and homework. That just is not how things work.
It's an excellent answer, and also highly relevant, as we've heard that in Canada and in other countries like Netherlands and Belgium, flavors are facing a ban, or an imminent ban. Last question.
Delon, I think they'll regret that. They will regret that, because what they've effectively done is made life easy for the cigarette trade. They've taken away a threat to the cigarette business, and it's a ridiculous thing to do. And what we'll have is all sorts of people making their own flavors, selling them to their friends, setting up little mini networks, and then we'll have the criminal networks will come in selling flavored disposable products. Banning stuff. I mean, we must know by now that banning stuff actually doesn't work in the way that the prohibitionists wish it did and think it should. It just doesn't. You end up with the most ridiculous, perverse consequences. Why we can't learn that lesson, I do not know.
Thank you, Clive. One last online question from Brazil. So Article 1D of the Framework Convention mentions harm reduction strategies. And in Brazil, Anvisa, the local FDA, are busy considering potentially regulating some smoke-free nicotine alternatives like vaping products. If you were an advisor to the government and you had to interpret at a high level harm reduction strategies that could work in Brazil, what would that be?
Wow, it's a great question. I have sent my unsolicited advice to Anvisa in its various consultations, and I hope. The interesting question here is that a regulator has enormous potential to do good in this field, to change everything when it comes to the burden of smoking-related disease. So what I would advise is a regulator like Anvisa, and operating within the constraints it has in law, of course, but it switches and adopts what we call risk-proportionate regulation. So this is the idea that you are as tough as you can be on the most harmful products, and that you regulate the least harmful products. These are the smoke-free products. Not in a laissez-faire way. You don't just say, well, you can put anything you like on the market, but you regulate with consumer protection in mind. So you are trying, let's say, so the simple example is that you ban all adverts for cigarette smoking, but you allow responsible communications about vaping. And the reason is cigarettes are established as the dominant product. New product entrants need to get a foothold and build confidence, okay? So these adverts for these other products, for vaping products, function like anti-smoking adverts, but they're free to the state, but they're beneficial to public health. High taxes on cigarettes, but low or no taxes on vaping and other smoke-free products. Strong pictorial warnings on smoked tobacco products, but messages about switching and relative risk that inform people that the products are not risk-free, but they're much less harmful than smoking. Maybe pack inserts in cigarettes that encourage people to switch. That's an idea that's going to be tried out in England. I'm very excited about that. So you get a message in your cigarette pack from maybe a regulator or a health provider that says, have you thought of switching to vaping? That would be a very cool thing to do, in my opinion. You set standards, and those standards would cover electrical, mechanical, thermal, and chemical safety. So you don't want high levels of, I don't know, mercury or something in vaping liquids. So you set standards for that. But once you've set standards, everybody knows the rules and can comply with them. The supply chains will comply, and everyone will be happy, and the consumer will be protected. So those are the sort of things. I think age restrictions. I don't think we want people under 18 buying vaping products, but maybe for cigarettes you go to 21, and do what they've done in the United States, for example. So everywhere you have a regulatory intervention, you're tougher on cigarettes, and your focus on the smoke-free products is on consumer protection and making the experience better for them rather than discouraging them from using it. Does that make sense?
Absolutely. Clive, thank you very much. We have one more question from an audience member, Dr. Diego Verrastro, who's a general surgeon. We can't show you his face, but he looks like he's a silver fox, looks like a former film star. Diego.
Okay.
¿Qué tal? Buenos días. Quería preguntarle a Clive qué opinión le merece el regular estos productos a través de la nicotina desde el punto de vista únicamente médico. El clásico ejemplo de Australia.
Clive, we'll give you the translation.
I think I got the gist of
Oh,
it.
you did? Okay.
No, please try if you can. Just I don't want to.
No, he couldn't. Diego, can you just repeat the question again, please? And then we'll...
¿Qué opinión tiene Clive sobre regular estos productos de daño reducido desde el lado de la nicotina como fármaco, solo desde el punto de vista médico? No sé si me explico.
So the regulation of the nicotine products as medicines in South America, what is your view on that?
Right. So it's a really good point. I think the first thing is there's nothing wrong with having therapeutic indications for nicotine products, like nicotine replacement therapy, inhalers, and so on. And you could sell these as medicines if you want. And that is more or less what we have in the European Union, the UK. It's an option. It's not the only requirement. Now, the place that's made this the only way to bring these products to market, famously, is Australia, which I think is a terrible way of doing it. Because I think the way to think of it is that there's two different models in the way people are, using nicotine to stop smoking. One is the medical model, in which you use a nicotine replacement therapy to cope with cravings and withdrawals during a period of smoking cessation, where you go from smoking and using nicotine to not smoking and not using nicotine. And that's the appropriate medical pathway. The other one that I think is going to be far more promising is the consumer pathway. And the consumer pathway is where the nicotine products essentially are rivals to cigarettes for nicotine use, okay? And they have to be appealing. They have to deliver nicotine in a way that's comparable to cigarettes. They're not therapeutic, actually. They happen to have a public health value, but people aren't using them as a medical treatment. They're using them as an alternative to cigarette smoking that happens to be much less dangerous. And they may be using it because it's much less dangerous. But the problem is pharmaceutical regulators don't have the conceptual toolkit to deal with this. For them, if something is appealing or pleasurable, that goes under the heading of abuse liability, and it's regarded as a negative. And one of the reasons why nicotine replacement therapy products are not particularly effective is because concerns about abuse liability mean that they can't deliver nicotine at the speed and intensity that you can with cigarettes or vapes. Okay, so they are a less satisfactory alternative, and therefore they're less successful at displacing smoking. So I am all for vaping products getting medical clearance if they can. I think it will give confidence to some doctors to use them. It will make it easier in the healthcare system. For some people, it will give them a kind of reassurance, but definitely not allow that to be the only way they can be accessed. You have to have the consumer rival to cigarettes if you want to get that creative destruction effect and drive smoking out of the market. You actually have to have a benign rival, and that's what e-cigarettes and the other smoke-free products are.
Clive, thank you most sincerely for sharing your wisdom and your talent. Keep up the good fight, and we will be following you on the E6 Summit next week as well in Washington, D.C. Thank you for joining us.
Okay. Have a great conference.
Thank you. It's now my pleasure to welcome to the podium Dr. Mariva Glover. Mariva is the director of the Independent Centre for Research and Excellence, Indigenous Sovereignty and Smoking in Auckland, New Zealand. She flew for 30 hours to be with us. So a big hand just for that. She's also the editor of the tobacco section of the International Harm Reduction Journal. And we look forward to your insights, please, Mariva.
Thank you, Delon. Okay, can you hear me? Now you can hear me. All right. Hola. And in Māori New Zealand, Māori Indigenous people, kia ora. And thank you, Delon and Jessica, for inviting me to be part of this very important summit. When I heard that Derek and Clive were on before me, and I was given 15 minutes, I was like, I'll have to go really fast. But you can't do that when you have people translating. You have to go slow and clear. So I have scripted what I'm going to say and given it to the translators so that they can keep up with me. I'll still try to go slowly. So I apologize for reading my talk. It's for the benefit of our wider multilingual audience. So, and Jessica, are you moving my slides for me? I think, you want me to do it? Okay, microphone. Oh, it's getting complicated now. These are my disclosures. So after working on helping people to stop smoking for 30 years, I'm a behavioural scientist. I studied psychology and my PhD was on smoking cessation. I've worked as a policy analyst in public health and then became an academic, was an academic for a long time in universities, a professor, and then joined Derek sort of as a grantee of the Foundation for a Smoke-Free World. So I'm continuing my research. I have to say that I have learned a lot more about tobacco than I learned in the 30 years that I was part of the Global Framework Convention Tobacco Control Program, a very closed, tightly controlled thought bubble. And I'm so excited as an Indigenous woman to be here in South America, the origin of the tobacco plant. And I've been studying and reading the anthropological literature on Indigenous people's uses of plants for the psychoactive properties, but particularly tobacco use. So here we are in South America, and I've learned that Indigenous people, oh, thank you. Can you, oh, you haven't got it. I have to say when. So Indigenous people have been using tobacco for over 12,000 years. There is archaeological evidence of this. And I'm focusing now just on South American tribes. Can you... Yep, I think we're in the right place. Sorry. And the modern day commercially used cigarettes, those plants are directly descended from plants in South America. Prior to the 16th century, so tobacco went from here to North America and then on to the South Pacific. And I have another study I've done where I've looked at all the indigenous people in the world, where they are, and tobacco use. I have this very kind of picture of how tobacco was traded by indigenous people with other peoples around the world, way before there was a tobacco company, and it moved right round. And anyway, it's fascinating. Thank you. So there were, sorry, is it flicking on, or it shouldn't be flicking on by itself? All right. So the indigenous tribes of South America, they use tobacco in many different ways and for many different purposes. So I want to disagree a little bit with Dr. Benowitz, but anyway. Some of the purposes will sound familiar to people who use tobacco or nicotine today. And this is from the anthropological literature, to suppress hunger. They gave it as a gift. They did trade in tobacco, so they grew it to trade tobacco with other tribes. They used it socially. For example, meeting friends, sharing tobacco with friends, and also to give to your guests and to welcome guests. Of course, ceremonially, for initiation ceremonies, many purposes, and a lot of spiritual, ritual, and traditional reasons as well. Now, interesting, I also looked at how tobacco was prepared by the indigenous tribes. Sorry, wrong button. I've gone. I'm missing a slide there. Yeah, I'm missing a slide. Yeah. So I looked at how tobacco was prepared, and there were 6 different main ways in which indigenous tribes prepared tobacco for use. Smoking obviously was the most common, mentioned in the anthropological literature, but so too, and I have a bit of a picture there, but it's not showing up. It's been censored. Drinking, chewing. This is an order that they appear in the literature. Drinking, chewing, snuffing, licking. You have the ambil product in South America, the tobacco paste. So licking. And there are 2 mentions, of tobacco being taken via enema. It was mixed with other plant extracts that had also psychoactive effects. Oh, sorry about this. All right, that's showing you the number of citations based on, in the literature, 300 tribes and clans, and those are the smoking, drinking, chewing, snuffing, etc. So New Zealand, there's New Zealand. I have found, walking around the shops, some people don't know New Zealand. Really need to hold. So New Zealand and Brazil were early ratifiers of the Framework Convention on Tobacco Control, and both countries have implemented comprehensive advanced tobacco control programs with ongoing amendments over the years, extending dissuasive ways to reduce smoking rates. So Clive mentioned many of those. But in New Zealand, the reduction in smoking has been very slow. So all of those ways Clive mentioned, taxing, the warnings on packaging, all of the dissuasive methods together still only brought smoking down very, very slowly until, about 1% on average per year until vaping took off. Okay, so this Ministry of Health New Zealand graph is important evidence showing how vaping has sped up the reduction of smoking in New Zealand. The top light blue line shows the reduction in regular smoking down to 2021-22. This is among people aged 15 years and above. Regular smoking down to 9%. The brown line shows daily smoking prevalence down to 8% in New Zealand, 21-22 year. The dark blue line, this is regular monthly vaping. And you can see that increasing. So around about 2015, 16 is when vaping started to spread in New Zealand, and then you see it just now 2019-20 is when the government passed regulations supporting and encouraging people to move from smoking to vaping, and you can just see it shooting up there and smoking correspondingly dropping. The orange line is daily vaping. So daily vaping is the important one. That is where people have more success at completely stopping smoking, and daily vaping there is up to 8%. Now, this data does not take into account whether people are both smoking and vaping, so some people could be in both lines. It is cross-sectional, so it does not prove a causal relationship, but the association shown here, and Clive showed another one for the US, and there's many other countries showing the same picture, along with other results, suggests that vaping does help to displace smoking. Right. However, New Zealand's national achievement of only 8% smoking hides the fact that there are some groups who are being left behind. This graph shows daily smoking by income split into quintiles. The graph shows, so quintile 1 are the 20% of the population earning the highest level of income. Quintile 5 is 20% of the population earning the lowest level of income. So you can see here that almost 60% of the population on the higher levels of income are all sitting around 5% now. 5% smoking is New Zealand's goal, to reach 5% or below by 2025. The highest income group are pretty much there. But look at quintile 5, the lowest income group. Now there, daily smoking among our poorest women is 16%, and for males, 19%. Another left behind group are our Indigenous population. We are about 15% of the total population, quite powerful politically. Sorry, this is so sensitive. All right. So this graph shows, I just need to give some historical context. Māori were introduced to tobacco. So it was we didn't have it. It was introduced around the time of colonisation. The missionaries, the whalers, the sealers, and the British people who took over New Zealand introduced it to both men and women. Women smoking at that time was not usual in Europe, but for trade reasons, it was introduced to our Māori women, and they have been smoking for 180, 200 years. Having both mum and dad smoking increases your uptake among youth, and this is why we are where we are with very high smoking rates. That was not the same for European women. The light blue line shows daily smoking among Māori women, which for many decades has been higher than Māori men. Until last year, and this is what I have worked for 30 years, to bring down Māori women's smoking rate, pregnant women's smoking rates, and finally we've dropped to below men's rates just last year, to 18%. And men, Māori men, the brown line, at 22%. When I started in this work, Māori smoking prevalence was 50%, 30 years ago. But look where New Zealand European, our white, population and other immigrants are. So the dark blue line, 6%, is women, and that's 3 times lower than Māori women. And similarly, New Zealand other men are at 8%, 2.63 times lower than Māori men. It is very important from a harm reduction perspective to consider how policies will affect the left behind groups. Harm reduction isn't just about getting people to move from a high risk product to a lower risk product. It's also about reducing existing harm whilst not introducing new causes of harm, like what happened as a result of prohibition of alcohol in the USA. A harm reduction approach does not support increasing other harms, such as those that result from poorly thought through policies like banning vaping. Poor policies like banning the lower risk alternatives to smoking can result in increased illicit market activity, illegal market activity, associated crime, injury, convictions and imprisonment. As a result, in New Zealand, of extremely high taxation on tobacco, making cigarettes unaffordable for the poorest people in New Zealand, it's like the wild, wild west now. Rampant with robberies for tobacco. Stores are ram-raided, cars smashed in, and product taken. They're now ram-raiding vape stores and taking vaping products. Recently, a convenience store shopkeeper was murdered in one of these robberies. And it's getting worse. They're now going on to ram-raid all other types of stores, jewellery stores, TV stores, fridge stores. In New Zealand, policies that increase poverty, marginalisation and crime will have a serious and harmful effect on our Indigenous Māori people and other poor people, the left behind groups. Māori have high smoking rates, so they will be particularly affected by very harsh anti-smoking policies. And they already make up over half the population imprisoned in New Zealand. Over 60% of women imprisoned in New Zealand are Māori women. Anything they do to increase crime, anything they do that will give the police more power to arrest and search and charge Māori will see them even more of them imprisoned. So I'm against these very extreme anti-smoking policies. They have an effect. for this forum, I looked at where South American countries are in terms of the 4 phases of the smoking epidemic, and you have the handout on your chairs. So just to explain the table, phase 1 of the epidemic, the darker green, is seen to be, it hasn't taken off yet. It's below 5%. And this is particularly the case in many African countries. Phase 2 countries have high rates of smoking and they have plateaued. They're not reducing at all, or it's not evident. So this is the yellow, this lighter yellow colour, phase 3. They're beginning to experience a decline in their high smoking rates, but it is slow. And phase 4, countries like Brazil and New Zealand, which have brought about a large decline in smoking rates. Now, if you have a look at
Mariva, do you want me to control your slides for you? Is that the right one? Is that correct?
Yeah,
is that
that's
right?
that's
okay,
the right
I'll do
one
it
now.
from the laptop.
Okay, if you could keep it there, because I'm sorry, it seems to have
That's okay.
a transition on it. So this will just be useful for later on, our discussions maybe later today. And right. So females in Ecuador and Guyana are in phase 1, so this darker green over here. Their smoking rates are below 5%. Peru and Suriname, are in phase 2, the orange, as are men in Chile, Ecuador and Guyana. The colours are not showing up very clearly, but you can see it on your table there. Phase 2. High smoking rates, not much decline is happening. Argentina, Uruguay, and women in Chile are in phase 3, the paler yellow, and Bolivia, Brazil, Colombia, and Paraguay are in phase 4, the light green. Next slide. In conclusion, historical context is important. Different social, cultural, and political contexts determine disparities within countries. Times and products have changed, but some of the reasons why people use tobacco or nicotine have not changed. Risk-reduced tobacco and nicotine products that are acceptable to the consumer could, in time, eliminate smoking-related diseases. Beware of policies for which there are no scientific trials conducted in real-life communities that record the adverse reactions and consequences of interventions and policies. And beware campaigns demanding prohibition, especially in countries with large disparities in smoking and income level and by ethnicity. Thank you. Obrigado.
Thank you so much, Mariva. I'd like to just point to your one statement about the smoke-free status of New Zealand. If you had to advise the Brazilian regulators what the steps were for New Zealand to almost reach that stage of 5% smoking prevalence, what would that be?
To rapidly reduce smoking to 5%, given that Brazil also has had a comprehensive program, has tried many of the Framework Convention strategies to reduce smoking, I would recommend supporting people who smoke, adults who smoke, to have access to alternative lower risk products, not just vaping. People need a choice, and so actually in New Zealand we also have the heated tobacco product, but advertising of tobacco products is banned, so very few people know about it, and it also costs more than vaping. Vaping is very cheap. compared to smoking. So allow people access to vaping products, heated tobacco products, and the oral nicotine pouches, at least the oral nicotine pouches, which are even lower estimated risk than vaping and heated tobacco products. So allow access like Sweden has to all of those alternatives, and you will see a much more rapid drop in smoking prevalence than even we have experienced.
Excellent. A round of applause for Mariva. Thank you very much, Mariva.
Sorry for the technical
No
difficulty.
problem. No problem at all. Thank you, Mariva. And what we will do is we will make sure that your full presentation is available on site on the PARA website. We have a local television station here who wanted to do an interview with Dr. Milton. So what we will do, Professor Gioda, is we will do our panel discussion when we do science, just after lunch. But we are very privileged to have with us one of the prime technical and experts in toxicology in Brazil, Professor Adriana Gioda. We welcome you and very pleased to have you here. And we'll have some panel questions to you later in the program. Now, just on the theme of smoke-free member states, this has been for the UN and particularly the World Health Organization a global goal. It's for all of the 194 member states of WHO to achieve smoke-free status. There's one country in the world, and we'll just quickly show you a video, who has almost achieved this. It's a country with a smoking prevalence of 5.6%, and we would like to ask Dr. Anders Milton from Sweden to give us some insights into how they did it, but first we'll show you a small video.
Suécia, o país com as menores taxas de tabagismo em toda a Europa. Tão baixas que neste ano, em 2023, deve se tornar, de acordo com os critérios oficiais, livre do fumo. É uma meta que a União Europeia pediu que seus Estados-membros alcancem até 2040. A maioria não devem alcançar essa meta, mas a Suécia irá ultrapassá-la com incríveis 17 anos de antecedência. A taxa de tabagismo do país há apenas 15 anos era superior a 150% do que é hoje. Os suecos nos mostraram o caminho para sermos mais seguros e saudáveis, da mesma forma que fizeram ao inventar os cintos de segurança de 3 pontos, mas enviaram a invenção para todos os fabricantes de carro do mundo de graça. Os cintos de segurança já salvou mais de 1 milhão de vidas, desde que um engenheiro da Volvo teve a ideia em 1959. O último milagre de saúde pública da Suécia poderia salvar 3,5 milhões de vidas na próxima década, se aceitarmos seu mais recente presente à saúde pública global. Os suecos praticamente extinguiram o tabagismo ao desenvolver uma fórmula de política pública específica que torna as alternativas mais acessíveis, mais aceitáveis e mais baratas que cigarros aos consumidores. Os resultados falam por si. Os suecos há muitos anos usam a educação, medidas de controle do tabaco e snus para manter as taxas de tabagismo baixas. Mas a introdução de alternativas modernas livres de tabaco, vaping em 2015 e bolsas de nicotina de nova geração que seguiram em 2018, aumentam ainda mais o declínio tabagista. Na última década, taxas de tabagismo na Suécia caíram por incríveis 55%. No resto da União Europeia, as taxas de tabagismo estão na média 5 vezes mais altas que na Suécia, porque tem uma abordagem de política de dar menos apoio às alternativas ao cigarro. Em comparação com o resto da União Europeia, a Suécia tem 44% menos mortes relacionadas ao tabaco, uma taxa de câncer que é 41% mais baixa e 38% menos mortes atribuíveis ao câncer. Se todos os outros países da União Europeia seguissem o exemplo da Suécia, até 3,5 milhões de mortes prematuras na Europa seriam evitadas em pelo menos uma década. Especialistas em saúde pública de renome internacional concordam.
I think we have the answer already. Tell the world about the Swedish experience and the mixture of pros and cons that we have had that have been helping people to leave cigarettes. Maybe it is something important for the government to tell the consumers that if you need your daily nicotine, use this instead of cigarettes.
E este é o presente da Suécia à saúde pública global e por que a mensagem ao mundo em relação ao tabagismo é: pare como a Suécia. Suécia Livre do Fumo 2023.
So it's my privilege to introduce to you Dr. Anders Milton. He's a specialist physician. He's also the former president of the Swedish Red Cross and the former president of the Swedish Medical Association and chairman of the World Medical Association. Anders, please.
Thank you very much. Thank you very much. I also did employ Delon at the World Medical Association. I was always interested in societal things. I'm a doctor by training, as Delon said, but I was always interested in society and what happens. I was also part of the group that Gro-Harlem Brundtland, the then Director General of the World Health Organization, called together to fight for less smoking. And that's where I saw Derek a lot. Why then do I work with snus, which is the Swedish equivalent of harm reduction, as it were? Well, the reason is that I was asked by a public affairs company in Stockholm if I would like to work with this, and I said, I mean, the two things. I mean, first of all, I have to choose the people I want to work with, and second, the people that pay us will not have any role whatsoever in what we study, and they will not look at the beforehand what we produce or what we publish. And they said yes. I said okay. So I called some friends of mine that one is the previous head of the Metal Workers Union in Sweden, you know, a friend of Lula's, you could say. Another is a journalist who worked a lot with Swedish television and newspapers, and then colleague Fogelström, who was a tobacco researcher for 25, 30 years, something like that. And we have produced a number of things, and we have fought to become Sweden, to make the Swedish policies more inclined to harm reduction, because we have the same problem in Sweden as you have in your countries, that people listen to the World Health Organization. I mean, I've been at the World Health Assembly for 15 years as a senior consultant to the Swedish delegation. I worked a lot there. But I mean, the thing is that now the World Health Organization is barking up the wrong tree, unfortunately. So we have, as you see, we have the lowest current tobacco use in the or smoking rate in Europe. The question is, does this show the whole picture? No, it doesn't, because about 15% of the men use snus daily, because we have that. It's a tradition that goes back 200 years, something like that. Nowadays, with nicotine pouches, you know, without any tobacco whatsoever, you just have the nicotine in a mesh, as it were. And I'll show you some photos. Well, this is we have 5.6% as a due for men. Well, it doesn't work. Could you have the next one, please? Well, I mean, we're almost to the point of 5%. We can have the next one, please. This is the prevalence of daily tobacco use. You see Sweden there, you know, about 20%. We are about the same as the rest of the European Union, except the difference is that they use non-smoked tobacco in Sweden. And, well, we can take the next one. this is tobacco smoking. You know, this is about 5% of the men that do smoke. And it's going down rapidly. We could have the next, please. Here you see cigarettes going down and snus and nicotine pouches going up. Now the question is, do you get cancer from snus? Well, you don't, unfortunately, as it were. You know, you die from smoking. 50% die from smoking, of the smokers. But snus, you can continue with that the whole life. You will not die prematurely. You will see your grandchildren grow up. That's the difference between different uses of tobacco. Could you? This is the cancer fund. You know, the Swedish equivalent of. You have the same in all countries. As a matter of fact, the director of that foundation is a member of one of the boards I'm chairing. But what they say is that we don't know yet. They don't know yet. But when we talk to them, they know that snus, in our case, is much less dangerous than smoking tobacco. Could I have another one? You'll have these. This shows that snus doesn't give you cancer. You could have the next 4 or 5 slides, because you will see them in. You continue. You can continue. You can continue. Continue. Yeah. You see, all the slides that I didn't show you tells you about the different forms of cancers and snus, and the different articles, the scientific articles that are there. And you know, in New England Journal of Medicine in 2017, there was a big article about diseases related to different forms of abuse or lifestyles. And I quote directly, it says, "There is no disease burden attached to snus." And the study was paid for by Bloomberg and the other, well, Gates. I mean, both serious non-smokers or non-tobacconists. And there is no disease burden attached to snus. The important thing for Sweden and for the rest of from Brazil is that you have to have alternatives. I mean, if you're going to have smoking stopped, you have to have alternatives. In our case, we have snus. In other countries, you don't have snus. You might have nicotine pouches, but you have vaping or you have heat-not-burn. And with snus, we know that it's not dangerous because we have had it around for a number of years. But the important thing is that you have to have alternatives. Otherwise, people will not stop smoking. Because as Clive said earlier on, people smoke because they like it. You know, they're not going to stop, unfortunately. So I think it's very important that you, on the one hand, have restrictions on smoking. I mean, the Swedish government has done what all governments in Europe has done. They have restricted smoking. I mean, you cannot smoke in restaurants, you cannot smoke in bars, you cannot smoke basically anywhere, apart from your home. But the point is that people have stopped smoking, but they haven't stopped using nicotine. They use nicotine. 23% of the Swedish male population uses nicotine. The same figure about it as in the rest of the European Union. So the reason why we have succeeded in lowering the incidence of smoking is that we have alternatives. You know, Norway is close to Sweden. I was there meeting the Minister of Health. And first speaks the minister, then the Cancer Foundation, the Norwegian Cancer. And they said that they had 12,000 cases of lung cancer in Norway each year. It sounded a bit much, I thought. So I looked at the Swedish Cancer Foundation. What are the Swedish figures? We have a population in Sweden that is 90% higher than in Norway. So if they have 6,000, we should have 12,000. basically, or 11,000. We have 5,200. So we have half the number of lung cancer that they have in Norway. You know, I mean, there must be something. And the question is, what is it that makes people leave cigarettes? But you have to do an alternative. Again, that's why the World Health Organization is barking up the wrong tree. Prohibiting alternatives instead of allowing them to foster. I think it's very important that we have alternatives. And that is really the experience of Sweden, I think. Fight smoking, but give alternatives. Thank you.
Thank you very much, Anders. I just want to make sure Anders is going to be interviewed by the TV crew, so we thank you heartily for your contribution. And I just wanted to make sure Anders has kindly also allowed that specific slides will be put on the Para website to summarize what Anders has just said, the fact that, as you saw in the video, that there is a very big discrepancy between the Swedish smoking prevalence and the rest of the EU. Secondly, that it's clear that, as Anders said, the fact that alternatives has been allowed, snus and oral nicotine and vaping products, that this has driven down the smoking prevalence. These are the really important stats for Brazil as well. The fact that there are 44% fewer tobacco-related deaths, 41% lower lung cancer rates than in the rest of the EU is testimony to what the Swedes did right. So the four fundamental strategies that were employed in Sweden: public policy that recognized tobacco harm reduction; secondly, the fundamental differentiation between combustible and non-combustibles; and then Anders's point, access to smoke-free nicotine alternatives made all the difference. And then obviously all the educational resources that were made available. The slides and the video in Brazilian Portuguese will be on the Para website. Anders, thank you very much. I'll let them call you, Anders. They're coming now. Professor Heino Sturver, all the way from Frankfurt. We want to thank you for coming to our Para Summit. Professor Sturver is a social scientist at the Frankfurt University for Applied Sciences, and he has the Germany national case study that he would want to share with us. I think you can see that the pattern that we're following is we started at global, the role that Brazil played in global tobacco control, and then we moved to New Zealand, Sweden, and we are delighted that Professor Sturver would be able to give us insights into what's happening in Germany. Professor Sturver.
Many thanks.
Sure.
Many thanks, Delon and Jessica, for the invitation. Yes, I'm reporting about Germany, which is a little bit the opposite of what Anders just told about. So we are, sorry, it kicked out? Okay, sorry. Now, we're a little bit the opposite. We are in line with the cancer plan of the European Union, and in the plan it is envisaged to become smoke-free by 2040, by the year 2040, and that's the same for Germany. So we envisage to become smoke-free. That means less than 5% of the adult population is smoking. By 2040, not 2025 New Zealand, not 2030 UK, but 2040 the European Union wants to become smoke-free, and that means 5% less. So I will tell you a little bit of how this could work in Germany, but unless they are not integrating harm reduction strategies into their smoking cessation strategies, this will not even be achieved, the goal by 2040. So Germany does not have an official tobacco control policy. It is left to the NGOs, and some 40 of them reported, made the goal for tobacco-free Germany 2040. This is the plan, which should, let's say, be achieved by 2040. And they had some 10 strategies recommended to achieve the goal, tobacco-free Germany 2040. But all of these goals are more or less, let's say, behavioral preventive oriented, and not, let's say, so the structural prevention is very much paid attention to here. And you will find no wording, the term of harm reduction will not appear throughout the whole text of this plan. As I mentioned, the plan not be, let's say, given by the government, but by 40 NGOs. However, how can we achieve smoke-free Germany by 2040 when we have a prevalence at the moment of 35% smokers? And that is, you see here, an increase of 10% during COVID times. 10% increase. You see, when the lockdown came, and there were lots of, let's say, reductions of public meetings and so on, people tend to smoke at home. So the lack of social control led to the fact that there was an increase by 10%, so now 35%, and not, let's say, the data just Anders presented from 2021 from the Eurobarometer, but now we've got 10% more. And this is the representative study, the inquiry of the smoking behavior of Germans, which has several points to inquire, and this is the latest form here from early 23. So Germany is a tobacco land. We've got hardly any control. The control is left to the 16 states of Germany, and that differs a lot from very severe anti-smoking policies like in Bavaria to very lax and loose strategies in some other cities or countries like Berlin or in the northern part of Germany. You see here the tobacco automates. We've got 340,000 of them standing available 24/7, and the only filter is that you have to be more older than 18 years. And then you can get, with a bank card or with your passport, you can get cigarettes out of them. So 340,000 pieces are standing in the community. This is the train station of Heidelberg in the southern part of Germany. You can see them everywhere. And this is giving a wrong signal, because showing, let's say, the easy availability and accessibility to tobacco products means or indicates that the content might not be as dangerous as it should be, because it's freely available here. So I think we are not equipped to achieve our goals unless we are integrating harm reduction strategies. But there's no or little, very poor political attention and allocation of resources to the policy in Germany. We do have a policy of doing more of the same and hoping that we will achieve the targets with this kind of strategies. We completely underestimate in official policies the impact of the dependence dynamics. So the WHO Collaboration Center for Germany is in the hands of the Cancer Institute in Heidelberg, and they are, I would say, a little bit blind on the eye of the independence dynamics, but they're fully, of course, focusing on the cancer issues around smoking. And we do have a one-dimensional fixation on abstinence as the only and ultimate goal of all the strategies we are applying. And of course, there's a lack of answers to diversity. When we look at the prevention strategies of stop smoking initiatives in Germany, we don't see, let's say, gender-specific, age-specific, minority-specific messages. We more or less see a one-size-fits-all strategy. And this is not, let's say, leading to the goals we are looking at. This has been already quoted, the fundamental sentence in Article 1 of the Framework Convention on Tobacco Control. That means here, already at a very early point of the stage, harm reduction is mentioned as a complementary strategy to supply and demand reduction strategies. So we should focus on that if we want to become really successful. So harm reduction is successful in other health and drug policy areas. Delon mentioned already HIV/AIDS and drug demand and harm reduction strategies. I was working in these fields for a long time, since 30 years more or less, on the HIV and AIDS harm reduction field. So we introduced clean needles also in the prison setting, and we did a lot, and it led to a success that below the HIV rate of the target group of drug user and prison inmates is below 7% in general, so that is quite a low prevalence. There are many forms of alternative forms of nicotine consumption. We heard that already, but this is ignored to a huge degree in Germany. It is allowed e-cigarettes, but they are taxed, for instance, in the same way as combustible cigarettes are taxed, and there's no risk-oriented taxation policy. An extension of smoking cessation strategy has to include e-cigarettes because it's successful, and we do have little knowledge about health benefits of e-cigarettes. A recent study said that almost 60% of those asked do think that e-cigarettes are at least as harmful or even more dangerous than combustible cigarettes. So there's a huge educational demand we can see. So in Germany, we do not see any differentiation of the harm reduction, of the harm potential when it comes to combustibles and all the other, let's say, nicotine plaster, nicotine pouches, snus, which is not allowed in Germany and in the rest of the EU, apart from Sweden and Norway and tobacco heated products. So there's no differentiation in taxation and also in the education and prevention strategies. And this is completely in opposite of what is being done by other countries. I do quote UK here, not Sweden, which is, let's say, a little bit exceptional because snus is allowed. But the ambitious goals of the UK, becoming smoke-free in 2030, and they are now at a point of 13% smoking prevalence in the adult population, which is tremendous for Europe. You have seen the high prevalence rates. And they are doing now 1 million free of charge e-cigarettes in UK to achieve the smoke-free goals in 2030 in the program SWAP to Stop. And this is really an excellent example of how we can reach, especially what we just heard from you from New Zealand, parts of the population which are belonging to the poor part of the population. So 1 million e-cigarettes are given out free of charge. So you see here, this is the tobacco control scale for Europe from 2021. And this control scale is measuring of what are the countries doing and how far they are implementing the recommendations of the World Health Organization for tobacco control. And you can reach 100 points here once you have, let's say, succeeded to implement all of these recommendations, not to have adverts or banning adverts, for instance, having no cigarette automats and many others. And you see on top the leader are Ireland and the UK with more than 80 points or 80% of implementing the WHO recommendations. And you see here on place number 34, Germany, which is hardly to implement the WHO recommendations. And that is, of course, only the fact, in the 2019 scale, we've been on place number 36, the lowest, but we are now at place number 34, just because other countries were included into this rating. So that said we were no longer the last in Europe. But that's a very poor result. You can imagine for a highly industrialized country to be in that very poor position in implementing tobacco control strategies. So you can see there's a very clear relationship between the inadequate tobacco control policy and prevalence. Germany is a high consumption country, and the counterexample UK is clear, approximately 13%. Sweden, the rate is 6%. And we only, let's say, implement the advertising ban in 24 next year. So until now, the big tobacco can clearly advertise the tobacco products wherever they are. So it took us, let's say, 20 years to reach only this small result that the advertisement is being banned next year. And then there's an assumption for drug costs for smoking cessation by the statutory health insurance system. So the conclusion is tobacco smoking is the largest preventable health risk, not only in Germany but in Europe. It's preventable. Until now, the results of tobacco cessation, smoking cessation, is very poor. Tobacco control policy in Germany is not evidence-based and differentiated in its objectives. So when we had the latest guide for smoking cessation strategies, even some of the most recent scientific results were not included and have not been taken place into the guide. And alternative nicotine consumption products are much less harmful to health than tobacco cigarettes. We've heard that quite often in the morning. And the reputation of e-cigarettes, tobacco heaters, is low, or nicotine pouches is low. Factual education is urgently needed, and a diversification of smoking cessation strategies is necessary. So at the moment, we are fighting for, let's say, integrating the construction of harm reduction also in the tobacco field, as we were very successful in other fields of public health. And this is one of the most recent publications we did on tobacco harm reduction, new smoking cessation strategies, and we hope to persuade the government in the very near future also in Germany. Many thanks for your attention.
Thank you, Heino. Heino, on this, what we will do is we will now turn towards Latin America and look at the example by Dr. Verrastro, and then we'll have a panel discussion later. It is now my privilege to introduce Dr. Diego Verrastro, who is from Argentina. He's a general surgeon, and he's also the spokesperson of the Latin American Network for the Reduction of Tobacco-Related Harm. It is such a privilege to welcome him, and so relevant to our discussions today. You've now heard from New Zealand, Sweden, Germany, and now the Latin American continent, and we look forward to your remarks in this regard. Press that one, and that's
Okay.
Yeah. Sí.
Bueno, muy buenos días a todos. Es un honor estar acá. Yo soy el portavoz de la Red Latinoamericana para el Control de Daños Asociados al Tabaquismo. Somos una red muy joven, tenemos 2 años y la conformamos más de 30 profesionales de la salud. No solo médicos, sino bioquímicos, psicólogos, hay personal sociosanitario como asistentes sociales, hay físicos, hay todo el profesional que esté en algún punto relacionado con la ciencia de la reducción de daños es bienvenido en la red. Tenemos, a ver, como les comentaba, es una unión de profesionales, ¿no? Pero la idea fue generar un espacio independiente de investigación y divulgación, y para eso hemos conformado la red sin personalidad jurídica. No tenemos cuenta bancaria. Todas las personas que se suscriben lo hacen por voluntad propia y ad honorem, que eso es lo que nosotros primamos en poder sumar a estas personas. Queremos tener una visión crítica y autónoma de lo que es la reducción de daños, y para eso no tenemos conflictos de intereses con la industria tabacalera, con la industria farmacéutica, la de los cigarrillos electrónicos, y con una gran industria que creo que es más grande que todas las anteriores, la industria filantrópica. Si a alguno le cabe la duda que es una industria, lo es. Bueno, la prevalencia de tabaquismo en Latinoamérica. Un gran misterio. Un gran misterio. A ver, la prevalencia del consumo de tabaco en la TAM no hay un consenso generalizado y cabe preguntar por qué. Fíjense, la Organización Mundial de la Salud dice que Panamá, Guatemala, Ecuador tienen prevalencias entre el 4, el 5, el 6 y el 7%. ¿Qué hacemos mirando a Suecia? ¿Alguien cree esto? ¿Que sea real? Creo que nadie. ¿Sí? Entonces, ¿cuál es el problema? El problema es que muchas de las estadísticas que manejan todos los gobiernos de Latinoamérica quieren estar en línea con el mandato de la Organización Mundial de la Salud. Entonces, muchas veces esas estadísticas no son reales, señores. Brasil, fíjense, según la Organización Mundial de la Salud, 11%. En la última encuesta de Covitel del año 2022, 11%. Hay mucha diferencia. Cabe preguntar el por qué. A ver, la región de Latinoamérica es una región muy heterogénea, con situaciones geopolíticas muy distintas, con idiosincrasias muy distintas, y todos y muchos de los países que la conforman han adoptado al pie todas las recomendaciones del convenio marco. Las recomendaciones, ¿sí? A pie juntillas. Bueno, la lucha no dio abasto, porque sus estadísticas no son reales, y a pesar de que en los números bajan la prevalencia al tabaquismo, se olvidaron de también medir que el consumo de tabaco aumentó. ¿Y aumentó por qué? Porque hay un gran comercio ilegal. Hace poquito tuve una reunión con la encargada del control de tabaco de Panamá, la doctora Reina Roas, donde me corrigió que por qué mirábamos a los países nórdicos y no mirábamos a Panamá, que tenía el 7% de tabaquismo. Lo que se olvidó de decirme la doctora es que el 90% del consumo de tabaco es ilegal, con lo cual está fuera de las estadísticas de ellos. ¿Por qué? Porque tampoco descienden las enfermedades asociadas al tabaquismo. Inclusive se han estancado en muchos de estos países. Entonces, ¿cuál es el camino? El camino que han optado son las políticas de contra el tabaco, que vienen siendo las mismas por décadas y décadas. No se atreven, como está ahí el slide, a salir del camino, a evaluar opciones nuevas. Y la reducción del daño por tabaquismo con estas herramientas es el camino, es la opción. Pero ellos no lo ven. Ellos, a ver, ya lo he puesto en mis redes, tienen un lema. En la era de los datos científicos, en la era de los datos estadísticos, los antitabaco tienen esta premisa: si los datos contradicen al relato, obvia los datos. Siguen con este relato, permanentemente, cueste lo que cueste. Y lo que está costando son la vida de muchas personas. El compromiso de RELDAT es el de formación de profesionales en THR. Ahora, yo les quiero preguntar, ¿dónde se forma un profesional en herramientas de reducción de daño por tabaquismo? ¿En la universidad? No. En los cursos de pregrado, tampoco. Lo tiene que hacer el profesional por su cuero, por su propio interés. Entonces, un poco la regla es estimular a que esos profesionales empiecen a estudiar, a salir de esa comodidad que conocían para poder empezar a incorporar estos nuevos datos de reducción de daño. Tratar de asesorar en la decisión política de los países a nivel institucional y el manejo de la información mediática y pública. Acá en Latinoamérica, un titular de un diario es la verdad absoluta muchas veces. Entonces, necesitamos intervenir también en lo que es la comunicación a la población. ¿Qué hacemos para eso? Generamos conciencia en profesionales, en la población en general, en los gobiernos, entablamos debates científicos con funcionarios del área de salud, lo cual ya les aclaro que es un trabajo titánico. La negación es absoluta y profunda. Informamos sobre generar productos de daño reducido, una información veraz, clara, que la puedan entender todos los niveles. Asesorar el asesoramiento médico-científico con el fin de contribuir regulaciones basadas en la evidencia científica. A ver, posiciónense en Latinoamérica donde Chile está en vías de regulación, todavía no está regulado. En Paraguay hay una ordenanza administrativa que les permite comercializar estos productos. En Uruguay está aprobado el tabaco calentado, no el vapeo. Y Venezuela, que bueno, todos saben, no es una democracia, por ordenanza presidencial está regulado como un producto de consumo. El resto es todo prohibido. En el resto está todo prohibido. Entonces, imagínense cómo podemos generar conciencia en el último efector que toma contacto con el paciente, que es el médico. Cuando el gobierno, la Organización Mundial de la Salud, el Ministerio de Salud le está diciendo esto está prohibido y usted puede perder su matrícula, su puesto de trabajo si hace caso omiso a todas estas indicaciones. Y ha pasado. La divulgación, como les comentaba, y participar en estos foros internacionales para poder llevar nuestra visión de lo que es trabajar en Latinoamérica con este tema. Hay esperanzas, hay esperanzas porque a lo largo de estos 2 años hemos tenido conversaciones con actores decisores de política en los parlamentos de Chile, Panamá, México, Colombia, Costa Rica, Argentina, Perú y Ecuador. ¿Por qué es necesaria una regulación basada en la evidencia? Creo que ya muchos los han dicho. Voy a ir rápido con esto. Evitar los peligros de los mercados ilegales e informales, ¿sí? Evitar la estigmatización de los consumidores de nicotina, maximizar el potencial de los nuevos productos de nicotina sin combustión para salvar vidas, ¿sí? Y justamente no olvidarnos de la protección de los derechos que tenemos, el derecho al máximo grado posible de salud, el derecho al libre desarrollo de la personalidad, el derecho a la información, y el derecho a participar en las decisiones y regulaciones que van a influir sobre nuestras vidas y sobre nuestra salud. La reducción de daños por tabaquismo es una estrategia amparada, como lo dijeron hace un ratito, en el artículo 1D del Convenio Marco para el Control de Tabaco de la Organización Mundial y además en el Programa de las Naciones Unidas para la lucha contra sustancias ilegales. Las malas lenguas dicen, y la mía que repite ahora, y se los digo acá y se los desmiento afuera, dicen que van a sacar este artículo 1D en la próxima COP10. Eso es lo que es el rum de pasillo, pero bueno, como así también cambiar la definición de humo. Fíjense hasta dónde están llegando para que nosotros no sigamos adelante. Una correcta regulación debe jamás equiparar estos productos al tabaco. No es tabaco, el vapeo no es tabaco, ¿sí? Como así una berenjena o un jitomate tampoco es tabaco y tiene nicotina. Garantizar el control de calidad para la seguridad de los productos. Ya sabemos que el mercado ilegal de los vapers es muy grande y a veces llegan productos que no tienen la calidad necesaria para esas personas y poniendo en riesgo también la salud pública. Control de espacios frecuentados por menores, esto es importantísimo, así también como la venta y acceso a los menores. Pero ¿qué pasa? Fíjense una cosa, menores. A ver, en los países regulados las terapias de sustitución con nicotina pueden ser implementadas a partir de los 15 años. ¿Y qué hacen? Reemplazo de nicotina. ¿Y esa nicotina es distinta a la que está en el vapor? No, es la misma. Entonces tenemos que abrir nuestras mentes y siempre dentro de un marco regulado podemos tomar decisiones correctas. Fomentar las adaptaciones tecnológicas para la investigación, el desarrollo, establecer los impuestos adecuados, alguien lo había dicho recientemente, permitir los sabores, permitir esos sabores para la fidelización de ese paciente. Los adultos nos gustan los sabores, a los niños también. No se olviden que muchas de las empresas farmacéuticas hacen catas de sabores para sus jarabes pediátricos. ¿Por qué? Porque si no, la criatura no lo va a tomar. Y el adulto exactamente lo mismo. Entonces, evitar los sabores es un gran error. Y más cuando un tabaquista empieza a rehabilitar sus papilas gustativas, sus papilas olfatorias, eso lo hace engancharse más con las herramientas de reducción de daño. Bueno, menos impuestos, menos daño. Menos daño, menos impuestos, perdón. ¿Por qué? En Latinoamérica la gran población fumadora es de medios y bajos recursos. Entonces, tenemos que generar un producto accesible y asequible. Realizar una correcta comunicación basada en la evidencia científica hacia toda la sociedad y realizar un seguimiento poblacional del consumo de tabaco y nicotina. Déjenme decirles que todo esto requiere mucho trabajo y muchos de los gobiernos les es más fácil prohibir que regular estos productos, porque tienen que, no ven todo el potencial de ahorro en gastos sanitarios ni en gastos del gobierno. Solo ven que tienen que trabajar. Disculpen, pero es mi visión de todo esto. Si hay algún político, lo lamento. Comprender la tecnología disruptiva, conocer las ventajas y desventajas a la hora de poder asesorar a nuestros pacientes. Intermediar con los entes de salud pública, generar información médica y científica y generar espacios de niveles formativos, no solo a nivel de los profesionales de la salud, pero sino también a niveles secundarios y niveles primarios con tutores, con celadores de esas personas. ¿Por qué? Porque muchas veces todos estos problemas aparecen en la escuela primaria o secundaria. Entonces, tenemos que tener a los docentes también capacitados para poder contener en este tema y poder intervenir. Ahora, ¿cuáles son los retos? Fíjense que a través de años y años de evolución y conocimiento, a través del método científico, hemos caído en la desidia, en la pereza, no sé por qué causa, pero creo que hoy la comunidad médica y científica le estamos fallando a la sociedad. No sé si por no salir desde del lugar de comodidad o qué, pero hemos caído en la confrontación agresiva y desprestigio como forma de imponer ideas. Siempre nos hemos peleado los médicos con los mismos médicos, pero en un ámbito de ciencia, dentro de un hospital, en un ateneo. Creo que hay varios médicos acá y por ahí han experimentado esto, pero no en forma mediática, donde eso a veces impone que los profesionales pierdan sus fuentes de trabajo, su prestigio profesional. Yo lo he vivido personalmente. Al estar a favor de las herramientas de reducción de daño, me han acusado de estar haciendo apología del consumo de la nicotina en todos los medios de mi país. Entonces, es una situación bastante complicada. Tenemos que decir basta, basta. Tenemos que ir a Panamá, a la COP10, a imponer nuestras ideas, a poder discutir en forma coherente y científica de que 2 ideas no suman 0, suman 2. Tenemos que poder salir de este cascarón en el que estamos y no olvidar lo que nos enseñaron nuestros viejos maestros de la medicina, donde se planteaban permanentemente y se cuestionaban permanentemente lo que estaban haciendo. Y si esto no es así, y probarlo con ciencia, no con discurso ni con relato, con ciencia. Y sin miedo a la soledad profesional, que la hemos sentido todos. El año pasado he escuchado los argumentos de Maregua en el GFN y la verdad que salí muy conmovido, y este año pasado lo hemos vivido nosotros en Argentina. Estamos del lado correcto de la historia. Somos médicos, honramos nuestro juramento de no hacer daño, do not harm, con mucha valentía y honestidad intelectual. Y déjenme hacer un juego antes de despedirme. Imagínense que son médicos en Latinoamérica que están a favor de la reducción de daños y que tienen a su paciente enfrente en el escritorio y le dicen, mirá, podés dejar de fumar, ya intentaste con un montón de cosas, cada vez tenemos menos herramientas. La vareniclina salió del mercado. Qué casualidad. No anduviste con el bupropión, no anduviste con las terapias cognitivas. Bueno, tengo algo para ofrecerte. Vamos a usar un vapor, una herramienta de reducción de daño. ¿A dónde lo mandamos a adquirir eso? ¿Al mercado negro? ¿Al mercado ilegal? ¿El médico va a hacer una receta en su escritorio para lo cual el médico debería conocer cuál es todo el circuito ilegal que tienen esos productos para llegar al consumidor? Créanme que ningún médico lo va a hacer. Gracias a Dios yo tengo la suerte que al lado de mi consultorio tengo un vape shop. Me es más fácil, pero si no, nadie lo hace. Muchas gracias.
May I please ask for Diego, would you please join us here in front, Heino and Anders? And if I may ask Professor Adriano Gioda to join us as well. Please take your handsets and allow me to just first introduce Professor Adriana Gioda. She is a professor in chemistry at the Pontifical Catholic University of Rio Grande do Sul, here in Brazil. And we are privileged to have on the panel, we'll have a short 10-minute panel of 2 Europeans and 2 Latin American health experts. And it's a pleasure to see them together. A question first for Professor Adriana. Professor Adriana, Diego spoke about intellectual honesty, the need for intellectual honesty. And toxicologists deal in black and white. They can make precise measurements. My question to you is, what role can toxicology play in tobacco control, specifically in differentiating between combustible tobacco and non-combustible nicotine alternatives?
Bom dia. Bom dia a todos. Então, há uma diferença, sim, mas essa diferença...
The difference here has not been...
Nossa agência reguladora. Então, deixa só eu explicar toda essa problemática, por que eu estou sentada aqui, né? Eu sou professora, então, de Química da Universidade da PUC, né? Da Universidade do Rio de Janeiro, não é do Rio Grande do Sul, como ele falou. E eu comecei...
And I began...
Okay, fine.
Ok, só para...
Levantamento.
Ok.
Ok.
Tá bom. Então, esse interesse surgiu a partir de uma audiência pública da Anvisa. A Anvisa, que é o órgão regulador, proibiu o uso de cigarros eletrônicos em 2009. Aí, a partir de 2016, ela abriu, ou disse que ia abrir uma audiência pública para discutir de novo se regulava ou não os cigarros eletrônicos no Brasil. Então, nós lá da PUC-Rio nos interessamos pelo assunto e realizamos 2 seminários para discutir os cigarros eletrônicos, inclusive com a sociedade, com os pesquisadores, com membros da Anvisa e com médicos, né, para fazer um debate, para poder também ajudar a Anvisa. Nós, como academia, temos quase que a obrigação, né, de ajudar os órgãos regulatórios no país, né, com a nossa pesquisa. Então, foi isso que a gente fez. Né? Então, discutimos, debatemos, e a Anvisa, ela sempre diz que problema é a falta de informação científica, porque eles alegam que a informação científica disponível atualmente é feita pelas
por los productores.
Fornecedores de tabaco, pelas empresas de tabaco. Então, para eles, isso não é confiável, né? Torna esses resultados não confiáveis. Então, a gente entrou em contato com a Anvisa.
That's what their position is. We also had some subsidies to conduct research on behalf of the tobacco industry, but we decided not to do it because it would be a conflict of interest. We conducted a research with Anvisa, partnering with Anvisa to investigate the liquids used by vaping and in the electronic devices as in general. And then we somehow tried to import the products, but we couldn't because there was so many demands and requirements that we couldn't. We started talking about it 5-6 years ago. It has not been easy, but recently, after trying everything, we tried to buy the products legally according to Anvisa's guidelines. Now we are working with donations, users' donations. So the user donates their vaping products, their liquid products to us, their cartridges. So it's something to give us a north. It's important to have these studies. If we don't have these studies, these results, how can we say you can legalize it or you can't? How are we going to work regulations? So some time ago, Anvisa came to us. They said it was absolutely denied because all the different organs, Brazilian agencies and the academic, they do not recommend us that these ends can somehow work in harm reduction. And we know that there is this trend, this huge trend in using vaping, even if it's illegal. So, but us, being the academy, we cannot recommend it. We have never published anything because we do not have enough data. We do not have a cohort that was big enough to do it. We know that ends and electronic cigarettes, they do cause some harm, but it's so reduced that, and even if we used electronic cigarettes in Brazil, it could not be a flavored cigarettes because even regular tobacco cigarettes cannot be flavored. Anything else you add to vaping, it's going to be a complication. So we have to understand what the officials and the governments is discussing. I myself, as a researcher, I get no financial support, no aid whatsoever. I'm doing everything on my own. And Anvisa is not part of it anymore. We did not get the e-cigarettes. The research is absolutely independent. I don't know if I helped or I complicated it even more, but this is what I had to say.
Professor Gioda. Now I'd like to ask Professor Stover. In Germany, he managed to pull together stakeholders from government, the regulator like Anvisa here in Brazil, consumers and health professionals for multi-stakeholder engagements. We'd like to ask him how he managed to do that, especially in his annual E6 summit in Germany.
Yeah, many thanks for this question. I started like you. I did it more or less on my own, maybe as a former ex-smoker. I had a little bit of, let's say, experience to the topic, coming from other fields of harm reduction and drug use. However, when I saw the potential of non-combustible e-cigarettes, when I saw that in late 2018, 2017, I immediately started, let's say, to look how can they be beneficial for the smoker? How can we build a new smoking cessation strategy on that basis? And then I started from an academic viewpoint or from the university, and that is quite easy for me. So the university is not suspected to collaborate with big tobacco, what is the case, or what is of course true. Unlike, let's say, political parties, some of the major parties, they get funds from big tobacco. For instance, their annual meetings are paid by a tobacco industry and so on. This is not the case with universities, and my university was giving me some chances, let's say, some organizational funds to do these E6 summits each year. We've now having the 6th one in October. And for the first time, the Ministry of Health is supporting this conference. Some 100 people meet there annually, and the stamp of the ministry is giving some impact on that conference. So, and that is, let's say, the frame in which 100 people, stakeholders, key people are meeting and are debating. And I've shown the devastating state of tobacco control in Germany, and we are trying to convince government and key stakeholders to integrate harm reduction strategies into their smoking cessation policies, with only little success until now, because the smoking prevalence is so high, and the goals, even to become smoke-free in 2040, are so ambitious and unreachable if they continue the way they're doing. So I think there's a lot of ground to work on once we see the goals of becoming smoke-free before 2040.
Herzlichen Dank. Diego, if we may ask you as a doctor, you have a patient who comes in, they smoke 20 to 30 cigarettes a day. They tell you, doctor, I want to quit, but I cannot. And I don't really want to quit. I want to use the product. What is your advice to your patient in Argentina? And what happens in Latin America? Is it an easy process or difficult?
A ver, en toda América Latina están las clínicas de cesación tabáquica que dependen muchas del gobierno. Ninguna funciona. Ninguna funciona. Si yo tengo un paciente en mi consultorio, voy a tratar de, como hago con muchos otros procedimientos, de tratar de buscar el gold standard dentro de ese tratamiento. Voy a probar todas las herramientas que tenga a mi mano. Y yo lo hago con sugerir terapia conductivo-conductual para todo el tema de trabajar psicológicamente esa dependencia a la nicotina, no la adicción, dependencia, son dos cosas totalmente distintas. Y sugiero, depende del estado clínico del paciente, utilizar cigarrillos electrónicos o nicotine pouch. Depende, me ha tocado tratar pacientes con cáncer operados de cáncer de pulmón, donde tienen un solo pulmón. Y bueno, en esos casos, sugerirles utilizar como administración de nicotina los nicotine pouch y utilizar esporádicamente vapor sin nicotina para no deshabituar el gesto, la gestualidad, y que no extrañen tanto eso como para volver a fumar. Claro que eran pacientes que ya estaban fumando, con un solo pulmón seguían fumando. Ahora, como les dije hoy, yo tengo la posibilidad de poder tener al alcance mío los nicotine pouch, tengo la posibilidad de tener a mi alcance dispositivos de vapeo, que muchas veces se los regalamos a nuestros pacientes, pero eso no es la generalidad. La generalidad es, deja de fumar o morite. Y el médico les dice, y si no deja de fumar, no me venga a ver nunca más al consultorio, hasta que no me deje de fumar. Y esa es la realidad. Entonces, estamos perdiendo, como les dije, le estamos fallando a la sociedad. Nosotros tenemos un montón de antihipertensivos, antibióticos, tenemos un batallón de herramientas médicas y elegimos con qué arma atacar a cada enfermedad. En el tabaquismo nos dejaron sin balas. No tenemos más balas.
Thank you, Diego. And last question to Anders. Anders, you Swedes seem to be pragmatic, and your government, as you explained, has allowed alternatives to smoked tobacco for Swedes. Now, the question about flavours and the impending ban of flavours in vaping products, for instance, in Canada and other countries. What is your view on this impending ban, and how would you advise governments who are considering such bans?
Well, that's a good question. I think that perhaps we are giving too much credit to the Swedish authorities, with all respect. They are not as pragmatic as you think. I mean, we have reached 5.6% of the male smokers, male smoking, due to the fact that we have snus. And what we are telling from the Snus Commission, tell people the truth. You know, we are just using official statistics. We're not doing anything funny with it. We're just giving back to the people who actually pay the taxes, who pay for the statistics. And we tell them, these are the facts. So if you ask me about flavor, I think that, as we heard Clive said earlier on, I think that it's better to get people off cigarettes. And if it requires, the vaping or is flavors or in snus, I mean, it's not a big concern of mine, really. The important thing is that they get off smoking. And again, tell people the truth. You get a long way with that.
Thank you very much, Anders. A fabulous session with health experts from Brazil, Argentina, Germany, and Sweden. And perhaps we have one question to Adriana, and then we'll close for coffee.
Hello, Adriana. I have an online question for you. Wait. So, Adriana, you said that you're receiving product donations for analysis to enable you to quantify their risk, etc. But it's very complicated in Brazil because there's no proper regulation. So it's not possible to ensure that the products follow the quality standards and proper sanitary rules. So how can we ensure that these results from these studies can be more reliable if we don't have this proper regulation in place?
Né? Que a gente sabe que os produtos que chegam no Brasil, né, de forma ilegal, pelo tanto de pessoas que a gente vê usando, né? Eu trabalho numa universidade e na universidade eu vejo muitos jovens usando. Eles sequer sabem que é proibido. Eles acham, como é tão fácil o acesso, eles acham que isso aí é regulado, né? E mas eles também não sabem, eles usam isso de
Cecilia, okay. You can start again, Adriana.
Então,
This project is, these projects are arriving in Brazil illegally, and people don't know they are illegal. So, no? So,
fazendo estudos com esses produtos. Então, a gente está fazendo estudos com produtos ilegais, exatamente pela preocupação de ver que produtos ilegais são esses, né? Qual a toxicidade, qual a composição química, porque muitos desses produtos, acho que foi você mesmo que falou, pode ser feito atualmente no fundo de quintal, né? Então, isso é bem perigoso, porque você está, às vezes, usando produtos de má qualidade. Então, eu acho que o papel da Anvisa, sinceramente, eu não queria estar na pele deles, porque eles estão ali entre a cruz e a espada, porque tem a parte médica, né? Dizendo que não é para liberar, porque isso vai aumentar os níveis de
people not to make use of these projects. They're advising the government to ban these projects, and you have the users making use of these substances or products because they know that the quality could be improved if they were regulated. I think that Brazil has a very low social economic level. So people who are more well off are going to be buying good products, and the lower classes are going to be using cigarettes or using other products that are not of very good quality. So this is not a very easy solution. It's a very difficult call. I don't know if I have answered the questions. So thank you very much. Muito obrigado.
Exactly the point that Mariva also made about the lower socioeconomic groups using the worst products and the need to make sure that the product standards of those products on the market are well regulated and well tested. May I please ask you to give a warm round of applause to our panel. What we'll do is we will have a coffee break now, and then we'll come back at 20 past 12 for Konstantinos, just so that we can give our interpreters a break as well. And then we're keeping all the questions, and we will ask it in the panel afterwards. Konstantinos Farsalinos. Konstantinos is a cardiologist. He's from Greece. He's been highly instrumental in developing the evidence base for tobacco harm reduction in not only Greece and the EU, but worldwide. In fact, he's the most cited scientist in tobacco harm reduction science, along with a few colleagues. So it's our privilege to ask Konstantinos to address those issues of tobacco harm reduction science that could be most relevant in Brazil. Konstantinos, please.
So, thank you very much. Thank you very much, everyone, and thank you for the invitation. I got jealous seeing that everyone had slides, so unfortunately for you, I prepared some slides at the last moment. So, as it was mentioned previously, I think by Heino, the EU is planning to be smoke-free until 2040. And that means for all European countries to have a smoking rate of less than 5%. And this means that we have to go down from 25%. And every year in the EU, according to the European Commission, we have 700,000 premature deaths caused by smoking. So it is quite strange that we still have a problem with smoking after more than 6 decades of knowledge, because the first reports presenting the adverse health effects of smoking came from the Royal College of Physicians in 1962 and from the Surgeon General in the US in 1964. So it's been 60 years since then. Still, we have more than 1 billion smokers worldwide, and despite smoking rates going down, the proportion of the population smoking, the absolute number of smokers is going up because of the increase in the population. And tobacco harm reduction has been discussed for a long time, and this is, I think someone also mentioned it before, Michael Russell, a well-known researcher in harm reduction, who presented many years ago, so 30 years ago basically, that we can use nicotine delivery systems as temporary cessation aids, but also even as long-term substitutes, as long as we don't have combustion, as long as we don't obtain nicotine through smoking. And that's extremely important because we must differentiate smoking from nicotine. However, it's been 30 years after this, this statement, and probably 50 years after the statement made discussing about people smoking for nicotine but dying from tar, also from the late Professor Michael Russell. But today, after 30 years, we are seeing a growing, overwhelming, authoritarian and restrictive or even prohibitory approach for nicotine rather than smoking, up to the point of equating the risk of tobacco cigarettes with the risk of other low risk, in reality, nicotine-containing products that do not involve combustion. So we are mainly criminalizing nicotine instead of criminalizing smoking. And this is a violation of the risk-proportionate principle and regulation, which is commonly applied in politics for everything in our lives. And it is a clearly prohibitory agenda. And here we have a meeting in a country which has banned all nicotine-containing products besides tobacco cigarettes. So Brazil is one of the several countries, it's not the only country, where you can legally buy the most lethal nicotine-containing product, which is tobacco cigarettes, but you are not allowed to have access to the least problematic nicotine-containing products like heated tobacco products, electronic cigarettes, probably snus too, or other oral forms of tobacco, which are proven to be lower risk products. If someone understands the logic behind that, I would like to share it with me or with us in general in that debate. So the question is that science, and will it serve the purpose of properly communicating scientific facts and truth to society, and will it eventually result in a smoke-free society? I doubt it. So we need to understand the difference between becoming smoke-free versus nicotine-free, and we need to understand that there is a lot of confusion in the terms, the goals, smoking versus nicotine, smoke-free versus nicotine-free. And the main confusion is that people, but not only non-experts, even experts like physicians, equate smoking with nicotine risks. And how do we see that? We published a study in 2016 asking healthcare professionals, so they were physicians and nurses, about the knowledge and perceptions concerning nicotine, NRTs, and smoking, but also harm reduction products. At that time, we only had electronic cigarettes. So the question was the contribution of nicotine on smoking-related atherosclerosis. And as you can see, more than 80% of healthcare professionals said that nicotine is an extremely very important or an important contributor on smoking-related atherosclerosis. Exact response was given to the question about the contribution of nicotine on smoking-related lung cancer and smoking-related cancer in other organs. While in reality, nicotine is not a carcinogen, it does not cause heart disease, but the view of healthcare. Now imagine the views of the society who has no expertise in medicine or science, but the society is using healthcare professionals as the main source of information. So you understand the level of misperceptions, miscommunication and misinformation being propagated by healthcare professionals. And it's not only in Greece, there are similar studies in the US, in the UK with similar results. So, of course, nicotine, as well as the behavioral aspect of smoking, you know, holding something in your hand, the hand-to-mouth movement, experiencing the throat irritation of smoking, all these factors play an important role in dependence. But the long-term use of nicotine through, of course, pharmaceutical products, nicotine replacement therapies, has been approved by the US FDA. It has been approved by the UK MHRA, which are the Food and Drug Administrations of the US and the UK, respectively. And why do they accept the long-term use of nicotine substitutes through nicotine replacement therapies? Because, as I said, nicotine is not classified as a carcinogen. It has minimal, if any, effect in the initiation and propagation of atherosclerosis. And, of course, it is much, much preferable and it's much safer to be a lifelong nicotine user instead of being a lifelong smoker. And in reality, concerning one of the harm reduction products, electronic cigarettes, the same pharmaceutical-grade nicotine used in nicotine replacement therapies is also used in electronic cigarettes. It's exactly the same, pharma-grade nicotine. So why smoking is still a problem? Because the available medical interventions to quit smoking, or even the non-medical ones, one of which is the most popular, is quitting by yourself, fail in the vast majority of cases. So quitting by yourself without any aid has a success rate, an annual success rate of 5%. This is the most popular, but the least effective smoking cessation method that smokers are using. Quitting by the use of medications, 20–25% efficacy when you look at 1 year follow-up of smokers. Many quit when they obtain the medications, but afterwards they relapse at a very rapid pace. There is another very large group of smokers who do not want to take medications, and this has been a global phenomenon. And when scientists ask these people, why don't you want to go to a smoking cessation center or clinic or whatever, they say that they don't consider smoking a disease, but a bad lifestyle habit, a bad choice in their lifestyle. So they need to change their lifestyle instead of treating some sort of a disease. They don't consider smoking a disease. So in reality, what we have is 8 out of 10 smokers who currently fail to quit with approved methods, either because the methods fail or because they don't want to try these methods. And in order to provide them with an additional tool to quit, we need to understand what is harm reduction. Tobacco harm reduction is nothing more than any type of harm reduction that we apply even in our daily lives. And what are common examples of harm reduction that we apply in our daily lives and they look pretty much common sense? Well, it's the use of seatbelts, because it does not eliminate the risk of being injured or dying in a car accident. It just reduces the risk. The only way of eliminating the risk is not to enter a car. Helmets, they serve the same purpose. I don't think that Brazil has banned the use of motorcycles because they are more harmful than cars. And I don't think that any country has banned the use of cars or motorcycles for recreational purposes, like, for example, taking your family and going for a vacation with your car or going and having fun with your motorcycle. No country has banned that, despite these things carrying some risk of being injured or dying in a car crash. But society is not about risk elimination, it's about a reasonable approach and regulation to reduce risk in any of our daily activities. In fact, even medicine is harm reduction. Medicine as a science, medicine as an approach to the patient. And why is medicine harm reduction? For a simple reason. Because only some infections are cured, which means that we completely eliminate the disease and there is nothing there. In almost all other cases, the diseases are treated. I don't know how you're going to make the translation between cure and treatment, but I'm explaining it below. What does it mean when we treat a disease? If someone has a heart attack, a myocardial infarction, then
for the rest of his life, some part of the heart is going to be dead. It will never be revived. We will never reverse the process of the heart attack. He's going to be a patient with heart disease forever. So we cannot cure the heart attack, but we treat the heart attack. That means we reduce the harm caused by this disease, we reduce the symptoms, the adverse consequences and the decline in quality of life, and we reduce any sort of inability coming from this or from any other disease. Well, these are basically the definitions of harm reduction, because we do not eliminate the disease, but we reduce the consequences of the disease in our daily lives. So medicine is, for the most part, a harm reduction science. And many people discussed about the Swedish experience, the only country in Europe who is basically has managed to achieve the smoke-free goal set globally of 5% or less smoking rate. The smoking rates have been going down over the past 40 years at a very rapid pace, and it has happened even more rapidly among men in the last few years. And now the rates are by far lower than anyone else in Europe. But the interesting thing is that while smoking rates are going down, some other products containing nicotine, like snus and nicotine pouches, are going up. And these are quite late figures from 2012 till 2022. But if you go further back, you will see that the major transition from smoking to the use of other nicotine products that do not combust tobacco was very, very impressive during the 80s and the 90s. So in different age group among men in Sweden, the smoking rates went from 30, 32, 33% during the 80s to less than half that, especially in young age groups, during the 2000s. And snus use increased at the same basically rate that we saw the decrease in smoking rate, we saw the increase in snus use. And as a result, Sweden has a very high overall tobacco and nicotine use in men, but most of them are not using combustible nicotine products. I mean, cigarettes, they are using non-combustible products. And if you look data from the Eurobarometer 2020, you see that smoking rate is very low. In 2020, it was 6.4%. Now it's probably 5%. But total nicotine use rate, Sweden and the EU, the same. So Sweden has not reduced overall nicotine intake, but they have considerably reduced smoking and obtaining nicotine through smoking. What's the result in Sweden? This has been happening for 40 years in Sweden. It's nothing new. Well, the result is that Sweden has the lowest death rates by far from heart disease, lung cancer, cancer in other organs, even all-cause mortality attributable to tobacco compared to the European Union. The lowest, I mean, if you compare it to the average, 2 to 3 times lower compared to the average EU. So we have proof of concept of a country where harm reduction was allowed to prosper. I mean, the officials did not really support it, but at least they allowed it to be available and for people to use it. And we already have epidemiological data on the results of such an approach. And Sweden has not only eliminated smoking, but without decreasing nicotine intake, they have decreased their death rates from smoking-related disease. And the other issue that has been used mainly as an argument against harm reduction products, it's quite common globally, I suppose also in Brazil, is the issue of flavors. So one of the main arguments is that flavors have been marketed with electronic cigarettes mainly as a method to attract kids and to create a new generation of nicotine addicts. That's the common scenario. That's what everyone is saying when they discuss about electronic cigarettes or harm reduction products. Well, is that the case? Well, it's not. A systematic review of 104 studies in adults, which was published in 2022, so last year, found that there are 2 factors that are associated with smokers wanting to use electronic cigarettes. That is high nicotine concentration and access to a variety of flavors. They called that higher abuse potential and appeal of e-cigarettes for adult, not kids, adult, current and former cigarette smokers. And what does abuse potential mean? Basically, it means appeal. It means, and I think everyone understands it because it's common sense, it's nothing about science, that when you want a smoker to stop using tobacco cigarettes and to use something else, the product, the alternative product, needs to be attractive. Smokers need to like it. If you try to create an unattractive, a horrible, a bad taste in a product, well, no one is going to try it. No one will want to use it. So you're making a useless product. There are many regulators globally who have an approach of making e-cigarettes less appealing, with less variability, with a bad taste, a bad smell. Well, who is going to use that? I don't know if any one of you would like to eat something that tastes horrible, or would like to drink something that tastes horrible, even if you are 75 or 80 years old. You know, my mother, at the age of 75, she had been a smoker for 50 years. She was smoking menthol cigarettes. At some point, she wanted to quit trying electronic cigarettes, and she's using cappuccino flavor, and she is using fruit flavor. She's not using menthol, she's not using tobacco. She's 73 years old. She's not 20, she's not 15, she's not 25, she's 73. She has never used a tobacco or menthol flavor despite being a 50 years menthol cigarette smoker. So, you know, it's in the human brain, irrespective of age, that people like to try and use things that they like. Things that have a very nice smell, a very nice taste. It happens to everyone, not only kids. So, in reality, what the authors of this study concluded that higher nicotine concentrations and the availability of a variety of flavors in electronic cigarettes might facilitate complete substitution for cigarettes. So if you want electronic cigarettes to serve the purpose of being a smoking substitute, you need to have appealing products. That means deliver enough nicotine so that the smoker is satisfied and have a very pleasant smell and taste and general experience. Because as Milton said, people smoke because they like it. If we want to find them to therapy product, we need to like that product too. And a study that we did in, among US vapers, all of whom were adult vapers, many were former smokers, the majority of them, we found that the vast majority of them were using non-tobacco flavors. Here is the tobacco flavors. And from the e-cigarette use initiation, the time they started using e-cigarettes, to the time of the survey, which was an average 40 months after initiation, there was a transition from tobacco flavors which were low, even at baseline, but went further down, to especially dessert, pastry, bakery, so sweet flavors, but also fruit flavors. And there's another study which followed up vapers for 5 years, and they wanted to see how they changed their flavor preferences over the 5-year period of follow-up. So that was a longitudinal study. And the preference for tobacco and menthol decreased to almost half of what it was at baseline. The preference for fruit remained stable, but for sweet flavors, it increased, it almost doubled over the 5-year period. And an important aspect is that almost all of them were using more than one flavor on a regular basis. And only 11% said that tobacco was their preferred flavor. And all of them were adult vapers. Adult vapers. And that's why the researchers said in the press release that, yeah, maybe teens also like flavors, yes, but it's also adults who like electronic cigarette flavors. So this is not a valid argument unless someone tells you that his preference is to eat something which is tasteless and smell something that is flavorless. So what regulators and politicians should do. You don't need to be Einstein. You don't need to have a high IQ. You just need to do whatever you do with all regulations concerning our daily lives. And what do politicians and regulators do for all aspects of our life? They follow a risk-proportionate regulation. The higher the risk, the stricter the regulation. The lower the risk, the less restrictive the regulation. What is happening in Brazil? Less restrictions on the most lethal product, tobacco cigarettes, because they are available, and they are available legally. Strongest restrictions ban on the sales of all tobacco harm reduction products. It makes 0 sense. It makes 0 sense. And you don't need to be a scientist to understand that. You just need to be a person using critical thinking and common sense, nothing more. What does risk proportional regulation mean in reality? It means that we should ensure product quality through legislation, but the legislation should not be complex and expensive, otherwise you will create a black market. We need to promote harm reduction products, promote them to intended population, that is smokers and former smokers. We need to maintain a competitive advantage for these products compared to smoking. So what Brazil is doing is that they eliminated any competition for tobacco cigarettes. You know, tobacco cigarettes are available in the market and there is no competitor. All the competitors are banned. And interestingly, the less harmful products are banned, not the most harmful product. Of course, we need to promote research and monitor the population use, avoid any unintended consequences like use by non-smokers. And of course, harm reduction products must be appealing. If smokers don't enjoy using an alternative product, they will just keep on smoking. It's very simple. If smokers see that an alternative product is much more expensive and they have less access to it, let alone ban it, they will not have any motivation to try an alternative product. Well, these are not any sort of novel ideas. It's what politics are about, and it's what regulators and politicians do about everything. So it's reasonable, risk proportionate, realistic, and of course, different from the regulation of tobacco cigarettes. Well, in Brazil, the regulation for harm reduction products is different from tobacco cigarettes, but the difference is that they have banned it without banning tobacco cigarettes. So in a realistic world, because we don't live in a utopia of the ideal society, in a realistic world, public health benefit is not about finding the safest option. Okay, let's decide tomorrow that no one is going to smoke. Who is going to achieve that? None of the smokers are going to just stop smoking tomorrow. So we have the safest option. For example, nicotine gums, nicotine patches, very safe. No smoker wants to use them. Even those who use such products, they fail miserably. So finding the safest option can be both unrealistic, but also not appealing for smokers. So that's not the solution. The solution is to strike the right balance between low risk, which does not necessarily mean zero, like our daily lives, which are not zero risk, and high popularity for such products and such an approach among the targeted population, that is smokers. Nicotine, in a non-combustible form, can be a very effective harm reduction tool because by itself, nicotine is associated with minimal risk. So if we add this approach, if we add harm reduction to the already established, currently approved smoking cessation methods, I think that the only thing that will happen is that we will accelerate the decline in smoking. Thank you very much.
Thank you very much, Konstantinos.
Are there any questions that I may address or not?
What we'll do is we'll ask Mihaela to speak, and then the two of you will answer questions.
Thank you.
Thank you so much, Konstantinos. and I think the local TV news is also chasing you. But I'd like to then ask Professor Mihaela Răescu, who is a professor of dental medicine at the University of Bucharest in Romania, to address one of the lesser known but extremely important aspects of tobacco harm reduction, and that is the benefits of tobacco harm reduction in oral health. Professor Mihaela.
Hello. It's okay now. Thank you very much. So thank you for invitation. Thank you for your nice presentation, Delon. I can continue the examples of Dr. Farsalinos about what kind of alternatives we are trying to find all the time if we need them. So just I saw the example with the motorcycles and the risk reduction. So if I think just a little bit about sugar, that we found some sweetener and we can change the place of sugar in case we have diabetes or something like this. And also we can try alternatives, for example, for breastfeeding, even if we know the breastfeeding is the best. We need sometimes in some situation to change this breastfeeding milk with some powder milk. So we always tried to find some alternatives if we needed them. In oral health is something very interesting because every time we think that the first place where the smokers might have some, let's say, changes, it's exactly in the oral cavity. Usually we can find some discoloration, halitosis, everybody can see a carie, everybody can see if we have a missing tooth or something which is very, very visible. So in oral health, it's quite easy to note every changes, and all the people around us might see exactly what I'm telling you. So usually in oral health, we can find the differences between a very nice and clean and healthy oral mucosa if you are a non-smoker and a healthy person. And also we can find the difference if you are a smoker and a cigarette smoker especially. I made some let's say, research, and I made some studies about how we can change the oral health aspect. I mean, if we can switch, I mean, if the cigarette smoker is switching the cigarettes with some other alternatives, let's say a heat-not-burn product or some other nicotine products without burning. So I saw that the patient may have some good changes in their oral health. That means I found after 9 months of switching that usually the bacterial plaque is less. That means less gingival inflammation, and also that means less halitosis, and also that means a better health in the oral cavity. Also, if we want to make a treatment with implants, and let's think about sometimes every one of us and or somebody from our family might need an implant treatment because this is the life. Usually, if the patients are smokers, we have to inform them that in the period of osseointegration, that means immediately after the first step, meaning surgical step, they have to quit smoking just at least for 3 months. So this is very difficult for somebody who wants to, who tries to quit smoking and it's a very long time smoker. And we have to, I mean, it's much easier for them to tell that they have an alternative. Otherwise, they will say, I cannot quit smoking in this period. And also, that means that the implant treatment may have maybe the healing process after surgical intervention is affected. So that means also that the result of the implant treatment may be a failure. So we have to inform the patient about the alternative they might have when they need a treatment with implants, for example. Otherwise, it is easy for us as a medical care to inform the patient and to explain them about the tobacco harm. You know, if you are a smoker, and I saw in my dental office, if they are a smoker, they are coming to doctors and they feel that they are okay. It is something about it is something about their behavior, their entourage, their lives. So we cannot tell them this is something bad. But if you take a camera, a video camera, and you show them exactly the aspect, for example, of their oral mucosa, or you show them the aspects of, let's say, how it is a smoker tongue and non-smoker tongue, or how come the oral mucosa vascularization is changing after the patient will switch from another alternative product after 9 months. Maybe he will try to understand that you have good intention, and after that, the medical advice is always something that the patient will trust a lot. So, I think usually the doctors, they don't speak about smoking. They don't speak about the effect of smoking. They are a little bit afraid to say about this, but they can see very easily the effects of smoking. So I think the most, let's say, responsible part of our job is to make the patients to take a very good informed decision for their lives. So every time when you have a patient and he said, okay, I'm a smoker, I tried many times to quit, as also Dr. Farsalinos says, it is difficult to explain them that it's bad, but usually the facts are exactly what might convince the patient. So it is really, it is quite, let's say, improbable that every doctor will show some pictures to compare, some comparative pictures in their office to show them the difference between oral health smoker and non-smoker. This is quite improbable because usually the dentists, let's say, like this, they treat exactly the problems. And most of us are going to the doctors when they really need it. This is the most, but at least we can advise them and we can inform them that they have some other alternatives, at least for the period of dental treatment, for the sake of the success of the treatment and for the sake of their, let's say, pocket in the end, because it's much more expensive to have long-time treatment, dental treatment. I'm speaking only about dental because usually we don't think too much about this, but in the end, when we meet a dentist, then we understand that it was better to meet them before. I mean, earlier than the moment that we are going there. Otherwise, in Romania, the harm reduction is quite unknown. I mean, the term is quite unknown. Usually, the doctors are not speaking about this. And even if they know some alternative, even if they use the alternative, they don't explain to their patients this alternative. So, because usually they prefer to leave the patient to have their choice. But an informed choice is always a better one comparing with, let's say, a choice that you are doing because you like something or you prefer something. So this is the reason that that usually we don't really explain to the doctors what's happening. And also, like from, let's say, from 2 weeks, not 2 weeks, for 1 inform doctors. So that means the tobacco harm reduction is also it's getting more and more in the dental area. And also about cessation, workshops with doctors. Just the Dental Federation makes these informative meetings. And this is part on a program for encouraging cessation and encouraging use the cigarette smokers to find an alternative if they cannot quit. So, in my opinion, as a doctor, I think we have to know first, we have to be informed ourselves, first of all. And after that, we might explain to, we can explain to our patients exactly, and we also can present them the alternative for cigarette smoking. So if you want to ask me something about, I don't know, I just wanted to point some let's say, key words about harm reduction and dentistry, because we are somebody, the dentists are the one that all of us need sometime in our life.
Mihaela, thank you very much, and I'll ask Konstantinos to come back to the front, and then we'll do a quick panel discussion with two very special people. I hope that you, Mihaela, thank you. First, just a question to Konstantinos, please.
Yes.
Flavours. In your piece, you argued for a different regulation to smoke-free nicotine alternatives to tobacco regulation. Prof. Adriana spoke about the banning of flavours in cigarettes in Brazil. And you said there should be different regulations.
That's a good argument, because most of the regulators globally are using the example of cigarettes and the flavor ban, which was the correct way to move forward for cigarettes. And they want to apply the same approach for electronic cigarettes. But they're making a fundamental mistake. Cigarettes were a consumer product with no public health benefits or any prospects of a public health benefit. Instead, it was a public health disaster. Electronic cigarettes are products with a strong public health benefit, that is, substituting for smoking. So they are two very different products in terms of the reasons why they exist. And the second, of course, is the vast difference in the risk profile of the two products. So even if electronic cigarettes were just a consumer product, they have a much different, a much lower risk profile compared to smoking. But that's not only that. We would have a different discussion if electronic cigarettes or other harm reduction products were simply a consumer product. We are talking about substituting for smoking. This is a product which is beneficial for society. Of course, there are some potential unintended consequences, and that's why we propose that this product should be regulated and not left in an unregulated, uncontrolled market. But what is happening in countries where these products have been banned is that they have only created an illegal, illicit market and nothing more. And when you have an illicit market, as a regulator, you have no control on quality, you have no control on marketing tactics, you have no taxes, of course, no income from the sales of these products because they're being sold under the table, and you've done nothing, basically. You've just created something that you have no control on. So the prohibitory approach has never worked for products where there is demand. It's as simple as that. So it's better to control it, that means regulate it, rather than ban it and have no control on a market that you are creating illegally.
Konstantinos, last night I heard you explaining to some of our South American friends about the evidence that you've built up also on flavors, and I just want to make a quick pitch for Konstantinos' own website, e-cigarette research, where he published e-cigaretteresearch.org, where he published a multi-dimensional review on flavors for use by stakeholders to submit to their regulators and their governments. And this is also published on thr.net. Any other resources that can be used by stakeholders in Brazil and Latin America?
it up about the effects of flavors on smoking cessation. And we are seeing, and we are publishing the study that I presented as a slide concerning the patterns of flavors used among 70,000 American vapers. It's currently under review. And we have in the discussion section several references to studies showing that flavors play an important role in smoking cessation for those smokers who would choose electronic cigarettes. And as I said, that's common sense. When you want to use something, you want to have a positive experience about it. So the approach of making e-cigarettes horrible because we don't want people to use it is an approach against smokers, because a smoker who doesn't like the product, he's never going to use it as an alternative to smoking. He'll just keep on smoking. So it makes zero sense, not only from a scientific perspective, but also from a common sense perspective.
Understood. Mihaela, you said something which was rather worrying, and that is that almost no doctors in Romania, and for that matter probably worldwide, speak to their patients about quitting smoking, and especially the ways in which they can do that, apart from nicotine replacement therapy. How can we improve communication between health professionals and their patients on cessation?
I think usually doctors are taking care about what the science says. And because they don't usually, because in congresses, there are few people who are speaking about smoking, except for the harm caused by smoking. That means we need a lot more people to explain that we have alternatives, to present the alternatives. But usually they explain also in congresses, we can find also only the harm-related smoking. So I think we need to make a team with the Federal Dental International Federation and promote this workshop and this discussion about the alternatives, about the results of the research, because the only argument that we have in case somebody is saying the alternative is not good is the result of a very good and well done research. And we need also some long-term researches, because usually we have short-term research for 1 year. I read a lot about what happened in the research field, and I saw most of the researchers are exactly short-term. I mean, meaning 1 year, 1.5 years. Myself, I did some research for with a duration of 1 year, and I think a longer-term research will have more, let's say, relevant results, and we can have more, let's say, conscience, and we can be more experimental. We can have more arguments when we explain what's happening, if we see exactly with the research as I did, because what I'm saying about less gingival inflammation, less bone resorption in case of implants, about a better oral mucosa, better health oral mucosa, about less halitosis, and also less problems, gingival problems. I saw it in my researches, and with my colleagues, I made some researches also in healing process, about healing process when we make some surgical intervention like extraction, and something which is very used, it's very popular, not exactly popular, but very frequent in our practice. So if we do some more research and we have more arguments, then the doctors will be more open to inform themselves, and also they will tell, look, I heard in that congress that it is better to use this if you cannot quit. So this is the nicest example about how a doctor can explain to a patient, look, I know that now somebody made a research about this, and we saw that this is a better idea to use this or this product. It's exactly like when you go to the physician and they say, okay, you have this problem, medical problem, you can use this medicine, even if the medicine is used for this disease, maybe the medicine may have some other side effects, but in the end you will use it at least for a short period of time to be sure that you will be healthier in terms of changing the moment that you were going there because you didn't feel well. So this is my idea.
Thank you.
We have to encourage the research, to encourage the communication, to encourage the doctors that are making the research to communicate and to explain, and not to be afraid that somebody from, I don't know, one ONG or something will say, okay, you don't have to speak about that.
Mihaela, thank you very much.
Let me give Delon a different approach. I don't think that we don't have enough research. I mean, yeah, research never stops. Questions are always exist, and we need answers. But it's not a problem of lack of research. I'm going to give you some characteristic examples of a different approach that has been used by physicians in the past. I mean, first of all, the problem in the debate of harm reduction is highly political and less scientific. And when you are engaged as a scientist in a political debate, what is very commonly happening in conferences like those mentioned before is cherry picking. So it's a well-known phenomenon in science, mainly caused either by confirmation bias, which is unintentional cherry picking, or it may even be intentional because you have some political views that you want to further propagate and support. But there is a lot of cherry picking. We have a lot of research on the lower risk potential of all these products. Of course, we'll need more, but needing more research is not an argument for physicians not to support harm reduction. You know what? They've been approaching harm reduction for many diseases without any research at all. I'll give you a characteristic example. A doctor who sees diabetic patients will always advise this patient to stop using sugar, and if they need something sweet, to use sugar substitutes, like, for example, aspartame, stevia, sucralose. There are no long-term studies showing that the long-term use of aspartame, stevia, or sucralose will improve the outcome of a diabetic, will reduce his risk of developing complications, will improve his quality of life, or will increase the life expectancy. But doctors are doing that. Second, they are giving advice for non-medical products. All these sugar substitutes are not medical products. When you advise a patient to eat less meat and to eat more vegetables, they don't subscribe apples and oranges. They just give a lifestyle advice. When they tell them to do more exercise, they don't prescribe 100 steps in the morning, 100 steps at noon, and 100 steps in the evening. They just give lifestyle advices for non-medicinal interventions. And that's what the harm reduction products are too. They are consumer products associated with a lifestyle change. And we do have a lot of evidence, and I think that every reasonable person accepts that these are harm reduction products, these are reduced risk products, and then you shouldn't feel ashamed as a physician of giving this advice because they have not been approved as medications. Because you give advice every day to your patients for to use products or consumer products that are not available as medications or approved as medications. And you do it even though there is not enough research.
Well, we've heard it from the mouth of a cardiologist and a professional health. A big kind of applause for them. Mihaela, thank you very much for joining us. We wish you were here next time. Thank you, Konstantinos. Thank you very much, Mihaela.
Just a second, if I might say, it is very true what Dr. Farsalinos is saying. As I said in the beginning of my presentation also about sugar and diabetes and everything, but the problem with the dentist, for example, I'm speaking only about this part of the doctors. They don't know about it. I saw it myself when I went to Congress in my country. If they are not informed, they cannot explain to their patient. And it's very true that the patient will always listen to the doctor's advice. Thank you.
Thank you, Mihaela. On that note, I would like to ask another warm round of applause for Professor Răescu in Romania and Konstantinos. Thank you, Mihaela.
Thank you.
Thank you. Our next speaker, I'm very honored to introduce, is Dr. Kgosi Letlape, the former president of the World Medical Association, which is like the mothership of physicians. He's also the former president of the South African Medical Association and the president of the Africa Harm Reduction Alliance. When Nelson Mandela wanted to be briefed on harm reduction in HIV/AIDS in Ghosi's home country, South Africa, he called him to give him a personal one-to-one briefing on that. And a big part of Ghosi's career was to work and advocate for the access to antiretroviral therapy to HIV patients. Kgosi, it's a pleasure to welcome you, and we are looking forward to hear your insight.
What's on the paper? What am I supposed to talk about? It looks like there's something about the role of health professionals. You know, it's a very difficult thing to talk about. And basically, Anders is here. You are ashamed that you are a medical doctor on this subject. And I'll tell you why we have to be ashamed that we're medical doctors on this subject. Because the sum total of teaching about tobacco and nicotine, it's not in the curriculum. You know, most of us can show you the symbol for glucose, the symbol for ethanol, but if you put the symbol for nicotine, 99.99% of doctors would not recognize it. And that's basically the sum total of the teaching about tobacco. And what we taught, it should actually not be called teaching. We are indoctrinated about tobacco. And the indoctrination is fairly simple. Tell your patient to quit or die. Tobacco is bad for you. And that's the sum total of the indoctrination that we get. And this is one of the few subjects where, as physicians, we are licensed to be unprofessional. You know, the question you ask after all the training to a patient that comes to you, and it's part of taking a history, we don't ask them whether they use nicotine. We ask them whether they smoke or not. And then, once they say they smoke, we advise them to quit, or they're going to die. And that's the sum total of the knowledge that doctors have. Why do I say it's a license to be unprofessional? It's because on all other subjects, we taught that it should be based on evidence. We're given the evidence. You know, how to diagnose a diabetic, what advice to give to a diabetic, how to diagnose a heart attack, how to diagnose hypertension. But when it comes to tobacco, there's no teaching. There's indoctrination. Now, there's a second thing that is not taught in medical school, and that links to our attitudes about tobacco. It's ethics. It's not taught. You're expected to know. You're expected to know that you put your patients first. You're expected to know that you don't experiment on patients. You have to do what you trained for. And if you do not know, at least have the decency to tell the patient, I don't know on this, I will research, I will come back to you. Or, I don't know on this, but I know someone who has studied this, who manages this, and you refer them. But with tobacco, we have a license to be unprofessional. We have a license to be godly. We have a license to be religious and say quit or die. We become dishonest. We become unethical. We're not saying, this I was not taught in medical school. This I do not know. There's a cessation specialist, maybe go and see them. There's a behavioral specialist, maybe go and see them. There's a lifestyle coach, because this is a lifestyle issue, go and see them. No. On tobacco, we have the authority as the lieutenants of God to tell patients to quit or die. We never do it on many other subjects. So until this is taught at medical school, it's embedded in the curriculum with proper content, we will never come right. Just like with ethics. Ethics are not taught. That's why doctors have become commercial. We have become retailers. We sit in front of a patient, we tailor the treatment according to the size of your wallet, not your medical needs. And we're comfortable. Why? Because ethics is not taught. You see, some of the things that are done in medicine are done on a simple basis of monkey see, monkey do. And ethics is one of them. You know, this was the CEO of the World Medical Association. This was the chair. They never ensured that this thing was in the curriculum. This was the president once. But we've never ensured that these things are in the curriculum. So ethics operate on the basis of monkey see, monkey do. So if you had an ethical mentor who never abandoned patients, who worked till late hours, that's where the values come from. But when you have the leaders that we have today that abandon the public sector, take a salary and run a private practice, that's the ethics that you learn. That you can abandon patients, that you don't have responsibility to patients. So this is an area where a lot needs to be done until we incorporate it into the teaching, and it is based on evidence, it is based on science, the way we learn about the Krebs cycle. It'll never come right. So the issue saying doctors are ignorant about nicotine, it's true. The only thing we know is what we taught. We're just simple human beings. We're great technicians based on what we taught. And what is not taught, where it is indoctrination, we pass on the indoctrination. And then there's a buy-in from the politicians. Now, one of the ironies about the situation in terms of doctor teaching is the bad behavior of the industry in terms of lying in 62, lying in 64 about the link between combustible tobacco and cancer. But sadly, and public health and others did a good job of getting the tobacco industry to account. But sadly today, public health has taken over from where the industry left off in terms of lying to the public. So there's a role reversal where public health is now being economical about the truth about nicotine. All the things that people have known. You know, people that have said the problem is not nicotine, but now suddenly we're lying. Nicotine is the problem. We're now not looking for a smoke-free environment. We're looking for a nicotine-free environment. And that's why we're lying. We're supported by government. And as I've said before, you know, one of the key issues is that all of us are potential addicts. You know, and the problem we have with tobacco is that the smoker, people who smoke, are addicted to the nicotine. The government are addicted to the revenues and taxes that they get from tobacco products. The companies are addicted to the profits they make from tobacco products. So originally in 2013, I had those three addicts. But there's two more to be added. Public health specialists are addicted to their rhetoric and the PhDs that they have from being anti-tobacco. And they can't see the woods from the trees. Now, they are on a bandwagon where they are not anti-tobacco anymore. They are anti-people who smoke. And we need to call it for what it is. And I think for some of us who are THR advocates, we could also become addicted to being THR advocates. And somewhere, we need to meet each other halfway. I wanted to ask Konstantinos a question about flavors and as to whether disinformation, if we dealt with the misinformation and disinformation, would we need the incentives of flavors? You know, because disinformation has a really corrosive effect. If you look at what happened during COVID, even when people had information about whether vaccines might help or not help, there are people that didn't want to take the vaccines because of disinformation. And you had governments having to give people incentives to be vaccinated. You know, you'll get a rent-free room, you'll get this, incentives had to be provided. So when you have disinformation, unfortunately, you get to a point where you need to provide incentives for people to overcome the disinformation. And as the disinformation gets stronger, there will be other incentives that you need to provide beyond flavors for people to do what is right for them. So we need to find a safe space where we can come into a room and differ and be able to create a consensus. So the last thing that I will leave with you is that, or two things that I'll leave with you, that what is important for people who smoke is access, availability, and affordability, so that people can make a choice. And lastly, in the words of Madiba, if he never provided leadership, that if you need to make progress and you have an enemy, the only time there'll be progress is if you're willing to sit across the table from the enemy, talk to them, and find a consensus. And until we get rid of Article 5.3, we will not make progress on this important thing.
Words of a wise man. Thank you very much, Kgosi. We have made an effort to make sure that all the European and African speakers have a counterpart in Latin America and South America. And it's now our great privilege to introduce to you from Mexico, Dr. Jose Alejandro Chavez, who is a cardiologist. I just want to make sure that he's online. Yes. Hello, Jose. The floor is yours. We are very keen to hear about your view on tobacco harm reduction and your field of specialty in cardiology.
Thank you, Delon. It's a pleasure and honor to be here with all your medical stars, talking to all the subject in cardiovascular risk. As I will show you in a short, one of the main cardiovascular risk still in Mexico is smoking, and it's very hard to lessen this. My disclaimer, I am cardiologist, I am not a smoker, nor I am a vapor, I have no connection with the tobacco industry, and my opinion is the following presentation follows to my professional background, my experience, and the clinical basis that I have got over the last 4 years. First of all, I would like to show the risk factor in myocardial infarction. In a prospect study in all these hospitals in Mexico, it was 63%. In a protocol that I made in the last 5 years, 58 of my patients smoke, and then they were with a heart attack. This is how can we approach to the cardiovascular complications for smoking, which is very simple. There is only 3 phases. One, brain, which runs from transient ischemic attack to frank stroke, heart, from angina unstable myocardial infarction, and heart failure. Peripheral arterial insufficiency, which runs until the gangrene of the limbs. Having said that, I'm going to show you one of the most interesting journals that I have got during the last years. Here's the first in what it was pointing the gun for smokers. In 1956, the American Association pointed that cigarette smoking was harmful for cardiovascular disease, and they established the relation between the number of cigarettes smoked by day and the amount of mortality. In this paper, there was classified that according to the number of cigarettes smoked and the age. Obviously, the more you smoke, the more you have the probability of having a heart attack. The results show that mortality between 2 and 11 times higher in the group of severe smokers. Then, a recent paper shows that cigarette smoking may produce heart failure. Here are one of my patients. He has dilated cardiomyopathy and he has a strong smoker. Here can you see an echocardiogram, dilatation of left atria. The left ventricle has a very bad movement, and that's what all see at the final step of a smoker. Okay, in this paper, we saw a linear relation between a product of a laboratory sample, which is peptide. This peptide, which is called natriuretic peptide, has the ability of increase when the left atrium develops. And this is caused by cardiac insufficiency in heavy smokers. Okay. As I told you, smoking is known as a risk factor for atherosclerotic cardiovascular disease. The association between smoking and heart failure was unknown until this paper, and both the frequency and the load of tobacco generates an increase in left ventricular mass, lower ventricular compliance, higher levels of natriuretic peptides, and higher incidences of hospitalizations for heart failure. Then the Jackson study in Afro-American person showed that smoking was associated with 2 times risk of ischemic heart disease, and this particular parameter, which is very important, calcification of coronary arteries. And for last, in heart, the ranking from the last 30 years, what is all about smoking and the risk. Although the burden of ischemic heart disease caused by smoking has decreased nearly 80% in most countries or regions, in the last 30 years, it's a very important risk factor to consider in countries with low or middle income economies, especially among men and the elderly. Therefore, there's a need to reduce the burden of coronary heart disease, especially in regions with a high rate of ischemic heart disease. And now another field, which is cerebral vascular disease. If we see the first papers, all of them conclude that smoking is a bad habit for brain, that is very, very heavy risk for that. The risk is mainly in the female sex. It doesn't matter the age, and it has the major events neurological, which is a stroke. Now, these pictures were very aggressive and very sad, which is the third field that is damaged by smoking, which is the legs. The legs are a very strong target for smoking, mainly through the Buerger disease. All these pictures are taken from patients which have a heavily habit of smoking. The first of them was in 1952, but you name it. The last, for example, according to the all the arteries in the body, mainly in the lower limbs, as you see, smoking is the heaviest risk factor. And this is a picture made by my daughter, and I would like to make a short commentary. Within stopping smoking, 1 year after quit smoking, the risk of myocardial infarction decreases to almost a half. 5 years, the risk of stroke is the same as a person who never smoked. 10 years after quit smoking, the probability of lung cancer decreases to a half. 15 years after quit smoking, practically the risk is the same as a person who never smoked. So this have to put in order. Let's have to say diagnosis. Where are we? Well, there is habit smoking. There are toxic substances in tobacco smoke. It is important the frequency and time of consumption, poor strategy to tobacco suppression, and relapses into smoking. These factors, I'm going to point two of them, which are very important. Substance within the tobacco, but only when it is heated, and poor strategy to abandon it. What is nicotine? It's a drug, stimulant, highly addictive, general chemical change in the brain found in tobacco. One question: if nicotine is harmful, so why do people continue to use nicotine-containing products? Let's see this diagram. These are the neurotransmitters, which are increased with tobacco and smoking. They come to the brain and they make new neurotransmitter. This neurotransmitter travel all the brain and make it a dependence. And this is the cycle. One starts and continues smoking. Then we have the false neurotransmitters. There they do their toxic function, and the cycle goes on. So there is to focus on the toxic substances and the poor strategies. You name it the strategy that you want, and at the end of the year, only 5 and 10% are quitting smoking. The other continue to smoke. At this point, the ideal is not to smoke, but one question is vaping. This is a life-saving product. Why is that strategic? When we smoke, the combustion that is made by the heat contains more than 7,000 toxics and harmful substances to health. This decreases drastically when we talk about other products. For example, electronic cigarette or vape compared with traditional combustion cigarettes. You can clearly see that there is a lot of products made of combustion which are not in the electronic cigarette. It was made in L'Hôpital de France de Paris, where they compare and they made points by any substance. For example, Traditional smoking, they found 100 points, which is highly toxic. Tobacco warmer, 23 points, and vaping, 1 point. As you see, there is a huge difference in favor of vaping. This other protocol, which is very important in women which have the necessity to quit smoking, they began to vape, and they were controlled by endothelial function. The endothelial function is the measure that we can see the vasodilatory effect of one substance. According to this, they put to vape women, and they measure the vasodilatation in the forearm artery. They show that within 3 weeks, changing to tobacco cigarettes to electronic cigarettes, primary women show significant improvement in endothelial function, that is, in vascular health, one more or more from 1 month to another month. The key message is e-cigarettes have the potential to benefit adult smokers who are not pregnant if used as a complete substitute for regular cigarettes and other tobacco products for smoking. E-cigarettes are not safe for youth or period. Young adults, pregnant women, and adults who are not currently using tobacco products. Although e-cigarettes have the potential to benefit some people and harm others, scientists still have too much learn about the effectiveness of cigarettes in helping adults quit smoking. If you never smoked or used tobacco products or cigarette, please don't start. Well, period. Conducting additional research can help understand the long-term health effects. Okay, everything is okay, but here is the black flea. As already has mentioned, the flavor is important. In the US, a bunch of adolescents and teenagers put instead of flavor vitamin A. As you will know, vitamin is practically oil. Just imagine put oil in your lungs or your bronchi. What happened? And mortal pneumonia. And it was EVALI, which means electronic cigarette or vaping products are associated with lung injury. The problem is that it was only by vitamin E and other substances like T-zeta-T. There is also some manifestations of EVALI, but these are completely not the truth. These are inspecific. This can confuse with bacterial pneumonia. So I don't want to make to the devil that EVALI can overcome and can stop the use of vape. Then what? Okay, don't believe me, but I'm going to show the papers and the bibliography. The Cochrane Library is the largest library all over the world. It resumes and it has the possibility of learn every and all of the latest literature. What do they conclude at the end of the day when they saw it? Cochrane said that there is high evidence that nicotine e-cigarettes are more effective than traditional nicotine replacement therapy in helping people quit smoking. They found the strong evidence that the cigarettes, also known as vapes, help people to quit smoking better than traditional nicotine replacement therapies such as patches or chewing gums. And at the end of the day, Cochrane Library finds high certainty evidence that it is very useful to stop quitting. According to this, there was 78 studies representing almost 33,000 people. And the result is that the use of electronic cigarettes increases the smoking cessation of smoke. It considers reduction of recidivism in tobacco use, ranks above nicotine replacement therapy, which is the current gold standard for the pharmacology management of smoking. And the key message is this. According to this Cochrane library, there is high certainty evidence that electronic cigarettes with nicotine increase quit rates compared with nicotine replacement therapy. There is moderate certain evidence that e-cigarettes with nicotine increase quit rates compared with e-cigarettes without nicotine. They did not detect clear evidence or harm from nicotine e-cigarettes when used to quit smoke. And of course, of everything in medicine, it is necessary longest and follow protocols to be sure that and for all that vape is safe. That's all my talk. I think the coins in here. My personal point of view is that vaping is much lesser. It's harmless for heart and for the arterial base. So the coins in there. I am here to discuss all the questions and to serve you. Thank you very much for your attention.
Thank you, Jose. Thank you. I'm going to pass a microphone to Kgosi. And Jose, thank you for your exposition in detail of heart disease and the potential benefits of vaping. A question to you in Mexico. Does the Mexican government allow for smokers to switch to vaping? Is it allowed, and how are health professionals advising their patients?
I am very, very sorry because I don't know why, for a magical reason, it is forbidden. It is forbidden for our president that has prohibited the vaping and also has forbidden the still smoking in every place. So I don't know what's going to happen in Mexico, but until now it is forbidden. So I think that we as professionals have to be joined and have the papers on, you name it, Congress, medical meetings, to reinforce the fact that vape is harmless than tobacco.
Thank you, Jose. Then I'd like to ask Kgosi. He spoke about the need for harm-reduced products to be affordable, accessible, and also acceptable to smokers. In the South African perspective, do people vape, and is it accessible in South Africa?
And it's accessible depending on where you fit in the economic structure. So to the middle class who can afford, there's vaping stalls inside malls, in the corridors of malls. There are shops in there, but it's for the affluent. For the poor people, it's a problem because cigarettes are still cheap. And if you don't give them affordable alternatives, the poor will remain on the most harmful way of getting your nicotine. And what is concerning, it's because the government has been dilly-dallying. There's no regulation of the vaping industry. There's no standards control. So there's no assurance that's been given to the public about the safety of the devices that they use or the nicotine concentrations, that they would not promote dependence, long-term, etc. So vapes are available. There's no legislative framework, but we have a pending bill that would basically treat the alternatives the same as tobacco. So there's a danger in terms of the bill that is in front of Parliament that can create havoc. So we're advocating and trying to make the ministry see reason that these things are not the same. There has to be differentiation based on the risk continuum. And that's a challenge that we have in the country.
Thank you, Kgosi. And if I could ask Kgosi, often governments have hearings and they invite comments from health professionals and consumers and all stakeholders. Would you mind if we use some of your slides on the PARA website and on the Africa Harm Reduction website as just one view from a cardiologist in Mexico? Are you happy to share your information and your views with other harm reduction networks in the world?
I will be very glad. Thank you. Of course.
And
you can count on me, and I'll be very glad.
Thank you very much, Kgosi. Kgosi, you as president of the Africa Harm Reduction Alliance and now the Pan-American Harm Alliance, you taking the hands. In what way can the information, views, evidence be shared worldwide?
I think, we can use technology to do that. But I think there should be a greater effort in trying to get the WHO to come back to the right track. I think the biggest problem is the lack of stewardship coming from the WHO. And that is the biggest threat to people who smoke, is the WHO. And that needs to be addressed. And countries like Brazil and South Africa are going to be key in addressing those issues. And what we need to be saying to our governments is that, being colonized, you get into a Stockholm syndrome, where you get to identify with the colonizer, and you take instruction from the colonizer. We should encourage our governments that what lies between our ears is not ornamental, and we should use it. And for me, that would be the greatest level of advocacy that we should do.
On that note, I'd like us to give a warm round of applause to Kgosi in Mexico. And Kgosi, thank you very much for sharing your wisdom.
Thank you. God bless you all. Thank you.
Thank you, Kgosi. We will have our lunch break now. And if I may ask if we can come back at 2:45. So 45 minutes lunch and then we're back. Thank you very much. And thank you for the fantastic Brazilian food. I'm sure you would agree with me that this morning we had outstanding content, and I would like to congratulate all the speakers, stakeholders at our first PARA Summit. Now my privilege to introduce to you Patricia Kovacevic. Now we've had health professionals speak, doctors, dentists, regulators, policymakers. Now our pleasure to welcome Patricia, who is a lawyer, resides in the United States, and she's a past master. She's an expert on regulatory science from an FDA, USA FDA perspective. Patricia, we are so grateful for your time, and thank you for addressing us on the principles of regulatory science, especially from the point of view of the regulators like FDA, Anvisa here in Brazil.
Thank you very much, Delon, and it is a pleasure and an honor to speak before this distinguished audience. I regret very much not being with you here. As Delon told you, I'm a lawyer and regulatory expert. I'm a general counsel as well. And for almost 20 years now, I had the privilege to become familiar and to advise on all matters related to laws and regulations governing anything related to nicotine. Although my perspective is global and my expertise is global, today, for the benefit of this distinguished audience, my presentation will focus on what does regulatory science mean, what is the role of regulatory science, and of the law that basically encourages regulatory science, the use of regulatory science, in promoting tobacco harm reduction. And I will give a very concrete example that is important because, of course, the United States is a very big market with a lot of smokers, but also a lot of research being conducted, some of it at government level regarding tobacco harm reduction. And my discussion today, if you can kindly move to the next slide, will be on the Food and Drug Administration, which is a science-based regulatory agency. The next slide, please. So in the United States, as most of you by now know, all nicotine products, all tobacco products, and all nicotine products, whether or not tobacco derived, which do not make a medicinal claim, fall under the purview of the Center for Tobacco Products at the Food and Drug Administration, which is a government agency. It is the most powerful government agency with probably the largest number of employees of all government agencies. I think probably over 15,000, maybe more. It has within its purview also drugs, devices, foods, dietary supplements, radiologic products, veterinary medicine products, and animal food and other other objects and substances. It is, of course, a very powerful agency and very involved, not unlike Anvisa in Brazil. Next slide, please. The FDA has in statute and in its guiding principles embedded regulatory science. Regulatory science, by the way, everything you see on this presentation is actually from the FDA website. These are not my words. Everything that's there is are statements by the Food and Drug Administration or by the leaders of the Food and Drug Administration. And this is the definition of regulatory science as FDA understands it. The science of developing new tools, standards, and approaches to assess the safety, efficacy, quality, and performance of some FDA-regulated products. Of course, for nicotine-containing products that are under the Center for Tobacco Products, the standard, the regulatory standard, is not safe and effective like it is for drugs. It is a bespoke standard called appropriate for the protection of public health. Still, the rulemaking as well as the review of all tobacco and nicotine-containing products in the US by the FDA is in fact guided by science. Some of the science is developed by the FDA, some of the science in fact is developed by the manufacturers in the context of regulatory applications and submissions, comments to the docket, and so on. Next slide, please. As a science-based regulatory agency, what you have on the screen right now are some of the priorities and some of the activities that FDA embraces, and one of them is meeting the challenges for regulating tobacco. As you can see, there are other areas of FDA activity, such as preventing or combating infectious disease and bioterrorism, things like predictive toxicology, and also general science and research with respect to biologics. But tobacco products have a very important role at the FDA, and in fact, the Center for Tobacco Products has been the center that has hired the most scientists because everything surrounding the products, in fact, that are reviewed by the FDA, tobacco products, has to be guided by science. And this is FDA's best defense when they're challenged in court. It is also the best opportunity for applicants presenting new products, introducing new products before the FDA, whether they're vaping products, whether they're oral nicotine products that are much lower on the continuum of risk compared to combustible cigarettes. And the manufacturer of those products have the role and the burden to convince FDA that, in fact, indeed, these products have a much better and less risky profile based on the properties of those products, so that they're much lower on the continuum of risk. Next slide, please. So the FDA, in its words, states that they are a regulatory-based agency, and in fact, the deep and broad scientific base of the FDA is aware that not everybody understands that FDA is not only there to issue rulings or to issue approvals, but in fact, FDA is there to conduct scientific research and to validate the scientific research that has been conducted by manufacturers for the various types of products, including reduced risk products. And science also is an important tool to influence not only regulatory decisions, but also FDA encourages scientists to collaborate. Although the Framework Convention on Tobacco Control appears to suggest that governments have to tread cautiously when interacting with tobacco companies or manufacturers of tobacco products, actually in the US, FDA requires collaboration with the manufacturers and in fact engages with the manufacturers in the process of reviewing new products through the pre-market tobacco application, through the substantial equivalence, pre-market pathway, because in fact FDA's goal, as you can see here, is standardization. FDA has to make decisions based on the best available science facing uncertainty, and we know science evolves. But it is still incumbent upon the manufacturers, upon the academics, the community at large, all of the stakeholders of public health, including sometimes even consumers, to develop science, to share that science with the FDA, and to communicate that science. While FDA communicates the science it develops, the science that FDA develops through grants or in-house papers, research papers that FDA publishes, sometimes collaborations with the National Institutes of Science or National Institute of Health. Unfortunately, FDA does not publicize necessarily the science submitted by the applicants or that the science that's developed independently of a product application by manufacturers of reduced risk products. And therefore, it falls onto those manufacturers to engage and to publicize their research. However, as a regulatory agency, FDA does have an obligation to be candid and honest, and they're held to that standard, for instance, through litigation. Again, the US is one of the few maybe countries in the world where you can actually successfully sue the government in connection, as we have seen in connection with whether it's new regulation or other product applications, because there is still a fairness, I think, to the system that that Americans value. Next slide, please. So what are some of the opportunities? Can you click another 2 times on this slide, please? One more time. Thank you. So what are some of the opportunities for a manufacturer of a tobacco product to engage with the FDA? So the first opportunity is to participate in something called the Tobacco Product Scientific Advisory Committee. This advisory committee, modeled after other advisory committees that operate in the area of drugs and devices, convenes regularly, also in connection with product applications, and it's supposed to have independent members. It does have an industry representative, but most importantly, it holds listening sessions, public sessions, and in fact, most of the actions and the hearings before the Tobacco Product Scientific Advisory Committee are public. One can sign up to speak, and I have done that in the past before the Tobacco Product Scientific Advisory Committee, and present scientific information. Again, it's made up of scientists, as the name suggests. So one way to engage, or I should say to share the science that is developed in-house is to present before the Tobacco Products Scientific Advisory Committee in the context of those public hearings to present the latest science developed in connection with a particular topic or product, or to candidate to become a member. So academics that are independent, completely independent from the industry, of course, are welcome because the members of the committee change every so often. And you can, of course, look it up on the FDA website. Another way to submit regulatory science for consideration to the FDA in connection with the new rulemaking, the most recent example is a new proposed rule for tobacco product manufacturing practices, also known in other countries as good manufacturing practices. The FDA opened a docket, wrote proposed rule, opened a docket, and then of course, everybody's invited, every stakeholder is free to submit comments. And FDA has a duty to review those comments and, if appropriate, to take them into consideration and reshape or simply take them into consideration when it makes a new rule. And because FDA is a science-based agency, it is very important that the best available science be submitted through this docket process, which is again open to the public. This is not lobbying, by the way. This does not mean lobbying. It means simply submitting publicly available scientific research to a docket for not only FDA, but everyone to see and review in connection with the topic of the proposed rule. In this case, tobacco product manufacturing practices, again, also known as good manufacturing practices. Next slide, please. And if you can click for about 6 times on that slide. Another opportunity to drive tobacco harm reduction through regulatory science. If you can click another few times, there are a few lines here. There are, for instance, the content of a pre-market tobacco application. If you don't mind clicking a couple more times, I think the slide will populate. A few more times, yeah, I think 2 or 3 more. As you can see, this document is actually from the FDA. It is a table of content that FDA would like to see when submitting a pre-market tobacco application for FDA review. And that submission is very important because, of course, it includes a full characterization of the product and a lot of types of scientific, clinical, and non-clinical data regarding the product. Of course, this is not a good to have. This is a must-have if you wish to introduce a new product in interstate commerce in the US. It has to have first a pre-market authorization from the FDA, also known as a marketing order, and that can be only obtained, in particular for reduced risk products, through the PMTA. And of course, if you wish to make a reduced risk claim, there is a modified risk claim that you can make, and it's a separate application. But as you can see from this table of content, everything related to the submission has to do with science, and that science will inform FDA's decision whether to authorize a product for sale or not. I only gave you a couple of examples. The reality is there are many opportunities to present regulatory science and to support the development of regulatory science. There are grant opportunities, there are cross-disciplinary collaborations among academics. I do believe that the honest thing to do in order to support tobacco harm reduction is to generate good quality studies, to publicize their results, to make available the underlying raw data for those studies and the outcomes to be believable. Of course, peer-reviewed studies, needless to say, and peer-reviewed research, and to seek opportunities to present that regulatory science before regulators, lawmakers, for their information, again, not on the purpose of lobbying or influencing outcomes, but simply I think we all have a duty to share candidly everything that is generated in terms of tobacco harm reduction research. I will stop here and I will take a few questions if there are any at this time. And I thank you so much as always for your patience. And of course, you can always contact me. I'm very happy to support you.
Patricia, thank you. Thank you very much. You come at exactly the right moment in our summit. the one interesting factor about the United States FDA, in comparison with all other member states, is that the FDA, by law, requires that the FDA engages with all stakeholders. So there isn't the pushback and the division of stakeholders and policymakers. There's an active engagement and there's an active consultation. But Patricia, the first question is, in Brazil, where Anvisa, which is the FDA equivalent, are now embarking on a process of looking at all of these smoke-free nicotine alternatives and potentially regulating them, how can the lessons learned in the US by the FDA be used fruitfully in a country like Brazil?
I do believe that creating an opportunity to brief Anvisa about the US legislation, about how the legislation enables and FDA requires sometimes manufacturers to meet with the FDA to discuss their products. I do believe that it would be important to create an opportunity to present to Anvisa A, the law, B, the structure of this requirement, and C, also some of the regulatory science that has been submitted by some successful applicants in support of modified risk tobacco products claims, describing to them what information was required by the FDA by law in order to authorize a modified risk claim, such as this product presents a reduced risk of heart disease or whatever it is, the claim, and inform Anvisa about some of the regulatory options that FDA has taken in this respect. I think while we can hope that Anvisa is looking at what's happening in the US, the reality is it's a very complex statute. It's a very complicated law. The science that is submitted for the applications is dense. Sometimes it's an iterative process to develop it. We've seen that not all applicants have been successful right away. FDA has required the applications to be supplemented with additional science, and it has provided justification why it wanted additional science. So while we can all assume that regulators in other countries look up to the FDA, they may see the tip of the iceberg. They may see maybe a press release which says, this such and such product was authorized, but they may not really understand what is the underlying legal requirement and what is the effort, which is quantified also in money and time, that an applicant has to engage in order to create this science, because it's a very, very costly effort. And what we really have to be careful about is the cost-benefit analysis of legislation and regulation to make sure that the costs that are imposed on generating the science are not unsustainable to the point where nobody's going to be interested to bring an application forward. Very often I was asked, why don't more companies take nicotine products through the drug device approval process? And the long and the short is it's a very lengthy and extremely, extremely costly process with no guaranteed outcome. And it is really only the privilege of very few extremely wealthy pharma companies that can accomplish that. And this is not the goal. This does not promote public health. Tobacco harm reduction and public health have to happen now, not 5 years from now. And during these 5 years, we have to avoid the loss of lives. So again, we cannot assume that even if Anvisa is familiar with some of the decisions issued by the FDA, for instance, for some of the products, modified risk products, we cannot assume that they understand exactly what the legal requirements are and what the burden, scientific burden is on applicants.
Thank you, Patricia. I have one last online question, and that pertains to the usual issue that in some countries the argument is made that there's not enough evidence to support the classification of one of the harm-reduced products as a modified risk tobacco product, for instance. We know that there are basically the 4 categories: oral nicotine pouches, smoke-free oral tobacco, heated tobacco products, and then the product probably most widely used in Brazil, vaping products. Have any of these products and product applications in the USA been approved? And are they products that are FDA approved on the US market?
So of course there are, they don't use the word approved, they use the word issuing a marketing order. Again, FDA never, in fact, bans the use of the word approved. But yes, several vaping products have received a marketing order, and the finding there was that this product was appropriate for the protection of public health. And the implication of that, and if you read carefully the accompanying FDA memorandum that is issued with every marketing order, FDA explains what was their scientific basis in authorizing issuing a marketing order for the respective products. There are several vaping products that have received it, many others haven't. Of course, as a percentage, the percentage is very small. But the reality is, we have to also understand that it is very difficult for a regulatory agency to make a finding that is a blanket finding. The US law does not allow FDA to find that all vaping products are appropriate for the protection of public health. It requires every individual unit, type of product, SKU, to go through this authorization process, because the thought process is, maybe this brand with this much nicotine and these ingredients is safe and, of course, appropriate for the protection of public health, and, of course, a lot less risky than tobacco, cigarettes, conventional combustible cigarettes, I should say, or this heated tobacco product is. Unfortunately, maybe different ingredients in a different product have a different risk profile, much higher, because of the nature of those ingredients, because of the temperature, what have you. So we're not going to necessarily see ever, I don't think, a blanket finding that all vaping products are less risky or all oral nicotine products. It's still going to have to be sort of a product by product finding. However, yes, I think the information provided by the FDA, when FDA described why it has authorized those vaping products, I do believe that that information is very clear. FDA explains their scientific basis. And obviously there is enough science, given that a regulatory agency as prominent as the FDA, after 2 or 3 years of review, it wasn't a quick review, it was several years of review, have in fact found that these products, because of their differences in their profile compared to combustible smoking, which is what these products compared to in that application, clearly are more appropriate for public health than cigarettes. So I would, even if I'm not a scientist, I think, again, I'm looking at what the FDA says. Don't believe me, but believe what the FDA has said about a substantial number of products, that the science is there to prove that, in fact, these are a better option that is appropriate for protection of public health.
Patricia, thank you for sharing your expertise, and we ask a warm round of applause for Patricia. Thank you for joining us.
Thank you for inviting me.
Thank you, Patricia. We now come to the session on consumers. Consumers are often regarded as the orphan in the debate, often the last stakeholders to be consulted, and we have an outstanding panel to address these issues. First up will be Dr. Chris Russel. He has specialized in research of psychoactive, affective, policy and product factors involved in consumer smoking behavior. He did his PhD, he's from Scotland. He did his PhD in smoking cessation. So Chris is a true expert and has been through many applications to FDA, for instance. Chris, we are very keen to hear your views on this subject.
Forward, and that's the point. Okay, thanks. Thank you very much, Delon, for inviting me here to speak, and thank you to all of you for welcoming me. As Delon mentioned, I'm Dr. Christopher Russel. I'm a behavioural scientist from Glasgow, Scotland. I'm going to talk to you briefly today about the various research needs of regulatory authorities for developing a better understanding of the harm reduction potential and the public health implications of e-cigarettes. Well, much of the discussion so far today has been about the health effects of e-cigarettes. I'm going to speak primarily about the behavioural effects, and I've tried to design my presentation to be most applicable to regulators who are either in the infancy of deciding how best to regulate e-cigarettes and other tobacco harm reduction products, both to maximise protection of public health and the improvement of public health. So just to start with just some disclosures, I'm a director of Russell Burnett Research and Consultancy. We are a company that designed perception and behavioural studies of a variety of candidate tobacco harm reduction products and their impact on future tobacco and nicotine use in the population. And we have received funds from a number of e-cigarette manufacturers to design and conduct a number of primary research studies of various e-cigarette products for regulatory submissions to the US Food and Drug Administration. So I want to start with just two core facts that shape all thinking about how appropriate, as Patricia mentioned, how appropriate new tobacco products and new nicotine products are for the protection of the public health. The first fact is that e-cigarettes were created and iteratively innovated in the early 2000s to provide adult smokers with satisfying and appealing alternatives, marketplace alternatives to combustible cigarettes. But with all commercially available consumer products, there comes the possibility that those products will be used by unintended user populations. In the context of e-cigarettes, that would be people who have never used tobacco or nicotine products before, and especially youth and young adults. So it's clear then that e-cigarettes cannot simply be categorized as being either beneficial or harmful to public health, but rather the potential public health impact of e-cigarettes depends on how they are used by the population in relation to combustible tobacco products. And depending on who in the population uses e-cigarettes and for what reason they're using them, e-cigarettes may represent either a threat to progress that has been made in reducing the smoking prevalence and associated smoking-related disease, or e-cigarettes may represent a significant opportunity for Brazil and other countries to accelerate reductions in the prevalence of smoking-related disease in their populations. And I want to speak, first of all, about some key behavioural transitions that either reduce harm to the population or increase harm to the population that collectively come to determine whether there's a net positive or negative effect on population health. So the mortality and morbidity risks of long-term e-cigarette use, in addition to, in place of, or instead of smoking combustible cigarettes, are not yet known, and likely won't be known for several decades with a large cohort of long-term users. However, there is substantial evidence that the constituents of cigarette smoke that we know to cause cancer, respiratory disease, and cardiovascular disease are either not present in the aerosol that's generated by e-cigarettes or are present at significantly lower levels compared with combustible cigarette smoke. Adults who smoke combustible cigarettes may therefore substantially reduce their health risks by either completely switching to e-cigarettes and continuing to use them for as long as they feel is needed to prevent a relapse to smoking, or to use e-cigarettes to replace at least some of the cigarettes they smoke. So the central potential health benefit of e-cigarettes and the reason for their invention is therefore to promote smoking cessation among adult established cigarette smokers, or at least to reduce those smokers' consumption of cigarettes. That is, the greatest benefit of e-cigarettes to individuals and to wider public health occurs when they're used as a complete or a partial replacement for combustible cigarettes by smokers who otherwise would continue to smoke cigarettes. And e-cigarettes are also likely to benefit public health to varying degrees when they're used by former smokers to help prevent a relapse to cigarette smoking, and when they're used by never tobacco users who likely would have initiated cigarette smoking but instead use e-cigarettes and subsequently do not transition to cigarette smoking. So those second and third benefits are for relapse prevention and from diverting potential new smokers away from smoking. E-cigarettes, however, are not risk-free, and long-term inhalation of e-cigarette aerosol is likely to carry some excess health risks relative to no use, both through direct effects on pathophysiologic mechanisms and also indirectly through the effects of e-cigarette use on subsequent uptake of combustible tobacco products, most commonly cigarette smoking. Therefore, e-cigarettes likely harm public health when they're used by never tobacco users who likely would not have initiated use of any tobacco product in the absence of e-cigarettes, and more so if those never tobacco users who initiate e-cigarette use then subsequently transition to cigarette smoking, either in addition to using e-cigarettes or in place of using e-cigarettes. And e-cigarette use that deters or impedes smoking cessation or promotes a relapse to smoking also obviously harms public health. And therefore, public health guidance has generally been consistent in discouraging e-cigarette use to individuals who have never smoked combustible tobacco or used nicotine in their life, including youth and young adults, and also including long-term former smokers, so people who have quit smoking for a long period of time. E-cigarette use would be discouraged to those individuals as well. So these different behavioural transitions from one product use state to another over time generate health benefits and risks of different sizes to different individuals and subpopulations. And these benefits and harms can offset each other, which makes it difficult over time to draw inferences about the net effect that e-cigarettes are having on the entire population. And therefore, the net population impact of e-cigarettes is commonly determined by weighing the health benefits and the health risks that flow from each of these transitions that reduce or increase an individual's exposure to cigarette smoke. National and local health authorities, including here in Brazil, therefore need a range of individual and population level data and information to best inform a regulatory framework that maximises the benefits that e-cigarettes can offer to a population while minimising the risks that they carry to the population. Now, given e-cigarettes' potential to simultaneously benefit some people in the population while increasing harm to others, Brazil's ability and the ability of any country to forecast the public health impact of e-cigarettes in the short and long terms requires arguably significant investment in research that can improve our collective understanding of who in the population uses e-cigarettes and the extent to which the use of those e-cigarettes promotes cessation and initiation of combustible tobacco use. In 2018, a report by the National Academies of Sciences, Engineering and Medicine in the United States concluded that the US Food and Drug Administration, federal research sponsors, and e-cigarette product manufacturers should all prioritise funding for e-cigarette research that addresses gaps in substantive knowledge regarding the effects of e-cigarettes on health, the effects on cessation of combustible tobacco use, and effects on initiation of combustible tobacco product use. And the committee concluded that prioritising research on these knowledge gaps can lead to a better understanding of the harm reduction potential of e-cigarettes and consequently of the public health implications of different approaches to regulating e-cigarettes. So the committee argued that, or recommended that investment should be committed to fund research that addresses a number of key questions of which I'm drawing attention to five of those questions. The first and perhaps most obvious is, do e-cigarettes help smokers to quit smoking combustible tobacco cigarettes? I won't go into too much detail about the current evidence base, because I'm conscious that Brazil is a unique situation and evidence from other parts of the world may not be entirely applicable here. But I suppose the best, or the greatest confidence we can have at this moment in time is the publication by the Cochrane Group in England, who routinely review the literature for evidence that addresses this question. And in the most recent evidence review have concluded that there is high certainty evidence that e-cigarettes containing nicotine do help adult smokers to quit. But as I say, I'm mindful that not all research crosses boundaries. So the second question, if a smoker switches completely to e-cigarettes, is the use of e-cigarettes a persistent state in which exposure to e-cigarettes is sustained long-term? Or is it a temporary state that leads to abstinence from both combustible cigarettes and from e-cigarettes? Or worse, is it a temporary state that is soon after followed by a relapse to cigarette smoking with or without continued e-cigarette use? Third, if a smoker becomes a dual user of cigarettes and e-cigarettes, is e-cigarette use in this population a persistent state of continued exposure to both tobacco smoke and e-cigarette aerosol? Or is it a temporary state, for example, in which smokers gradually reduce their cigarette consumption over time en route to exclusive and persistent use of e-cigarettes? Fourth, what is the impact of widespread retail availability of e-cigarettes on population smoking cessation rates? And fifth, perhaps a more qualitative research question, why do smokers use e-cigarettes? With what intent do smokers initiate or start using e-cigarettes? And with what intent or for what purpose do they continue using e-cigarettes, either in addition to or in place of regular cigarettes? Now, the NASM committee suggested that answering these questions will require a series of carefully designed, well-funded research studies, especially adequately powered randomized controlled trials, assessing the effectiveness of e-cigarettes as aids to smoking cessation, using standards and methods that have been employed to evaluate smoking cessation pharmacotherapies. So trials that would compare e-cigarettes against FDA-approved or otherwise approved smoking cessation pharmacotherapies and other evidence-based cessation treatments would be the most informative. And ideally, a randomized controlled trial would enroll cigarette smokers who are seeking to quit smoking, and they would be randomly assigned to switch from smoking combustible cigarettes either to an e-cigarette or range of e-cigarette products, or to a no treatment group or a placebo group, or to using, as I mentioned, another approved smoking cessation pharmacotherapy such as nicotine replacement products, varenicline, bupropion, or to some other evidence-based cessation intervention such as behavioural counselling. And these trials could also compare the effectiveness of e-cigarettes when used in combination with existing approved cessation aids. Now, it's important that these trials be conducted not only in the general population of smokers, but also among subgroups of smokers in which rates of smoking are higher, among subgroups of smokers who are less likely to use or to respond to existing cessation treatments. So people, for example, who don't want to use NRTs or who have used NRTs in the past and have tried to quit and failed to quit with NRTs. And also in the subgroups of smokers for whom continuing to smoke would be especially harmful. So this would be adults with pre-existing health conditions who continue to smoke. And ideally, these trials would measure the proportion of smokers using e-cigarettes who are completely abstinent from cigarette smoking or who have substantially reduced their cigarette consumption up to at least 6 months. And during that time, there would be a repeated standardized assessment of the frequency and severity of adverse events in a manner that allows a comparison of the safety profile of e-cigarettes to that of approved cessation treatments. Now, RCTs are often complex, big, expensive, and sometimes impractical to conduct. Another very useful way of demonstrating longitudinal transitions in tobacco product use behaviour is through prospective observational cohort studies. So in the United States, there is a study called the Population Assessment of Tobacco and Health, or PATH study, which launched in 2011 with, if I recall correctly, around 46,000 adults and youth. And the goal of that study was to monitor and track the cohort's product use behaviours, beliefs, perceptions, attitudes, opinions over time. So they were assessed once per year. And this is a very useful design for establishing the temporal relationship between the onset of use of one tobacco product and the subsequent use of other tobacco products. So a very useful study design for estimating the rate at which, say, for example, among youth, e-cigarette use precedes smoking, and vice versa, the rate at which cigarette smoking precedes e-cigarette use. And then we also have nationally representative population surveys, which are not useful, or they can't tell you anything about causality, about the direction of any effect of one product on another, but it's very useful for characterizing the prevalence of ever use and current use of a range of tobacco products in the population at any one time. And that gives a very high level indication of how much progress or lack of progress a country or a jurisdiction is making relative to various targets that the country has. And fourth, research sponsors should be funding research that seeks to understand the appeal, the affordability, and the accessibility of e-cigarettes compared with other available cessation treatments, and the appeal of specific product characteristics such as certain flavours, flavour classes, certain form factors such as disposable versus rechargeable, refillable devices, and whether there's any relationship between product characteristics and then subsequent cessation or initiation of combustible smoking. And finally, research sponsors should fund research to develop effective strategies for communicating to adult smokers that switching to vaping would substantially lower their risks of developing certain smoking-related diseases in later life, and substantiate those claims with available science that again is communicable to the general public in basic English or basic Portuguese. And finally, certain types of studies for demonstrating the likelihood that youth who don't use any tobacco product will, in the first instance, initiate e-cigarette use, and then at some future point in time, initiate cigarette smoking, and those two events are related statistically and clinically in a clinically significant way. Again, prospective observational cohort studies of the and perhaps erroneously known as a gateway effect, the extent to which the use of one product leads into use of the other product. So prospective observational cohort studies, starting with a cohort of young people, say the age of 12, followed through to at least the end of adolescence, 17, 18, and more ideally into young adulthood, to establish whether, to establish both the rate of uptake of e-cigarettes and secondly the rate of subsequent progression to combustible cigarette smoking, and secondly the existing and new nationally representative population surveys are key for demonstrating the size of the youth problem, the youth use problem in a population, as indicated by the proportion of youth aged, say, 12 to 17, who have ever used a vaping product or who currently use a vaping product or who use a vaping product, say, on 20 out of the past 30 days. So, in summary, the harm reduction potential and the public health implications of e-cigarettes are not set in stone. They depend on how the population use these products in relation to combustible tobacco products. And there's a great need, especially in countries and jurisdictions like Brazil, who are possibly embarking on a process of considering how best to regulate e-cigarettes for the protection and improvement of its citizens. There's a great need for more and higher quality research to understand the contribution that e-cigarettes have to population level rates of smoking cessation among adults and smoking initiation among youth and young adults. And while there will be much debate about the appropriate regulatory framework for e-cigarettes, and I certainly have my opinions based on the evidence that I've seen over the past 10 years, what I think we can be certain about is that given the potential for e-cigarettes to be used by the people we want to use them and the people we don't want to use them, a regulatory model that is too restrictive, i.e. that makes it too difficult for adult smokers to obtain e-cigarettes, or a regulatory model that's too permissive, i.e. one that makes it too easy for youth and young adults and other unintended user groups to obtain e-cigarettes. Neither the too restrictive or the too permissive model is going to be optimal for maximizing the benefits and minimizing the risks that e-cigarettes can have for the whole population. And undoubtedly we'll have further discussion and debate about where the optimum level of regulation sits. But going forward, my recommendation to Anvisa and other countries who are seeking to embark on this process of evaluating the scientific basis for different models of regulation would be to heed the recommendations of the National Academies of Sciences, Engineering and Medicine report in 2018 to identify the types of evidence that are needed to substantiate or to support different models of regulation, and to, obviously, this is the difficult ask, is to commit investment to that necessary research. And only with the commitment to those types of research over a long period of time will come the best understanding of the harm reduction potential of e-cigarettes and the public health implications of more restrictive and more permissive models of regulation. Thank you very much for listening, and happy to answer any questions.
Thank you so much, Chris. Chris often says, don't tell me what you know, tell me what you can prove. It sounds very much like an Anvisa, FDA type statement. A question to you, Chris, is how much of the work that you've done on consumer behavior in other countries would be generalizable and applicable in Brazil as well? Or do they have to start de novo?
No, I do think there's a lot of research evidence that is transferable to Brazil. I think, going out on a limb here to say globally, adult smokers who want to quit, they will want to, if it's at all possible, to continue using nicotine in a way that's not going to kill them prematurely. That's an attractive option. Obviously, there are smokers who want to quit all tobacco use, quit all nicotine use, and be done, for the rest of their life, be done with tobacco and nicotine. But we know that there are despite all of the success of the FCTC and all of the empower measures that have been implemented all over the world, there are still millions, and indeed a billion people who smoke. And I would venture a guess that they're broadly similar in if they're all simultaneously offered a product that satisfies them, gives them pleasure, gives them enjoyment, gives them what it is they're looking for from nicotine, but doesn't expose their lungs and other vital organs to toxicants that will ultimately curtail their life. It's a very attractive option. I make the joke, I'm from Scotland, which is a very typically diet unhealthy nation. And I say if we can find a way of making chips, French fries taste like, we can find a way of making broccoli taste like French fries, I'll eat broccoli. And I'm sure many more people would. So the more you can offer a consumer population pleasurable, enjoyable substances and activities to replace the pleasure that's provided by much more harmful substances and activities, the people will take that option. And I think whether that's UK smokers, US smokers, Australian, Brazilian, I think people are fundamentally the same. They want to have maximum pleasure for minimum risk, and that's what e-cigarettes and other THR products are providing.
One more question online to Chris is just for young researchers in Brazil, social scientists, health professionals, what would you recommend to them as a pathway to learn the best practice in putting together social science designs and engage successfully with Anvisa? In your case, you did a PhD and then you went into essentially private practice. What are your recommendations to young scientists in Brazil?
So, obviously beyond going to university and immersing yourself in that world for a number of years early on, I mean, what I've found to be the most sort of interesting and in a sense annoying is there's no reason for anybody in any part of the world not to be aware of the totality of the research literature that exists in any other part of the world. It annoys me when people from a certain part of the world have a certain view because they think the evidence is in such a way, and then there's people in another part of the world who believe something else because they are being exposed to an amount of evidence that tells them something else. There's excellent resources developed by the UK National Health Service, the Royal College of Physicians, the Royal College of Midwives, the Royal College of Surgeons, and then, for example, I mentioned the National Academies of Sciences, Engineering and Medicine report on e-cigarettes in the United States. There are massively useful, informative sources of information about e-cigarettes and the concept and practice of harm reduction more broadly that is available globally, except for paywalled information. But really, the information that currently exists on e-cigarettes should be available globally. And my recommendation to young researchers is read as much as you can. I mean, it sounds basic. Read as much as you can on the matter. Talk to people, both the people you agree with initially and the people you disagree with initially. Resist the temptation to close yourself off to people on either side of the fence. In fact, try and sit on the fence for as long as you can until the evidence undeniably pulls you in one direction. But just try and stay open as long as you can and engage with both material and people you both agree and disagree with.
Thank you, Chris. The last question from Anders.
May I ask you, does this work?
Yes.
Yeah, okay. May I ask you, I mean, what would one do to get the World Health Organization to accept scientific facts?
It's just a small question.
He's on a broccoli diet.
What would... well, yeah, exactly. On broccoli. As Clive, and Clive, I defer to Clive on most things. He's infinitely more wise on these matters. And if Clive says, he cannot understand for the life of him why, when faced with the strongest available evidence conducted across contexts and populations and times, observing a similar effect of e-cigarettes on smoking rates, why it's not acceptable from a scientific perspective, why it's not acceptable to WHO, and the conclusion that we're increasingly pulled towards is that it's not only based on science. I try to stay out of the politics and the diplomatic side of that debate, because I'm just not qualified to speak sensibly about it. All I can do is, and I think people maybe like me can do, is keep doing science according to the best standards and the best way we know how, keep contributing to the literature and to regulatory submissions, and have perhaps a naive faith that eventually the weight of that good science and good application of science to regulation will eventually ultimately produce a situation like Sweden, where you look at it and you say, how is this not the world that we want? Why don't we all want to achieve what they have achieved? And as people like Clive and others have said, why aren't public health researchers from around the world all boarding planes, flying to Sweden, flying to Japan, to understand what is it that's going on in these countries with the proliferation of reduced risk products and the reducing prevalence of smoking and smoking-related disease? Why are airplanes not full of public health researchers flying to these countries to understand? I just have to, suppose, keep that naive faith that that there will come a point where it's scientifically indefensible to argue against the public health utility of commercially available reduced risk tobacco nicotine products.
A big warm round of applause. Thank you, Chris.
Thank you.
Thank you, Chris. And on that note, Chris's point that aren't people flying to Sweden to understand why consumers have switched away from cigarettes, the perfect moment to introduce Federico Fernandez. He's a fantastic thinker, entrepreneur from Argentina, currently lives in Poland. He's the executive director of Somos Innovación, which is a network of 30 think tanks and NGOs, not for non-governmental organizations, who try and find solutions through innovation. Somos has done outstanding work in South America in indexing the tobacco harm reduction maturity of different nations, and we'll ask him about that later. But Federico is here this afternoon to share with us the results of a recent study they did in Sweden. So this is in Argentina who he boarded a plane and he went to understand what's happening in Sweden. Federico, the floor is yours.
Thank you, Delon. Thank you very much. I'm very happy to be with you today. And thank you for organizing this event. Sorry, I'll put my timer, so I'll try to be on time and not to talk too much. But again, thank you very much to you, to Jessica, and everybody involved in setting this event, in putting it together. And it's a great pleasure and an honor to share this panel with Dr. Chris Russel, with Miguel Okomura, and two great friends such as Juan Facundo Teme and Francisco Ordóñez. So I wish I would be, the only thing is I wish I would be there with you. Unfortunately, I mean, I couldn't leave home, so next time. Anyway, I'll share a presentation in a second. Don't worry, I'll go quickly, but it's important. Just a few words to complement what Delon very kindly said in my presentation. Somos Innovación, or we are innovation, depending in which part of the world we are. It's a network of more than 30 think tanks, foundations, and NGOs around the globe. Currently based in the Americas, in Europe, and hopefully this year also expanding to the area of the Asia Pacific. We are very much, as our name states, we are very much committed to innovation. We believe innovation empowers individuals to take matters, take matters in their own hands and be part of problem solving. The scope of our activities goes way beyond innovation in the nicotine sphere, so to speak. But we believe that innovation that has happened regarding safer nicotine products cannot be understated. And as you know, innovation is a very wide field, and the topics and the areas that we try to pick are areas that we consider that are not only innovative, but also have a deep and profound human impact. In that regard, what has been going on in the last 10, 20 years with safer nicotine products, we believe is a game changer. What I'm going to show you today, and just allow me to share my screen. This always works until you try to do it, but it seems it's working. Right? I hope you can see the presentation. What I'm going to show you, to share with you today, is an opinion poll that we ran in collaboration with Ipsos. Ipsos is an international company that does this. And well, why Sweden? Of course, I mean, I'm sure during the whole day you've been saying, and Dr. Anders Milton is there, for instance, Dr. Russell just mentioned it, but this cannot be, let's say, we have to say it over and over again. Sweden is reaching smoke-free status this year. That means that less than 5% of the people there smoke. Compare just to the European Union. In the European Union, 23% of the population on average smoke, and in some of the countries, 1 in 3 adults smoke. So there is, let's say, and by the way, the goal of the European Union is to reach smoke-free status in 2040. And, and I hope you understand the reference, like Colomwani in the final, they are about to miss that goal. I mean, in the case of Colomwani, thank God, but in this case, really, not thank God for sure. We did an opinion poll in which we asked ex-smokers who switched to safer nicotine products, to alternative nicotine products, about certain issues, and this is what I want to show you. I won't bore you with the methodology, and by the way, I'm not going to share with you the full study because of matters of time. You can check the whole thing both on somosinnovacion.global or weareinnovation.global. It's there, and it's a very recent study. Just to begin with, it's a quite obvious result, but it's important anyway. Most of the people who switch from being smokers to alternative nicotine products, they do it because of health concerns. Social and financial aspects are also part of the equation, but health is definitely the number one. And we like to say about this that this really shows how safer nicotine products empower individuals to take matters in their own hands, to make the switch that allows them to improve their health overall. There is just, I'll go later on this topic, but it's interesting that in the case of women, for instance, social aspects are have a heavy. They are heavier, in the considerations than for men, and there will be some of these differences as well in other questions, and it's interesting to reflect about them. Another very important finding is that it's very, and this is what the ex-smoker said. It's very important that there is a wide variety of products available. In Sweden, and I'm sure this has been mentioned during this seminar, in Sweden, still snus is king, but products such as nicotine pouches and vaping are definitely gaining ground, are gaining consideration among ex-smokers. And this is something, that we really want to highlight. We believe that this makes very clear that both availability but also development of products are key in order to facilitate the switch. As I was a couple of weeks ago in Sweden talking about the study, with, by the way, with the presence of Dr. Anders Milton there as well as in the panel. And one thing I was saying is that there is non plus ultra in innovation. We don't know what if we had, let's say vaping as we know it has more or less 20 years old. What if we had stopped innovation there? It would have been a problem. We don't know what could come up in the future, and we have to remain open for that. And as I was saying, snus is king, perhaps, but for women, nicotine pouches are the queen. And this is extremely interesting. The product that is more accepted in order to make a switch for women are nicotine pouches. And vaping is twice as important as a resource for women than men. So again, these things also not only tells us and gives us the idea that we have to also keep certain gender sensitivities into consideration when we are thinking about harm reduction strategies. Another important point, and please, I won't go through all the whole thing because there's no time, but just from top to bottom, keep your attention on the first 3 bars, please, is that there are three findings that we think are quite important. Consumers really prioritize being able to get a product, to access a product that both offers the flavor that they want and the nicotine levels that they want. And not only that, 61% thought that it's crucial that alternative nicotine products are cheaper or at least affordable compared to combustion cigarettes. This for us highlights something that is extremely important, and let's say that has policy ramifications that are very big. That we think that this really shows that these products need to be priced competitively, and also the taxation that they are under should never be the same kind of taxation that goes for combustion cigarettes. And we were talking about certain differences between women and men, and I was mentioning in the previous slide flavors and nicotine levels. And this is also, I think, a very interesting revelation from our study on flavors. 50% of women said that they were very important, while 37% of men said the same. And in the case of nicotine level, more than 1 in 3 women said that, again, they were very important, and less than a quarter of men said the same. This really, and I have highlighted several instances, we believe that this really shows that the one-size-fits-all regarding policies for harm reduction is really a very antiquated and wrong approach. In a way, we could call it, I'm saying this slightly as a joke, but we could call it almost a patriarchal approach. And again, there are these gender sensitivity, there should be gender-sensitive approaches regarding harm reduction. Two final slides, and I'm happy that I'm within my time. 2 things that I wanted to show. These were the more puzzling approaches, findings from our study. We asked ex-smokers who switched to alternative nicotine products, how do they think the government views alternative nicotine products, the public health institutions, and society as a whole. And these were not the most, let's say, optimistic results. A striking 61% said that the government is neutral towards alternative nicotine products, and almost 1 in 4 said that it's hostile, just 15%. thinks that the government has a positive view and a positive attitude towards alternative nicotine products. And this is interesting to compare with, you know, what they think about society's views, because if the Swedish government could mirror at least what society thinks, according to ex-smokers, it would definitely improve. And the other thing, and this has to, I think this relates in a certain extent to the last question that was asked to Dr. Russel. According to ex-smokers who now use alternative nicotine products, the public health institutions have a hostile view towards them. That's the, let's say, the main response, followed very closely by neutrality, and only a positive one, it's less than 10%. So it's extremely low. And last but not least, let's say the users of alternative nicotine products are not very happy with this situation, and more than half of them think that the government should change their approach, should have a more positive view. And it's interesting to contrast how, on the one hand, individuals, you know, civil society, we could say, but well, the people who we poll see these products as empowering tools that allow them to quit smoking, and they don't see the government mirroring the same feeling. That's interesting. We think this should open the eyes of decision makers, policy makers, parliamentarians in Sweden. And this really gives them an opportunity to show more openness for alternative nicotine products. In any case, I think these results show again that let's say how powerful in the story of Sweden alternative nicotine products are, from snus, which is a magnificent innovation that has a couple of 100 years now, to what we see today, and also how differences between men and women should also be contemplating every time we are thinking of harm reduction. Thank you very much for your attention. I'm here for any questions, and I'm also really looking forward to listening to Miguel, Juan Facundo, and Francisco. Thank you very much.
I have to say that the quality of the content and presentations today has been absolutely outstanding. Federico has brought some insights into the Swedish story that we've heard at least 4 times today in the most fresh and relevant manner. Thank you very much, Federico. Federico, we would like to ask if there are any questions. Please just indicate that you have a question. But just in the meantime, we're in Brazil, and there are many stakeholders who are looking for resources as they build their advocacy programs or their research programs. How can they use Somos Innovación, both this consumer study, but also the index that you've put together? Could you tell us more about the THR index and where it can be found?
The index is an index of, as we call them, effective anti-smoking policies. It's an index. I'll try to be quick, but it has a certain history, even though we only did one edition so far. Our idea was to measure basically Latin American countries, but we realized quickly that it was going to be an index of basically very bad students. There are a couple of exceptions, but in general, the situation. So we decided to expand it. We measured 59 countries, but it took us, we thought it was going to take 6 months, more or less. It took us 1.5 years to come with the first edition. We're very proud of it. It's everything. And by the way, everything that, let's say, all the research that we did and why each country and each product has, we measured, let's say, the policies regarding snus, nicotine pouches, vaping, and heated tobacco. Everything is available. You can download our let's say, Excel sheet and take a look, and we're happy to, let's say, receive criticisms. So far, we haven't received that many, and we have received a lot of praises, but always happy to improve. we're already working on the second edition, but the first index, which was published just 5 months ago, 6 months ago, it's completely available. It's on our website. We are innovation.global or somosinnovacion.global, and we believe it's an interesting resource to see who's doing well, who is not. Unfortunately, countries like Brazil or mine, Argentina, are, let's say, on the bottom, and also what would be the roadmap to improve. So, and everything. And by the way, we are very happy in Somos Innovación. We have presence in Brazil, we have presence in the whole region, and also in Europe as well. We're very happy to help everybody who wants to try to create a smart regulation environment for these products. We don't believe in prohibitionism, and we don't believe in stifling innovation. We believe in this case the best approach is a smart regulation approach, that it's open to innovation, because, as I said, there are magnificent alternatives for people who want to quit smoking today and turn to alternative nicotine products. But we don't know what may come in the future, and we should be open for those possibilities too.
Thank you, Federico. We have a question that will be translated for you. If you just give us 1 minute, please.
Hello, Dr. Dylan.
Yes. Yes.
I'm so sorry, but my English is so
Portuguese.
bad. I will speak in Portuguese, okay? Eu sou sua fã.
I'm a fan of yours, really, and my name is Alessandra Soares. I'm a pharmaceutical field, and I was director at Anvisa from 2017 to 2020, and I congratulate you on this event today, seeing so many specialists and experts here, working with science responsibly, coherently, and worried and really concerned about the health of the Brazilian and the world population. There's no question here, it's just a remark. And I'm telling you how important, just like to tell you how important this event is, and thank you all for this journey. No. Okay. Men and women who are very brave to approach this topic, worried and concerned about smokers' health. No?
A minha esperança é que discussões como essas, ou antes direitos da pessoa, como pensam médicos e profissionais da saúde refratários a essa discussão, and convince those health professionals and physicians who do not accept this alternative model.
Because it's not acceptable. Sorry, I was told to stop, but I'm going to continue. I'm sorry. It's unacceptable that people won't won't be dealing with the risks and harm of the tobacco smoking. So I wish you all a lot of courage and creativity so that you can keep on researching, producing good results, so that the best decisions can be made based on the information you have obtained. And thank you very much.
Let's hope we can play as the regulatory game as well as you play football in Brazil. Alessandro, if I can make a comment and then just facilitate a question between you and Federico. So the United Nations has a position statement on the prevention and control of non-communicable disease, in which they say that the only way to overcome this problem is through a whole of society approach, a whole of government approach, and with multi-stakeholder engagement. I think all of us appreciate your words that we are multiple stakeholders in the room, we're all committed, we're all sincere, and we're all hoping that in Brazil can become the world champion in tobacco harm reduction and tobacco control, like you are in football. It's no argument in football, but let's do the same in tobacco control. So just the question between you and Federico, if very important research, as Somos Innovación has now conducted in Sweden, if they wanted to share that with Anvisa, how would you recommend they share or submit this research to Anvisa? It's coming. It's coming. Federico, I hope you agree with the question.
Yeah, I mean, I would be, let's say we would be more than happy to support anyone who wants to share this with Anvisa. By the way, we will be doing a few things in Brazil as well. We think it's, Brazil, let's say it's at the tipping point and it's very important. Brazil, it's a giant in the region. Whatever happens in Brazil is going to have a huge impact in the rest of Latin America. And we are, let's say, looking forward to try to do whatever we can to let's say, make the regulatory bodies to make the right decisions. Prohibitionism doesn't work. They are putting a lot of, I mean, I'm not going, you know all this better than I do, but let's say it's extremely sad that the products that have helped Sweden basically defeat smoking and defeat a lot of the cancers that are related to smoking are the same products that in Brazil and Argentina are forbidden. So that tells you a lot.
Thank you, Federico. Last word from Alessandro.
Alessandro, a minha pergunta, my question. Federico, congratulations on your work. I thank you for your question, and I think that it's key, your offer to Anvisa, the results of your research. Eu sei. Desculpe, Alessandra. No, don't worry. It would be very interesting if you could forward the results to the 5 directors of Anvisa, the technical directors, the management, tobacco management department, Not only the results of your research and your work, but also the remarks and your opinions that these products, they
ação endereçada a esta casa. Isso é possível fazer, é uma casa que recebe documentos públicos, há uma via e posteriormente posso inclusive orientá-lo como fazer isso.
It would be very important if, apart from all the studies you have, you could also have a written manifest from not with just your findings, but all other your colleagues' findings to Anvisa. Anvisa is very open to receiving that documentation, and it's very important that that is done.
Okay?
And sorry, I forgot to add something. And she is very pleased to help and offering the guidelines as how you can do it.
Wonderful. Big round of applause. Thank you, Alessandra.
Thank you.
Thank you very much, and thank you very much, Federico. We will now ask your friends to the front, so please stay online to also listen to them. Thank you, Alessandra. Now I would like to ask Miguel Okamura from Brazil, Gopurugast, and Juan Facundo Teme from Argentina. And I do apologize, I know Argentina is the World Cup champion. But we're in Sao Paulo and the great man lived here. Miguel, please, if you come and sit here, Juan. And then we are going to ask for Francisco Ornez to join us online, if that's possible. So this is the penultimate panel, and we wanted to ask Miguel and Juan, as advocates for the consumers in Argentina and in Brazil, their opinion on what can be done to strengthen the voice of the consumer of vaping products and other harm-reduced products in these countries. What are your insights into what's happening now, and how can their voice be strengthened? Miguel.
In order to speak with my heart,
please,
I will have to speak in Portuguese. So
please,
ready your translator devices.
Just give it 1 second, just so that everybody... Francisco, welcome. Francisco is from Colombia and an editor of Vaping Today. You are very welcome. You are joining the panel with Miguel and Juan. Miguel is speaking first, and then I'll repeat the question to you. Please, Miguel.
Bem, é importante dizer que eu sou consumidor. Então, que durante esse dia todo aqui, que a gente viu muitos estudos e sempre foi falado do fumante na terceira pessoa, né? Talvez eu possa falar hoje do fumante na terceira pessoa.
So today I can talk about smokers.
Eu conheci como redução de danos. Eu larguei 7 anos de tabagismo como se fosse uma terça-feira, sabe? Então que com isso, né, quando eu conheci o vape, eu não sabia nada a respeito, assim como provavelmente muitos dos outros consumidores brasileiros. E graças a Deus por ter acesso a uma boa educação, eu comecei a pesquisar, a procurar, a tentar entender alguma coisa a respeito dos cigarros eletrônicos que eu tinha encontrado. A minha reação inicial é que era muito bom para ser verdade. Porque
oh my God, it's got to be good.
Tanta minha necessidade
because it didn't only meet my needs,
but like it worked for my dependency, my addiction. And throughout this research, I noticed that it was forbidden in Brazil. And not just forbidden, banned, but you cannot advertise, you cannot commercialize it, you cannot tell the differences between combustible cigarettes and vapors or vaping. Yep. So it's difficult for consumers to talk about the product. You can't. You just can't. It's banned. So I was doing, like a personal research. I was doing it as an individual, not as an academy member or a scientist. But I found out that I needed to know more about it. As you could see here today, the response of consumers in all the researchers with regards to harm reduction is huge. When you think of the death daily rate, oh gee, INCA's number, the Brazilian Cancer Institute, we are talking about thousands of deaths every day. And how can't it be our major concern? I was reviewing their data. It's 1/3 of total deaths in Brazil. How can we keep quiet towards that? As a consumer, as a citizen of Brazil, I'm an individual of this country. You're talking to people and you got to be open and honest. But you know what? I cannot tell you, how we can do that. I know that we as consumers, we have to get organized. It's got to be something formal. But this information, this knowledge doesn't come, over the night. I have a podcast. I've been talking to people every week with people, health professionals, consumers, and honestly, after getting to know Juan Facundo and Francisco, I noticed that I'm an activist. I'm responsible. I'm responsible in answering your question. I myself and other Brazilian consumers, we're in a rush. We need to get there. We need help. Because I believe that we Brazilians, we're very important in Latin America, given to our size. Take a look, the space that we occupy, and I would love to be the example in Latin America. But who are the examples? It's Juan, Francisco, other people from Latin America who are way ahead of us. So I'm here to learn from you, to learn an answer from you. So we can at least give an
Fabulous, thank you.
Muito obrigado. Agora perguntamos.
Your words or questions and recommendations to us all.
Buenas tardes a todos. Bueno, como Miguel también voy a hablar en español por lo pasional de mi discurso. Agradezco a todos los presentes, agradezco la invitación de el Dr. Human, de Jessica, por organizar este evento.
Dr. Human's invitation. Today, the agenda was very long, exhausting, but I think that the reason we're here is because we're talking about reduced risks and potential users of these devices, people who smoke, people who wanted to quit or would like to quit but couldn't quit combustible cigarettes. So we have here from different fields, people, scientists with different papers and different studies showing that these results are, this is achievable, these goals can be achieved. Journalists fighting disinformation, that we have a technological culture about these devices today in Latin America, and mainly in Argentina and Brazil, where these devices, with these products are considered illegal. It's very difficult for you to adopt them as a way of quitting smoking. We have to become experts on everything. We question a lot of things, and I don't want to sound politically incorrect, but harm reduction, cigarette, tobacco, I think that these devices are, they're not considered, they're not fair. There is a bias concerning them because they can help, but at the same time they're banned. Why countries like Argentina and Brazil, the option we have is just banning of these products have been banned in Sweden and other developed countries. They are not. Why are they not considered? Why are they illegal? Why are they considered an option? So we have a lot of questions to ask. We have to talk about the trade. We're not talking about the legal trade. I'm talking about the commercial aspects. And how many, what about informal economy? And how many regulations and policies there should there be so that people could work formally and have dignity doing that? Argentina, so I think that we depend on the users today, because prohibition unites us and makes us make use of the informal market. For example, Dr. Maria has given us the example about the illegal market in New Zealand, and that people that ill-intended people get in the way of these commercial activities, and that users should benefit from these products. So knowing that Anvisa has a very close relationship with Argentina, and there should be studies about vaping in Brazil. So I recommend, I don't know if I have an answer, but working together, the civilians, the doctors, scientists, everybody should work together. It's not black or white. Not even medicine or exact sciences. We have to work together. Studies on these devices have to be carried out unbiased. We have to have an open mind. In Argentina, that makes me very sad to say that. I mean, in Argentina, there are many deaths, and in Brazil, there are going to be more deaths. We all have someone close to us who we have lost or who is suffering from the effects of tobacco smoking. I don't say vaping is a lifesaver. It's going to save everyone. I mean, these deaths account for 14% of the deaths in my country. But if we can save 5 people, 10 people, 15 people, we have done something. Vaping doesn't kill. For example, we can tell someone, you either quit or die. It's one more tool to help us. We want to broaden this range. We want to, for example, the gums, the medicine, one more tool we may have at our disposal that won't bring any risk to people's health. And sometimes we have problems with certain kinds of medicine that we have side effects, for example. So why not consider this possible too for products that will reduce the harm? I'm sorry for speaking so much. I'm really long-winded, but I'm very passionate about the topic.
Before I ask you, may I ask our international guests to just join us in the front, please? Heino, Anders, Kgosi, Riva, Konstantinos, Chris, please just join. This is the grand finale. Francisco, we'll give you a moment. In a moment, we'll let you talk.
Okay.
And then you will remember, Diego, thank you, join us. Yes. Okay. Francisco, you're speaking from Colombia. You work with vaping today. You've heard some of our discourse. We would love to hear your thoughts, please.
Ok, bueno, primero que todo, muchas gracias.
Primeiro, muito obrigado a todos vocês, Jéssica e todos pelo convite. From the perspective of users, I am a person who's been an activist for over 10 years. We founded the first users here in Colombia. And based on this, Colombia, we were able to offer support to other countries, Costa Rica, Chile, Argentina, Paraguay. So in many countries, we were able to replicate our experience. It is the voice of the individuals, the country's populations, the consumers. Consumers, the citizens, the population, vaping, and activists, and all the different products for nicotine absorption that are less harmful. We are activists, and we consider that harm reduction is a human right that has to be respected, and it has to be free and available in every country. Because we're seeing the harm that comes from tobacco, combustible cigarette use. We are the people who consume these devices, these alternative devices every day. So we should talk about it to consumers, to people, to say where they can find these devices that will help them to reduce harm. We know it's a political decision, and we, the people, we, of course, have a saying. We vote. We did that in Latin America, the countries I mentioned as well, other countries in Europe as well. We started to listen to the people's voice. We started defending our rights. We know it's a political decision to reduce harm. It's something that has to be based on science data. Luckily, we have, people who gave their contribution, organizations that helped us to get our products legalized. And we, as the people, we have to show our legislators that we have our rights. We are different anti-tobacco organizations, so we have to step up and have a voice. These alternative products are an alternative to tobacco. Of course, they're risk, but they're, none when compared to combustible cigarettes. And they will, of course, bring benefits to the countries, the different countries' health system. And it's important that we work together, we as the people and activists, human rights activists and smokers, we're here to defend them. We should create this network to help everyone. We built these networks. We built networks not just with users, but with organizations and scientists, and that has helped us to make it bigger. It became wider, broader. It's important that in the recommendations, we, the people, and it's a role that we have, we have to, as users organizations, we have to inform people what are the advantages of these products that are alternatives to the combustible cigarette. It's important that we are all together as associations. We have the obligation to inform everyone. We have to inform other organizations, physicians, scientists. We have to tell them all so everyone can share the same information and everyone has access to that information. If we work together, united, we can make more. We will be more successful. We have more chances than if we work, each one on their own. So that's why I say it's important that the organizations have to get together. I've been working for over 10 years. I'm very perseverant. I'm always, advocating products. I'm always advocating the low risks that harm reduction alternative products offer. But as this physician that tells me we are on the right side of science. Thank you, Francisco.
Leslie Rodriguez to join, please. Sorry, I didn't see you part of our whole of society panel. If I may just explain, this is the grand finale of the day. Very welcome, and we will listen to you first. We've had a super day, Para Summit, and we've heard some outstanding presentations. And as the UN has asked, we must have all the stakeholders together and find solutions in a whole of society approach. And we have all of the world here in front of us. This is a small microcosm of the world, wonderful committed people. So I'd like to give each one of the panelists just 1 or 2 minutes to give their last thoughts, their last recommendation to Brazil, how to accelerate tobacco harm reduction in complement to tobacco control. First, I'd like to ask Cynthia and Erika, please just say your name, your profession, and then how you would see Brazil could embark on the tobacco harm reduction journey.
Eu vou falar em português para poder ser mais.
I'll be speaking in English, and I want to thank you for the opportunity of being here.
Durante todo o evento, ouvimos muito a respeito da necessidade do Brasil ter uma melhor política em relação ao cigarro eletrônico e inclusive novas alternativas para conseguir tratar melhor os usuários. E eu tenho uma formação acadêmica, eu fui coordenadora de cursos de medicina e hoje em dia a gente tem um ensino da medicina voltado para a prática das melhores evidências. Então, me soa bastante até contraditório não termos na nossa agência reguladora hoje a execução das melhores evidências. Claro que entendemos que há uma velocidade de informação muito grande, no entanto, os outros países, como no Reino Unido, na Suécia, foi possível executar essas transformações nas políticas de saúde baseadas em evidências. O sistema público de saúde aqui do Brasil, ele é bastante robusto e preza por ter boas políticas, tanto que nós atualmente temos uma política de cessação do tabaco considerada de sucesso. Mas, infelizmente, a gente percebe que nós médicos, eu sou médica também, nós médicos percebemos que não há uma velocidade de ações conforme a demanda da população. Um dos argumentos que a Anvisa também propôs era que não tinha um número tão grande de usuários de cigarros eletrônicos, mas não é essa realidade que hoje nós conseguimos perceber no dia a dia, e inclusive entre os jovens. Portanto, há uma necessidade crescente de
So we need that we implement the best practices based on evidence. And we have to somehow bring it to the population that is growing the risk, because they consider it a risk, don't they? So there is this new population growing up with the risk. We don't know what is using the vaping liquids. It's important that we do something about it. There is a discrimination among the different types of vaping, of vapings. So I know that those who are more updated on scientific evidence, they can tell the difference. They can tell the different types of combustible cigarettes, non-combustibles, the different ends products. But if there is not a differentiation to tell which vaping device you should be using, what you're doing is that you are exposing your youth to risk. And I'm talking about youth considering that, there are different strategies to decrease tobacco usage among the current users. Muito obrigada. So, good afternoon. Thank you for the invitation. I'm a biologist. My focus is public health. I was never in tobacco before. I'm going to tell you what I'm doing here. I'm a teacher. I'm in the academy. I'm in university. And we saw, youth, the students using vaping. I live here in São Paulo. So, you go to restaurants, you go to bars, you're out on the streets, and you see the use of vaping. We do have Anvisa as our regulatory agency, and they say vaping is not good. So when we think of public health, the first step is to acknowledge the issue, the problem. It's growing. We have data. Fiocruz in Rio. We have that telephone service where we conduct research, health research. We see data there. They call users. They call people, and they ask questions about these people's health. And we see answers that people are using these electronic devices more and more, mainly those who have never been smokers before. And you know what? The research is done with people over 18. We're not talking to teenagers. And if we believe that teenagers are not experimenting, forget it. We would say that we would be naive. We would, not look at this group. This group does exist. It is there. Vaping is here with us, with all these different population targets. We have to measure the social impact. People will have to stop working, sick leaves more and more. It's costly. So programs that can reduce harm, like in England, Sweden, makes you ask yourself, why we're not there? Why we're not with them? Why we're not trying to reach better answers? Because our focus is our population should have better health conditions and more access to health.
America. Maria, each of the speakers, 1 minute, one sentence. What brilliant ideas can you give us?
Thank you. It's been really wonderful to see the diversity of people here and the range of experts and consumers, and just to learn more about what is happening in Brazil and Argentina. I think most of the lessons we could impart have across the speakers been given, and I think these types of events, getting together, as you acknowledged, are very important, and perhaps more of this, more of spreading the message, as everybody is saying. I think everything has been said. People having access. I am hearing more and more the concern about youth and, for example, Australia moving to basically cut access to all adult smokers so that they will have to go to a doctor for a prescription. This is a barrier that will prevent many people from continuing to vape, and they will either relapse to smoking or they will continue smoking and stop vaping. Understanding the motives of politicians that pass such policies, I think, is important. They have many. There are always many pressures on policy analysts and politicians. And Australia saw their taxation income from smoking dropping rapidly. And they chose to restore that. When some of us visited Japan, and we learned this from the Minister of Finance there, that they also were experiencing a rapid loss in taxation income from cigarettes. So they implemented a very complex tax on heated tobacco products, whereby as the tax reduced on cigarettes, they would increase the tax on the heated tobacco products. The health of citizens and preventing disease, preventing premature death, needs to come before those kinds of financial incentives for government. The New Zealand government chose to go ahead with supporting people to switch to vaping if they smoked, either quit or switch to vaping and they're running a public campaign like they do in the UK, and I showed you how smoking is dropping. New Zealand said, we will find that tax income somewhere else. And I think that's what Australia needs to do and other countries. So it is something you will need to address if governments are concerned about losing income.
Thank you, Mariva. Juan, last sentence.
Voy a tratar de ser lo más breve posible. No es algo que me caracteriza, pero lo voy a intentar. Digamos que la moraleja que nos deja todo esto, tanto para Brasil como Argentina, es que la prohibición ya no es obsoleta. Si el problema son los menores, es esconder el problema abajo de la alfombra, porque prohibiéndolo sigue generando un mercado informal y los menores en esta fase de experimentación son curiosos. No quiere decir que permanezcan, algunos permanecerán en el vapeo longevamente, otros probarán y lo dejarán como todo, pero si queremos proteger a nuestros menores, tenemos que tener una regulación sensata. Y una regulación sensata tiene que garantizar la accesibilidad a los adultos responsables e informados y conscientes de la decisión que están tomando. No podemos limitar a los adultos por los menores, ¿sí? Tenemos que regular estos productos para que los menores no tengan alcance a estos productos e que sim, os adultos fumadores
São fumantes que precisem, os usuários que já existem, como disse na Argentina, tem quase 1 milhão de usuários, no Brasil tem que ser muito maior, o número deve ser muito maior, isso garante acessibilidade a produtos de qualidade e que a regulação sensata também seja seguida da economia emergente, o mercado emergente local. Por quê? Importando a muito mais, acompanhe e incentive o crescimento desse mercado, entender o mercado local, porque aqui o mercado não existem grandes empresários ou como os narcotraficantes, porque está tão criminalizado que são pequenos empreendedores que fazem isso, são pequenos produtores, e isso também tem que estar contemplado numa regulação sensata, e a regulação tem que acompanhar esses pequenos empreendedores no seu crescimento e com a regulação. Muito obrigada.
O controle do tabaco vai salvar vidas e o sucesso do Brasil, das políticas de controle dos danos.
In the past 20 years, there are still millions of Brazilians who continue to smoke. And when millions of people continue to smoke in response to all of your best efforts to help them to quit, there comes an ethical responsibility to ask what more can be done to help those people who are never going to quit or very unlikely to ever quit in response to everything that you're currently doing. There is strong evidence that e-cigarettes, when used under normal conditions, expose people to significantly fewer and lower levels of toxicants that are known to cause smoking-related disease. There's strong evidence that using nicotine-containing e-cigarettes helps smokers to quit. And there's strong evidence from countries that have e-cigarettes in widespread retail availability that vaping is displacing cigarettes at the population level. There's no real reason why e-cigarettes cannot help hundreds of thousands or millions of Brazilians to quit smoking. There's no reason why vaping can't displace smoking at in the Brazilian population. And that seems to be an opportunity worth serious consideration, and what would be worse would be if that opportunity is ignored and we're back here in 5 or 10 years looking at stagnant or very little change in smoking cessation rates or smoking prevalence rates. So I would hope that Anvisa and local health and regulatory authorities give serious consideration to the opportunity that e-cigarettes present to reducing smoking prevalence and smoking-related disease.
Thank you, Chris. Miguel.
Eu não lembro se eu comentei, mas eu não sou da área da saúde e eu não sou farmacêutico e eu não sou advogado também. A minha formação é em engenharia, eu sou das exatas, dos estudos, dos gráficos, né? Honestamente, para mim, não me resta dúvidas, né? Porque
Quão certo, no doubt, how right do we have to be to use something that it somehow decreases in 444 deaths a day? What information do we need to save a life? I myself, in my ignorance, in my selfishness, if I had just half of the knowledge I have now, I would still try to save a life. So, you know, we're close to 544 deaths a day. How many more do we need? As a consumer, as a regular consumer, just like anyone else, what I see is that we have to get organized in associations, not just one. There is one in Brazil, but we need more. And we have to make our voices heard. You know, we're activists, right? We have an objective, a goal here. So you know what? We have to tell people that they're vapors, lots of them. That cessation in itself is not enough. You know, from the bottom of my heart, I know how much effort the Brazilian government has done with regards to tobacco smoking. But if we take a step forward, why not? We're just a country with a good example. That is a good example. We don't want to be just that. We want to be the country. We are expecting United States and Europe to show us the way, to give us the regulations. You know, as a consumer, I have so much to ask and say. But what I can tell you today is that consumers have to get together more and more. Thank you, Miguel.
Oh, sorry. I would strongly recommend to the people here from Brazil, Argentina, and Colombia to strengthen the consumer perspective because they have a lot of power they can put on the stakeholders and politicians. This is one level which needs to be improved or united, probably. The other level I'm working in, and lots of my colleagues are working in, is to strengthen and increase the evidence base for non-combustible nicotine consumption forms in that way that it can no longer be ignored by stakeholders and politicians. I think the evidence base is quite good. Clive Bates already told us a lot of important documents. So there's a lot of evidence around we could use for fighting for, let's say, intelligent concepts of tobacco control, which are, in the end, doing a diversification of cessation strategies and not only one size fits all. What I learned in the end, and what some of my colleagues stressed already, is that we in the future should closer look at gender-based and age-specific research questions, and in that way that we no longer are satisfied with one size fits all. That's our task as academics and as scientists and practitioners.
Thank you, Aino. Francisco, and then Kgosi. Francisco.
Ok, sí, la escucho. Bueno, mis recomendaciones, conozco gracias a Mihaela o a Claudio que nos va a acompañar esta vez, pero realmente lo que pasa aquí aplica realmente para muchos países, incluso en Colombia, donde ahorita actualmente tiene una regulación.
Não temos uma regulação agora e eu acredito que é importante, em primeiro lugar, dizer que os cidadãos queremos e precisamos de uma regulação dos produtos de administração de nicotina, mas tem que ser uma regulamentação diferenciada, porque são produtos totalmente diferentes ao tabaco, que é o que buscam muitos estados. Eles tentam equiparar esses produtos de administração de nicotina com o tabaco de combustão, gerando muitos problemas, tanto a imagem dos produtos, porque...
And they are not. The image to users is that these products are the same as combustible products. That's why we need a different regulatory, different rules for them, with rules and regulations. Of course, what happens in Brazil is not right. Ban the trade of these products. You cannot market them because the products that are being used in Brazil, as in Panama and Argentina, in other countries in the region, they are illicit products. And what happens with those products? They have a very doubtful quality. You don't know how they're sourced. There is no control. There is no control about the quality of these products, and then the people's health is at risk. And apart from that, the government loses with no taxation. I don't know what the Brazilian scenery would be, but as a result of the prohibition, taxes make buying the product impossible. The majority of the population cannot access them. They can't buy them. They don't have the money. And it's been said here before, because those with access are not necessarily those who smoke the most, because in Africa and South America, the smokers are the low-income people, the low-income population. So what happens with this ban? They buy counterfeited product, dubious products, not good quality, and then harm reduction will never reach its goals. Products to reduce harm, there are many. You have the patches, the gum, so many other products. And these products, they have an opportunity. We have products that are much better than the nicotine replacement products. They can be a solution for everyone, even those that are low income. And people have to make an informed decision, an informed choice. They should choose what's best for them. Of course, there is a long way to go, but if we keep working together, fighting together for human rights and people's choices, we will get to harm reduction.
What you say have been said by the previous speaker, so thank you. Bye. I think the key message is that the problem is combustion of tobacco, and that there are a few alternatives that are non-combustible. So it should not just be about e-cigarettes. You've heard about snus, there's heat not ban, so it's combustion that is the problem. And you need to open it to all form of non-combustible and be able to research them. There might be things out there that we know nothing about that might be useful. And vaping should not be seen as a problem. It should be seen as a reality of today. Because if you view it as a problem, you already have a negative association with vaping. So that it's viewed, you open yourself to come out where the research takes you. But if it's a problem, you're already on one side of the issue. You've judged it, you've taken sides. And to physicians, as a physician, physicians, we have to stop being farmers' useful idiots. So we can't be promoting everything that is promoted by pharma. We got to go beyond medical interventions and prescribing. We got to be the advocate for the person. We got to be lifestyle gurus, which means we need to be trained differently, but we also need to approach it differently, where we are enabling patients to make informed decisions about their own lives and not deciding for them. And lastly, prohibition is abdication. When people don't want to use their thought processes or are not fit for purpose as leaders, they resort to banning things.
Thank you,
So
Kgosi.
instead of banning things, just resign so a competent person can take over.
Anders.
Thank you. I think we have to be truthful. We have to tell people the truth. Give them the facts, and they will come. And give them the facts and the alternatives, and they will come. Simple as that. And then we have to fight the World Health Organization, because they are screwing the minds of the world, really, including the governments of Brazil and some other countries, unfortunately. And I think we really have to do it. It's a long-term work, but we have to do it.
Thank you, Anders. Diego.
Bueno, ¿qué más decir, no? Me dejaron todo ya sin palabras. No sé lo que vas a decir vos, Konstantinos, porque ya dijeron todo. Pero contarles que la información está, los datos están, las experiencias científicas están, las experiencias demográficas están, ¿sí? No miremos para otro lado. Tenemos que poder acompañar a nuestros pacientes con todas las herramientas que tengamos para que de cualquier forma se deje de fumar. No tengo más para decir, pero lo hacemos todos los días. No nos olvidemos, como dije en mi presentación, de nuestro juramento y dejemos de mirar para otro lado. ¿Sí? Hagámonos cargo de esto porque tenemos la oportunidad histórica de poder pelearle al tabaquismo con todas estas herramientas. Estudiemos, formémonos, consultemos. Hoy, con lo que es la tecnología, podemos ya saber qué estudio se está publicando en Fiji, en Estados Unidos o donde sea. Entonces, utilicemos toda esa tecnología. Y si los jóvenes están vapeando, es porque entendieron este paradigma tecnológico y quieren
Paradigma tecnológico e eles querem consumir nicotina de uma forma mais saudável. Não vamos castigar esses jovens, não tem mais o que dizer.
You know, vocês sabem, algo baseado na proibição é fechar a cortina e não deixar o sol brilhar, mas o sol vai estar brilhando.
For any product for which there is demand, especially for health reasons, as e-cigarettes have a demand among smokers, it doesn't matter whether you want to ban them or not, they're going to exist. The problem that the prohibition introduces is that the prohibition itself is creating an uncontrolled, unregulated market. Of course, it's a black market. So the first two speakers of this panel discussed about the problem of seeing people vaping, and of course they don't know what they're vaping because there is no regulation, there is only a ban, so there is no control on the quality of the products, no one knows where these products are coming from, they are illegally being imported to the country, we don't know who sells them, there are no quality standards, there is absolutely nothing. All these are the outcomes of the prohibition. It's not a problem of the product's existence. There are many countries, there are regions, the whole European Union, for example, where the products have been available since 2006, 2008. They have been regulated. We know what is available in the market. There is a registration of every product in a central database in the European Union. There are specific rules on what can be used or not be used. The producers are registering all the ingredients of the liquids. The same happens with the devices, atomizers, and so on. So regulators know what the market contains, what is entering the market. In Brazil, they don't know nothing. And of course, you also understand that it's very difficult to do some research on patterns of use or on prevalence of use, because if someone is using a product which is illegal, he will not be willing to admit in a questionnaire or in a survey that they're using an illegal product, because they may even face some legal consequences. So the government has tied the hands of themselves and of scientists and researchers by introducing a prohibitory regulation. So my suggestion is accept that the demand exists, and instead of having an uncontrolled use, even among non-intended populations like never smokers that you mentioned, make a proper, it's not you who is making the regulation, but you should encourage the government to make an appropriate regulation that will both help smokers have an additional tool in order to quit smoking, and at the same time protect people from unintended use, non-smokers and youth, but by creating rules in terms of marketing, in terms of promotion, and of course, product quality standards, so that you will have a balanced approach that will exploit most of the positive prospects in terms of public health, while at the same time avoid the unintended adverse effects. Thank you.
Thank you, Konstantinos. The last word is from a Brazilian health leader, Professor Adriana.
Okay.
Brasileiro. Muito obrigada. É uma palavra de uma brasileira.
Há aumento visível, né? Nós, como brasileiros, sabemos desse uso, principalmente quem está na universidade, observa um aumento cada vez maior de estudantes e jovens usando esse tipo de produto, né? Então, significa que a proibição não está funcionando. Se a gente está tendo um aumento, a própria Anvisa considera como algo epidêmico, significa que a proibição não está funcionando. Então, de onde vem esses produtos, que também já foi comentado aqui, e é da preocupação da minha pesquisa, por isso que a gente está usando, nesse momento, que a gente consegue de doações. Então, a gente não sabe de onde exatamente vem esse produto, já que aqui é proibido, né? Então, acho que como, digamos assim, um conselho, né, para o Brasil, nós temos um potencial enorme de fazer pesquisa. A gente pode fazer pesquisa para responder a maioria das perguntas que a Anvisa ainda pode ter, frente ao que não foi respondido lá fora, né, com todos
Those that are different from what other countries have conducted. We have technical capability to do that. And having events like this one, they're so important. It's so important debating. I would love to congratulate you all because you deserve it. Not just for the academy, it's for everyone. We have to hear and listen to what everyone has to say to get to a conclusion of what is going to be best for the most.
Friends, we couldn't have ended the conference on a more conciliatory and friendly note. I'd like you first to please give a warm round of applause for all of our panelists. And then, if I may, if we can also just give a round of applause to our interpreters. Thank you for all your hard work. And for the R1 audiovisual team. And for all the Jessica, Ilna, Chase, everybody who made this possible, we'd like to thank you and just say that what we will do with all of the material that we gathered today is we will get a highlights section, send it to you, and just make sure that all the facts and the recommendations that we have broad agreement on, that's shared with you and that we can stay in communication. And that Brazil now has a new football team playing for you. We might not score goals like Pele, but we'll try. Thank you very much, Brazil and Sao Paulo, for being so hospitable. We love you. I think when Pele, the last thing he said before he died is he said 3 words are the most important words: love, love, love. That's what we feel for you. Thank you very much for coming.